Καλή σας ημέρα. Φίλες και φίλοι της Fair Life, καλώς ήρθατε στη δεύτερη μεγάλη ημερίδα της Fair Life. Καλώς ήρθατε εσείς που είστε κοντά μας, καλώς ήρθατε και εσείς που μας παρακολουθείτε από απόσταση. Σήμερα είναι μια πολύ σημαντική ημέρα και έχουμε τη χαρά, σε αντίθεση με πέρυσι, να έχουμε πολύ περισσότερους κοντά μας. Έχει αντιστραφεί δηλαδή η απόσταση με την φυσική παρουσία και το διαζώσεις. Παρ' όλα αυτά, και για τις δύο κατηγορίες θεατών και φίλων θα κυλήσει μια πάρα πολύ ενδιαφέρουσα ημέρα. Βλέπουμε όλοι το θέμα ο καρκίνος του πνεύμονα στην εποχή της καινοτομίας. Είμαστε εδώ ένα χρόνο μετά από την πρώτη ημερίδα της Fair Life, Νοέμβριος του 2021 ήταν. Στη δεύτερη συμμετέχουν για ακόμα μια φορά όλοι οι σημαντικοί αυτού του τομέα. Από την ιατρική κοινότητα, από την επιστημονική κοινότητα, από τον κλάδο της υγείας, αλλά και οι φίλοι και οι υποστηρικτές της Fair Life. Ένα χρόνο μετά από την πολύ μεγάλη συζήτηση που είχε αρχίσει για τον προσυμπτωματικό έλεγχο, είμαστε εδώ να δούμε τι έχει γίνει, πού βρισκόμαστε, πώς μπορούμε να συνεχίσουμε, να πάμε αυτή την κουβέντα ένα βήμα παραπάνω για αυτά τα πάρα πολύ σημαντικά ζητήματα που αφορούν στον καρκίνο του πνεύμονα. Σε αυτόν τον ένα χρόνο, φυσικά η Fair Life έκανε μια σειρά εκδηλώσεων, μια σειρά από δραστηριότητες, με μια πολύ μεγάλη βεντάλια για το κοινό, για τους φροντιστές, για τους γιατρούς. Ενδεικτικά μόνο, θα σας πω το πρόγραμμα ψυχοκοινωνικής υποστήριξης BREATH, το οποίο προσφέρεται δωρεάν σε όλη την Ελλάδα στους ασθενείς με καρκίνο του πνεύμονα, αλλά και στις οικογένειές τους και στους φροντιστές. Για την ψηφιακή βιβλιοθήκη «Μαθαίνω, ενεργώ, ελπίζω», αυτό που βλέπουμε και όλοι εδώ στη σκηνή, ένα πάρα πολύ σημαντικό σύνθημα της Fair Life. Ενημερωτικά webinars και με το ταξίδι και με το 14 λεπτά ζωής, αλλά και θεματικές webinars με τίτλο «Το ταξίδι του ασθενή». Μια πολύ μεγάλη προσπάθεια που ήρθε να καλύψει, εγώ θα πω να υπερκαλύψει σχεδόν, μέσα σε πολύ λίγο χρονικό διάστημα, ένα πάρα πολύ μεγάλο κενό που υπήρχε. Παρ' όλα αυτά, ο καρκίνος του πνεύμονα παραμένει δυστυχώς η συχνότερη και η πιο θανατηφόρα νεοπλασία σήμερα. Από την άλλη πλευρά, υπάρχουν συνεχώς θετικές εξελίξεις. Υπάρχει ένα πολύ μεγάλο όπλο που λέγεται καινοτομία και ακριβώς το πώς μπορούμε να το χρησιμοποιήσουμε, πώς μπορούμε να το μάθουμε, θα συζητήσουμε σήμερα όλη την ημέρα. Ο καρκίνος του πνεύμονα στην εποχή της καινοτομίας. Όλο αυτό το οποίο θα συζητήσουμε, όλα αυτά που θα συζητήσουμε, ο σκοπός, η διαδρομή και ο στόχος βρίσκεται ακριβώς στον τίτλο της σημερινής ημερίδας. Όμως, εδώ κάπου θα σταματήσει η δική μου εισαγωγή για να καλέσω στο βήμα την κυρία Κορίνα Πατέλη-Μπέλ, ιδρύτρια, πρόεδρο της Fair Life, εκλεγμένο μέλος του ΔΣ του Ευρωπαϊκού Φορέα για τον Καρκίνο του Πνεύμονα Λούτσε, αλλά και στην πραγματικότητα την ψυχή της Fair Life.
Καλή σας μέρα. Έλενα, σε ευχαριστώ πολύ για τα καλά σου λόγια και σε ευχαριστώ που είσαι στην ομάδα της Fair Life και μας στηρίζεις εδώ και 2 χρόνια. Καλημέρα σε όλους. Ευχαριστούμε πολύ που είστε κοντά μας. Αξιότιμη κύριε Υπουργέ, αξιότιμη κυρία Υπουργέ, αξιότιμη κύριε Πρίτανη, αξιότιμη κύριε Καθηγητά, αξιότιμοι προσκεκλημένοι και όσοι μας παρακολουθείτε διαδικτυακά, φίλες και φίλοι της Fair Life, σας ευχαριστούμε όλους που για μία ακόμη χρονιά ενώνατε τη φωνή σας μαζί μας, συμμετέχοντας στη δεύτερη ημερίδα της Fair Life με τίτλο «Ο καρκίνος του πνεύμονα στην εποχή της καινοτομίας». Στόχος μας είναι όλοι μαζί, ο καθένας φυσικά από το δικό του τομέα ευθύνης, να γίνουμε η ανάσα για όλους όσους αγγίζει καθημερινά ο καρκίνος του πνεύμονα στη χώρα μας. Η σημερινή διοργάνωση εστιάζει στον προσυμπτωματικό έλεγχο για την πρώιμη διάγνωση της νόσου, το μοριακό έλεγχο, τις κλινικές μελέτες και τη ραγδαία ανάπτυξη νέων καινοτόμων θεραπείων που χαρίζουν καθημερινά ζωή σε χιλιάδες ασθενείς. Μέσα από τις τοποθετήσεις
that will give life to thousands of patients on a daily basis. Through the presentations of our 52 prominent speakers, we aspire to provide answers to critical questions. For example, how many of these diagnostic options and therapies are available to Greek patients? How can one get easy and fast information on clinical trials taking place in Greece? What are the inclusion criteria that must be met? How easy is it for a patient in an early stage to identify their disease early and treat it without delay in an effective way, making use of surgical procedures as well as targeted procedures? How is it to treat metastatic disease in the hope that it will become a chronic disease? Last year, we presented for the very first time in Greece a study on screening in cooperation with the Health Policy Institute. On the basis of the findings and analysis of this study, it was established that introducing screening for lung cancer will lead to a significant drop of deaths. The early intervention, making use of the best therapies available, and more lives being saved. So, this is our goal. But are we ready to introduce screening within the national health system? So, we will be discussing these topics today together with Greek state representatives, prominent figures of the academia and scientific societies, pharma executives, as well as patients' representatives. Dear friends, a recent study carried out within the EU has ranked Greece among the top countries in terms of lung cancer related deaths. This country involved 13 EU member states, including Poland, the Netherlands, Belgium, and the UK. According to the study, although Greece is among the countries that have revised their national cancer plan, it remains, obstacles still remain in the efforts of researchers. One of them is the lack of data, and the situation is even more complex since there are efforts to find adequate resources while the requirements for an effective preventive framework have not been yet established. Also, there is still more to do with respect to palliative care, the universal application of the anti-smoking law, and the implementation of adequate primary health care. But I think that this cannot wait, and we will all agree on that. So, before I welcome our prominent speakers and guests, I would like to warmly thank the Board of Fairlife, our interdisciplinary team that has been supporting us for 2 years. I would like to thank our volunteers and hundreds of friends, our ambassadors, the mass media representatives, the pharma industry, and all of our supporters. If it weren't for their support, we wouldn't be able to continue carrying out our work. In closing, I would also like to thank all those who contributed to today's event and wish that the next conference of Fairlife will find us in a place where we will be counting the steps we have already taken in tackling lung cancer. So, I would like now to present to you a brief video showcasing the actions of Fairlife. I would also like to mention Simon, my husband, as well as all those who have perished due to this disease. And I would also like to thank all of those who have pledged that they will continue to make efforts and support all lung cancer patients. On our behalf, we will continue to raise awareness and we will continue to aim aim at prevention and early diagnosis. We will continue to spread our vision. We will continue to overcome barriers. And we will still claim a fair life with equal opportunities for patients across Greece. I am certain that after today's event, we will have all understood that innovation has given rise to unprecedented benefits for our patients, and more innovation will follow. So, treatment and cure is possible. Before showing this video, I would like to say our motto: let life take your breath away, not lung cancer. Thank you.
Κερδοσκοπικός κοινωνικός φορέας στην Ελλάδα που ασχολείται αποκλειστικά με τον καρκίνο του πνεύμονα. Ο Σάιμον Μπέλ έχασε τη μάχη με την νόσο και η επιθυμία του για μια δίκαιη ζωή των ασθενών έγινε πράξη από τη σύζυγό του Κορίνα Πατέλη Μπέλ με την ίδρυση της Fairlife τον Νοέμβριο του 2020.
Ο καρκίνος του πνεύμονα μας αφορά όλους.
Στόχος, η ανάληψη δράσεων που θα έδιναν πνοή στο όραμά του, διαδίδοντας το μήνυμα «Η ζωή να κόβει την ανάσα, όχι ο καρκίνος του πνεύμονα». Η Fairlife απαρτίζεται από μια ομάδα που εργάζεται δυναμικά, αναδεικνύοντας τη σημασία του προληπτικού ελέγχου, της έγκαιρης διάγνωσης και της ισότιμης πρόσβασης των ασθενών σε νέες θεραπείες, καθώς και κλινικές μελέτες. Τη Fairlife αγκάλιασαν από την πρώτη στιγμή η ιατρική κοινότητα, επιστημονικοί φορείς, φαρμακευτικές εταιρείες, καθώς και τοπικοί φορείς. Είναι μέλος ελληνικών και διεθνών φορέων για την προαγωγή δικαιωμάτων των ασθενών. Τις δράσεις της υποστηρίζουν πάνω από 70 επαγγελματίες υγείας από την Ελλάδα και το εξωτερικό. Το έργο της αναγνωρίζεται και βραβεύεται. Η Fairlife μεγαλώνει. Αποκτά εκατοντάδες συνοδοιπόρους και πρεσβευτές.
Ας γίνουμε η γενιά που θα φέρει την ουσιαστική αλλαγή.
Η επιλογή είναι δική σου.
Με πολλαπλές δράσεις ενημερώνουμε, προλαμβάνουμε, στηρίζουμε. Συμμετοχή σε ημερίδες και συνέδρια.
Fairlife was born to fill a gap.
Θεματικά webinars και οργάνωση ημερίδων. Ψηφιακή ενημερωτική βιβλιοθήκη «Μαθαίνω, ενεργώ, ελπίζω». Ενημερωτικές εκπομπές 14 λεπτά ζωής. Δράσεις ευαισθητοποίησης νέων. Η Fairlife συναντά τα παιδιά στα σχολεία μέσα από ενημερωτικές δράσεις, καμπάνιες και μαθητικούς διαγωνισμούς. Δράσεις ευεξίας.
Καθαροί πνεύμονες, ελεύθερη ζωή.
Ο Χρήστος και η Fairlife τερματίζουμε τα 5 χιλιόμετρα. Μπράβο, μπράβο.
Πενταψήφια γραμμή ενημέρωσης 11157 και το δωρεάν πρόγραμμα ψυχοκοινωνικής υποστήριξης Breath σε συνεργασία με έμπειρους και εξειδικευμένους επαγγελματίες υγείας από αναγνωρισμένους φορείς.
Η ζωή να κόβει την ανάσα.
Οι ασθενείς που νοσούν με καρκίνο βιώνουν ένα μοναχικό ταξίδι, όπως και οι φροντιστές τους. Χρειάζονται ενδυνάμωση, ψυχολογική υποστήριξη, κατανόηση και σεβασμό.
Η Fairlife διεκδικεί ίσες ευκαιρίες για όσους βιώνουν τον καρκίνο του πνεύμονα χωρίς στιγματισμούς.
Η Fairlife βρίσκεται δίπλα τους, ενημερώνοντας το κοινό, στηρίζοντας όλους όσοι έχει αγγίξει ο καρκίνος του πνεύμονα. Τους το οφείλουμε. Και αυτή είναι η υπόσχεση της Fairlife για μια δίκαιη ζωή.
Εύχομαι κανένα παιδί του κόσμου να μην χάσει το γονιό του από το καρκίνο του πνεύμονα. Η πρόληψη σώζει ζωές.
Fairlife. Η ζωή να κόβει την ανάσα, όχι ο καρκίνος του πνεύμονα.
So all this and a lot more in just 2 years. I don't think it's right, Karina and dear friends, to say what will happen in the next 2 years, because we all sincerely hope that in the next 2 years we won't have this emergency situation. We hope that the needs will be different. Mr. Plevris, the Minister of Health, is not in Athens, but he will be with us in some way. He wanted to address us, so he has sent us his message. Let us listen to him. Honorable President, participants, representatives of various associations, it was a great joy for me to accept this invitation to participate in your event with focus on clinical studies and screening. This discussion is taking place at a difficult point in time because after the pandemic, but even before the pandemic, there was a discussion scientifically that there should be more screening, particularly for cancer, because the new epidemic we may experience is the flare of various forms of cancer. So through the RRF, right now we're running 3 programs for cancer prevention, the FOFI Yenimata, which is for breast cancer screening. We also have cervical cancer screening and the large intestine screening. We're already holding discussions with the scientific community because we want more programs, among which the lung cancer screening, because we know that unfortunately lung cancer is widespread and it is a disease which often leads to death. And of course, we have many, if you like, forms of treatment. So if there is more screening, and here we're talking about coverage of all forms of cancer, together with a strengthening of primary health care, and this is why we have the GP, the general practitioner for every patient, their personal doctor who can follow these citizens not as a patient but as people who need to be monitored and to carry out tests. So together with digitization, and I'm talking about the medical records of patients, so we are creating a framework of safety so that citizens can monitor their health closely. It's what the WHO says. We have to go from treatment to prevention. So if we manage to prevent diseases, it will be much easier to deal with a situation. Let me just give you an example. In the 3 months that we have been implementing the FOFI Yenimata program for the fight against breast cancer, over 3,000 women have been found to have early-stage breast cancer, which means that they will be able to deal with their disease in a more effective manner. A very important chapter in lung cancer are the new forms of treatment, the new therapies. And despite the fact that in Greece we have the clawback mechanism, which is a deterrent, but we work together with the negotiation committee. So we are trying very hard to make sure that all innovative treatments will be made available in Greece. And of course, this will be based on negotiation. And we have to find the best possible prices. And all this is in the arsenal of weapons we have. And we also want to focus as well on clinical trials. This is why we have the institution of the investment clawback, which means that companies investing in clinical trials will get back part of the clawback. So we invite companies that can run clinical trials in cancer and particularly in lung cancer to run such clinical trials in Greece. It's not just the money that can be generated. What is more important is for patients to have the best available treatment in Greece. And I think that participation in a clinical trial gives you the possibility as a patient to have access to innovative treatment, state-of-the-art treatment. This is what we want to do. We're working on screening, new therapies, clinical trials, and we place great emphasis on cancer. And this is why through the RRF, it's not just the medical record of the patient, but we also have a registry for cancer underway in order for us to monitor what's happening, the latest developments, and inform the citizens on possible clinical trials they can participate in. So we're creating a framework in order to lay the foundations in the coming years to effectively treat various forms of cancer, including lung cancer. I will await with great interest the results of your event today. Unfortunately, I was not able to be physically present. I have to accompany the Prime Minister, who is now in Patras, but I want you to know that we will wait with bated breath to get all the conclusions, and we will work together in order to achieve the best possible result. Thank you very much. Now we will hear from Mrs. Mina Gaga, Deputy Minister of Health. Let's listen to her message. Good morning. I'm very sorry not to be with you today. I wanted to be with you, but also the subject that you will be discussing today is very close to my specialty, but also very close to my heart. I'm very interested in screening in lung cancer and in clinical trials as well, because I think that in this way we will be not just close to the patients, we will be able to prevent the disease, we will be close to the citizens and offer a good quality of life, avoiding stress and suffering and pain. Thank you very much. So I wish you the very best of success today and in the effort that you have undertaken, and we are by your side in order for us to walk along this path together. Thank you very much, Mrs. Gaga. Now let us invite again via a video connection Mr. Athanasios Meletios Dimopoulos, Rector of the National and Kapodistrian University of Athens, Hematology Oncology Professor, and he is from the National Kapodistrian University of Athens. You have the floor, sir. Good morning. We can't hear the speaker. He's muted. Could you please switch on your microphone? Good morning. Thank you very much for the kind invitation. It is with great joy for me to participate this year as well in this very important event. And this event focuses on the importance of screening, new therapeutic approaches, and clinical studies in Greece. So we know that the incidence of cancer has grown. Last year, it is estimated that over 2.5 million inhabitants of the EU were diagnosed with some form of cancer. At the same time, we have an increase of the survival of cancer patients. Why? Because we have earlier diagnosis, but also because we've had the development of new treatments, new therapies. So among the goals that have been set for the next years, which are feasible, are one, to cover 90% of the population with screening programs. We want to make sure that the instruction is maintained in the EU, the renewal of guidelines regarding screening for forms of cancer that occur most often. As you know, lung cancer is the third most common diagnosis after breast cancer and prostate cancer, and it is the leading cause of death. The epidemiological, if you like, recording shows the poor outcome of many cancer patients. This is why in the last few years we have developed smoking cessation programs, and I think that this is the main risk factor that can be modified. What is also available are programs, screening programs, but also new therapeutic modalities, new options, which have radically changed the prognosis of lung cancer patients. So here we're talking about targeted therapies for the minority of patients that have specific mutations, but also immunotherapy, which is now used in the case of most lung cancer patients. In Greece, we estimate every year over 5,000 cases of lung cancer to be diagnosed. So the need for screening and early intervention is key, not just for the patients, but also for the national healthcare system. And this is why early diagnosis is important, but also the development of screening methods. Why? Because unfortunately, lung cancer in the early stages does not have obvious signs and symptoms. So we're talking about low dose CT. We're also talking about dropping the mortality. It was 26% and 39% in women when they undertook low dose CT. So this is an effective method, and I believe that this will be further detailed and mentioned today during your event, the Fairlife event. In our university, we are very proud because when it comes to oncology, particularly in the case of lung cancer, we have a lot of work being performed by distinguished scientists that are internationally renowned and have contributed greatly to research. And we have international collaborations. I'm talking about Professor Kostas Sirigos, for example. Furthermore, the Medical School of Athens is present. Many of its members are here, and I think we've made steady steps forward towards the future, and we always try to be in the vanguard of research, of clinical practice, and of connection to society. By way of conclusion, let me congratulate Fairlife, Simon Bell's family, Karina Patelli Bell, Melina and Eric Bell. They have worked very hard, and this is to the benefit of public health. And all together, we can cry out loud that let life take your breath away, not lung cancer. Thank you very much. Thank you very much, Mr. Dimopoulos. So we now have a video from Professor Popat.
Everyone, my name is Sanjay Popat. I'm a consultant medical oncologist at the Royal Marsden Hospital and Professor of Thoracic Oncology at the Institute of Cancer Research, both in London, in the UK. All of us know that if you have lungs, you can get lung cancer. And I believe that all our patients deserve access to the best expertise and care that we can possibly give, and that this can be obtained by us as professionals through three areas: education, facilitating and implementing research, and representation to policymakers. Lung cancer continues to be a major public health problem globally. Access to healthcare remains problematic, and diagnoses occur way too late in the disease trajectory, often as an emergency in hospital. Despite huge advances in treatments which are undoubtedly leading to more cures, our patients continue to die rapidly and without access to expertise and the best treatments and palliative care. Uniquely in the field of cancer, our understanding on preventative strategies for lung cancer is huge. We know the causative carcinogen in most cases, tobacco and air pollution. And yet our controls for managing tobacco and its addiction are mostly markedly lacking. Moreover, with the lung cancer diagnosis comes shame, stigma, and guilt, alongside indifference from the public and, sadly, some healthcare professionals, facets that are entirely unnecessary. Lung cancer is, therefore, a disease fundamentally arising from a failure of public policy. So what can we do to solve this wasteful, shameful loss of life? First, we have to map, document, and understand the issues each country faces. We should understand lung cancer national epidemiological data, mapping diagnosis, stage, type, treatments, and outcomes to each hospital. Clear and accessible data drives better performance and allows mapping of solutions and, importantly, budgets. We must have a clear diagnostic standards with timeframes and map performance and outcomes of diagnostic and treatment teams to these. We must have a strong and funded tobacco control policy to ensure that every smoker gets the opportunity to quit and that we prevent new smokers from starting. Hand in hand, we must have governmental policy in place to reduce the amount of polluted air we all breathe. We have to engage with primary care to ensure that lung cancer risk factors are identified and documented and ameliorated, and that lung cancer remains an early differential in at-risk patients. Lung cancer has to be considered at first symptoms, not after the third course of antibiotics. and that rapid pathways exist for interfacing with secondary care to allow diagnoses to occur quicker and without delay. These pathways should be mapped, defined, and core funded to minimize delays to diagnosis. And when a diagnosis of lung cancer is confirmed, we must have a national and funded strategy for genetic testing. The future of all cancer treatments is in genetic mapping, and getting this right at diagnosis improves outcomes and saves cost by avoiding futile treatments. Patients should ideally have a key worker or specialist nurse or another professional to support patients in their cancer journey and ensure that all the pieces of the complex secondary healthcare speak to each other in a timely and efficient manner. All patients should have access to a clinical trial for their condition. It's only through research that we will be able to learn from each other and improve treatments, and simultaneously improve education for doctors and improve investment in the life science industry. And when treatment starts, it must be evidence-based, based on clinical guidelines, with shared decision-making between clinicians and patients and their families. None of this can happen unless there's a robust and efficient mechanism in place to value the cost of new drugs that can function at pace, given the number of new drug approvals are projected to be submitted over the next 24 months. And of course, treatments and cases should have undergone multidisciplinary team review. As lung cancer treatments are becoming more complex, we need to sense check our approach to every patient and ensure nihilism and bravado are both kept in check. But prior to this, we must have a national CT screening program. Lung cancer is a silent killer. If you have symptoms of lung cancer, it's usually too late. CT screening is by far the best way to improve the cure rate and prevent unnecessary pain and suffering to families. Moreover, CT screening is a cost-effective way to spend healthcare funds. Here, in the UK, our government has agreed to implementing CT screening for lung cancer and has deemed it cost-effective. CT screening is active in the region where I work, and having witnessed its impact, we can already see a large drop in stage 4 cancers identified, allowing us to cure patients before they are lethal. So, what are the solutions? The answer is actually with each and every one of us. Today, I call on all of you present to resolve these barriers in any little way you can. As leaders in your field, your power and influence is strong. Go forward and make a difference. Do your part and advocate for lung cancer. You can make a difference. All our past, current, and future patients deserve it. Thank you for your time.
I think that every single phrase of those we've just heard could actually stand as a motto for awareness-raising purposes. And you know, Mr. Sirigos was actually introduced by Mr. Dimopoulos a few minutes ago. So Mr. Sirigos is a professor and also an NHS director with the Athens University's School of Medicine. Good morning. I'm very happy to address this very important conference. I'm here to talk about precision medicine. Unfortunately, the sound is very poor. Professor, could you please fix your sound? Probably there's something wrong with your mic, and perhaps speak a little slower, says Ms. Patelli. Okay, so I was just saying that the new era in medicine is the era of precision medicine. And also, it is a patient-centered medicine during which the patient will also have a say in their treatment, in research, and in the use of any innovative medicine or technology. So, conferences such as the one you're holding today is very important because they serve as a reminder of where we are and what we want to do. patients are next to us. They're not opposite us. Thank you very much for your intervention. Now we will watch a video shared by Ms. Karen Kelly, who is a professor emeritus with the University of California.
SLC and a longtime thoracic medical oncologist. Let me begin by thanking Fairlife and the conference chairs for putting together an outstanding meeting. I'm so sorry I can't be there in person to learn from all of you. I will say that I admire the title of the meeting, Lung Cancer in the Age of Innovation, because it embodies all the building blocks to prevent and cure lung cancer that perfectly align with the mission and the vision of the IASLC and symbolizes the global and multidisciplinary collaboration that the IASLC brings to foster innovation. Innovation in basic laboratory methodology, drug development, diagnostics, surgical and radiation techniques have led to unprecedented benefits for our patients. And more amazing innovations are coming. Cure, regardless of the stage of disease, is possible. Significant inroads into identifying high-risk subjects and mitigating risk regardless of smoking status is also an exciting area that is underway. I do believe that we will conquer thoracic cancers in this century, perhaps even in the next few decades. But we need to match the scientific innovation with educational innovation. It is only through educating physicians, patients, policymakers, and the public to learn about the amazing advances and then applying this knowledge that we can make monumental impact. This conference that brings together researchers, patients, and policymakers who are united and committed to eradicating lung cancer is a model forum for others to replicate. We must also be innovative in training the next generation of thoracic researchers and clinicians. How do we inspire a young generation in this virtual world to follow in our footsteps? I chose to become a clinical researcher in thoracic oncology at a time when there was no effective systemic therapies, believing that one day in the distant future, I could make a small difference. Personally, I think now is really the greatest time to choose a career in lung cancer research, given all of the exciting science that we are seeing translate before our very eyes into real-world benefit. I'm sure the next 2 days will prompt many new and exciting ideas for your young investigators. And so with that, thank you again for all that you are doing and enjoy the conference.
Ευχαριστούμε πάρα πολύ την κυρία Karen Kelly.
Thank you very much, Ms. Karen Kelly. While we wait for our next speaker to join, I will give you a short introduction about what will follow. So I will remind you of what happened last year. So last year marked the kickoff meeting for a discussion around the first study conducted by Fairlife, headed by Professor Souliotis from the University of the Peloponnese, as well as Ms. Hadjiandreou, who is a PhD holder in public health, and Ms. Linardou, who is a medical oncologist in Metropolitan Hospital. So this gave us the first findings that served as a basis for us to launch the relevant discussion. And now this discussion would be evidence-based. So is our next speaker with us? Or perhaps we could take a look at some snapshots from last year's event.
νομίζω μπορούμε να καλημερίσουμε την κυρία Σμίτκε.
So I think that now Ms. Smitsky is with us.
My name is Evelina Schmidtke, and I'm the Vice President of Lung Cancer Europe. Thank you for inviting me to this important event to represent Luce here. Luce is an umbrella EU-level non-profit patient organization in lung cancer. Our members are other lung cancer organizations in the national level in EU. Currently, Luce has 37 members representing 24 countries, including very active and professional Life in Greece run by Corina Pateli-Bell. Together, we work for a better situation for lung cancer community in the EU. Apart from helping to build the needed skills among national patient advocates, acting for a better advocacy, including sharing our position on lung cancer screening EU recommendations that are currently under development, we also run awareness campaigns. A good example is the Get Checked campaign that started last year and concerned lung cancer symptoms recognition that this year developed into Get Diagnosed campaign, focused on receiving timely and good quality diagnosis. This campaign was co-created with Corina and was very successfully advertised in Greece and other European countries. Luce finds such an event as this one very important. It provides access to most up-to-date treatment recommendations and innovative care solutions, as well as it stresses the importance of early detection with lung cancer screening programs that we feel are crucial to be implemented for better outcomes in lung cancer treatment. I believe that with that many important stakeholders in the room, this may lead to valuable improvement in Greek lung cancer community. I wish you a fruitful event and sincerely congratulate on all of the hard work for the lung cancer patient in Greece that has already been done. Thank you.
Thank you very much. Good morning. Και Λούτσε σημαίνει φως. Και εμείς είχαμε την ευκαιρία πέρυσι, όπως...
So last year, we had the opportunity to shed some light through our research involving 3 different entities on some significant evidence relating to lung cancer. But it's been a year since that time, so we want to see, was last year's optimism something that was proven true? Was that research followed by other important surveys? So, Mr. Siliotis, Ms. Linardou, Ms. Hadjiandreou are here with us. They are physically present, and this brings us joy. And also with us is Professor Loukidis, a professor of pulmonology with the Athens University, and Ms. Irini Agapidaki, the General Secretary for Public Health. So welcome. Good morning. I cannot help but asking the first question. How critical was, after all, the evidence found last year? How useful did they prove to be? Because, truth be told, this was a research that was actually given a lot of publicity, so sometimes we, journalists, do something right. Please go ahead. Please take the floor, and I'll be the first one to answer your question. So thank you very much. Thank you, Elena. I would like to thank all colleagues. I would also like to welcome all guests, those who are physically present and those who are with us remotely. So how important and useful was that research? It was important because Fairlife and all scientists believe in evidence-based medicine and in evidence-based public health. And that was the first step taken by Fairlife through this study. So if I may say so, I need some help, please, as a speaker. Thank you. So the minister was very eloquent in describing the program launched. He mentioned the government gazette, so the program has been launched. I would like to insist on a couple of points. Firstly, there are generally accepted rules and criteria. In fact, there are 10 such criteria that mandate rather screening. I'm sure my colleagues will mention them as well. So you can see these criteria on screen, but criterion number 10 states that this must not be a one-off thing, but it must be an ongoing practice. So screening is not a one-off thing. No, it is a process that starts from how the state will identify the eligible population through a series of procedures. Then, for example, using text messages, these members of the identified population will be asked to come for screening. And then patients will come in and the screening will proceed. So take a look at the screen. These are some of the latest evidence on gender. Take a look at the diseases that are in the lead. It's cancer. Also, this is the mortality rate in Greece and the reasons for death. These are data from the Hellenic Statistical Service. These are data on lung cancer. So 14% of cancers diagnosed each year are lung cancers. This is followed by breast cancer, prostate cancer, colon cancer. Just keep in mind that screening involves colon, breast, So take a look at the colors. It's incidence and prevalence. So we're talking about the annual figures and also its mortality, all-cause mortality. So there may be a large incidence, a high incidence involving breast cancer, but lung cancer is next. And things are different when we talk about mortality. Is it a serious disease? Yes, we all know that. But, you know, the WHO, take a look at the left side of the screen. The mortality in lung cancer, it's in the lead clearly. And take a look at the projections for 2040. Breast cancer will also rise. And lung cancer even more. So we will start seeing more and more cases also due to the pandemic. By the way, these are Greek figures. And, well, this also has to do with high smoking rates in our country. So through this fast process, I will now ask a question. Is it perhaps something that we're missing? And clearly, the answer is yes. We still do not have screening on the part of the state. We have set the foundations. We've listened to what the health minister said. He was very optimistic, and we are eager to listen to Ms. Agapidaki, who is ex officio the expert on public health. She will talk to us about the imminent plans for this type of cancer. Hopefully things will happen very soon. Thank you.
Mrs. Agapidaki, we will ask you, but later. Mr. Suliotti, no introductions are needed. We know who you are and what you've offered, and we know your contribution. Thank you very much. Good morning. And I'd like to make mention to Karina and what she's achieved. It's truly impressive. Of course, what she has done is very moving. We know her passion, but she has mobilized so many people. She has created an alliance of the willing with the contribution of the journalists, I must say that. And this means that the scientific community has been informed, the wider public, and so on and so forth. And Greeks tend to complain. And sometimes we are right and we should ask for more. But here we have a success story. We have Fairlife, which has come to cover a need, an unmet need. So 1 year later, what's happened 1 year later? I've been asked to speak from the stage, and sometimes I tend to say not a day has gone by. It seems as if a day hasn't gone by, but this is not the case. I think that a lot has happened and a lot more will happen. First of all, we see the pandemic is leaving us. We have tools, we have therapies, we have vaccines. We know what the risk is. Last year, we were on our own, 3 of us and the journalist, and we were presenting our study in last year's event. Now we have a lot of people who are physically present and we can talk face to face. So why did I talk about the pandemic? Because the pandemic, COVID, put a pressure on the healthcare systems. So we know that there was a demand for screening, but we had the pandemic. We see that there was pressure on public finances. There were bad habits on the part of the citizens as well. This is an explosive mix. And this is from the European Patient Forum. And there was access to healthcare. So screening went down. People didn't go to hospital to get screened. Why? Because they were scared to get into contact with other people. And of course, we will pay the bill many years later. And I'm talking about the health of the general population. Here we see that there are new studies that say that we will have a lot of cancer diagnoses in the future, and we should get ready. And if, for example, the pandemic was something unprecedented, this is going to be something we should expect, meaning there will be pressure regarding new cancers. Why? Because we saw that screening went down for the reasons explained previously. So we need to cover this gap and start running. This reminds me of a marathon, this whole thing with the pandemic. And we know that you must keep running, because if you're overcome by pressure, you're lost forever. And Mrs. Hatziandreou also talked about the causes. The main cause for lung cancer is smoking. And fortunately, we have a law which says that there should be no smoking in many areas. It's very good for us to observe the rules. And it's very bad if people started becoming more relaxed. Now, let's talk about the cost. This is something we should never forget. Lung cancer is expensive. In the last few years, a lot of fiscal adjustments have been made to the healthcare system, and we can't consider our health system in Greece as being wasteful. So we can generally say that we are underfinanced even in certain cases. So we need to bridge the gap between our country and other developed countries. However, lung cancer and cancer is very costly, and at the end of our life in particular, Mr. Sirigos and myself had carried out a study. So end of life tends to be very expensive. And here you see that we try to do the best we can. We try to muddle through, but this is not good for the state or for the cancer patient either. So here we need to have prevention. And this was last year's work. I'd like to thank everybody, particularly the clinicians, because we live in the age of interdisciplinarity. People cannot go it alone. and the clinicians cannot do the job of the administrators. We need specialists. We're talking about mental health policies and so on and so forth, because these people have a big burden to bear. So what is needed is an interdisciplinary approach. This is the only way forward. So what did we do? We did what was self-evidence. We ran a predictive model, a hypothetical scenario where we'll screen 100% of high-risk population. This is the tree that we had. It was validated by international bibliography and the clinical experts we had for every stage, and what percentage one can move on, and so on and so forth. Those diagnosed will receive treatment. Why? Because we have such a system in place. So we may complain, but people who are diagnosed are not rejected. They have access to treatment. So we get a high score on this. And of course, we have the existing scenario. We did a cross-check with the existing use of CT imaging. So we used personal algorithms in order to test our assumptions to make sure that they were logical. And this was our result, meaning what happens in every stage, how many will remain at an initial stage thanks to early diagnosis, and with the assumption that all will receive care. So we calculated that through the implementation of such a screening program, we have a drop in deaths by 24% and a reduction by 30.9% of quality years, QALY. So this is similar to what you see abroad. For example, the Nelson study gives you 24%, we 24.61. So we're very close to international studies. So this means that a screening program will pay off. Now, what has changed a year later? And this will be the end of my presentation. First of all, let me say that we actually published this article recently. Now we have a call to action. So on the basis of the study, we have a policy recommendation paper. So we will be proposing a program, a screening program, following a specific procedure in a specific way. And we hope that we will mobilize some mechanisms in order for measures to be taken. We also ran, for example, a study on surgery. So we need to have people reading these results. It's not enough just to publish some information. We must know who will use it and do something with it. So this is a study. It will be published by next week. And we will also move on with implementation and actually completing this with management techniques, because they save lives. So we are more aware. We have the Doxiadis program, Spiros Doxiadis. This is a flagship initiative on digital mammograms. This has borne fruit, so it's very impressive. So we've moved ahead. We're not where we were last year. And I'd like to say that last year was not a normal year. It was very different from what we were used to. And I'd like to say that hats off to the Spiros Doxiadis. We have Fofi Yanimata. We have a culture regarding prevention. So the question is, are we ready? How ready do we want to be would be the better question to ask. So if we want to be ready, of course, we must take measures, but we must be aware of the finances. I'm not saying that everything should be free. I think that the main commitment by the national health system is we cover everybody, but not for everything. So the responsibility of people managing the rare financial resources is for them to make the best possible use of these resources. We have solutions, we have evidence-based solutions, so we must find ways to implement them. So dear Irini, let me say that all of us here are by your side. We will stand by you, the scientific community, health professionals, all the associations, all the stakeholders salute you. We would like to see this progress even further. Thank you very much.
So while listening to Mr. Siliotis, dear Kyriakos, I remember that very first period, March 2021, after the outbreak of COVID-19. It was a dark period. We were all in front of the TV looking at the experts, listening to what the infection preventionists had to say. But you know, we are also experiencing another pandemic, the cancer pandemic. So we're very scared. We're scared that things might get worse due to the other pandemic. Hopefully, our fears will not be proven true. The other thing that I was thinking of while listening to you is something that we've talked about a lot and on many occasions. Miss Leonardo, can we actually rely on the Fofi Genimata program? Will it serve as the starting point for us to reach out to more people? Good morning. Thank you. Thank you, Elena. Thank you all. Above all, I would like to thank Corina. She is the soul of Fairlife. For 2 years now, through her hard work, her huge efforts, and her vision, she has actually successfully addressed the gap that existed in Greek society. And it was a long-standing gap. Unfortunately, it was something that affected cancer patients and their families and their loved ones. So a year ago, Mr. Siliotis, Ms. Hadjiandreou, you remember that dark room we were in? We were wondering whether we need lung cancer screening. I think that this is a question that has been answered across the globe in many different ways. I think that undoubtedly so. We do need lung cancer screening. We've heard things already. It's the leading cause of death among all cancers. 25% of cancer deaths are due to lung cancer. Most of our patients, actually more than 70% of our patients, are diagnosed with advanced disease. This fact alone provides us with the primary reason for which screening and early diagnosis is of essence. There are also some few patients who are actually identified at an earlier stage of the disease. Then they may actually get cured. And this is a huge thing when it comes to lung cancer. So, lung cancer screening is an imperative. It is something needed in Greece today because more than 7,500 people lose their lives. This is not just statistics or numbers. These are real human beings, members of our families. So it's been a year, and the question should not be, is lung cancer screening necessary? No, the question is how we will apply today across the country. In a country that has these dreadful statistics, although things have improved, and although probably we're not the leading country in Europe, as was the case until recently in tobacco consumption. Okay, so we're now second in Bulgaria. So our statistics, unfortunately, are very poor. And we're in a country that there were many new smokers, young smokers. So we have many people who, even though they may have quit smoking for 5 years or 10 years, they are the high-risk population. They are the potential patients. They're the people who used to smoke 20 years ago. They're the people who exposed their children to smoking and tobacco. So this is not a safe setting. So what will we do? How will we apply screening programs? We will take a look at some examples from all over the world so as to see what has happened in the year following the launch of the relevant discussion together with Fairlife. We've had different events involving the academia and the pharma industry, so the discussion has been launched. But what are the examples from across the globe? There are currently many lung cancer screening programs, for example, in the US or in Croatia. Croatia was the first European country that actually applied a national lung cancer screening program. Poland followed this example slightly before the pandemic. And they started this program that was actually funded by the EU in its entirety. There are also many pilot programs that are ongoing in the UK, in Italy, and in many other countries. Also, we had taken a look at different examples last year as well, but we started talking about the UK because they went to industrial areas such as Manchester, Liverpool, because it was expected that therein there would be a high prevalence of smokers and lung cancer patients. And they didn't tell people, come, we want to screen you. No, they told people, come because we want to check your health. So their approach was different, and this allowed them to reach out to people. And particularly the Manchester and Liverpool pilot programs were the basis for more national programs. And these programs were supported by the UK's NHS. So they were talking about the MOT for your lungs. What is MOT? It's actually the service used to maintain our cars and vehicles. So this approach actually brought patients to doctors for their checkup, for their screening. We are not to expect factory workers, people who have been exposed to occupational risks and hazards to come to us. No, we will set up the CTs on site. They've had mobile CTs installed in parking lots, outside supermarkets, outside soccer stadiums. So we are the ones who will bring screening to the patient, to the vulnerable population. And clearly, this is attached to a reference center. So, what is going on in Europe in general? Recently, and in the last year in particular, we have had policy statements, position statements about screening. We've had many different groups that were working on how to implement screening and what will the relevant rules and procedures be. Because, like we said, screening is a process. It's not about prescribing the low dose CT that will be reimbursed by the National Security Organization. No, screening is what is shown on screen. It is a process. Can it be done? Yes, and I'm saying that loud and clear. But we must be willing to do that. What does the process involve? It involves risk assessment. It involves the low dose CT. It's available in many places across Greece, and there is know-how also. It involves the liaison to a smoking cessation clinic. It also includes a multidisciplinary board. This must be in place. It cannot be that the diagnosing radiologist will give a diagnosis to the patient who will then leave. No, there must be a team of scientists, including the pulmonologist, the oncologist, and the diagnosing radiologist, plus other specializations as necessary. And the end of this process is the liaison with the community, with the primary healthcare doctor, and with the follow-up screening. As part of the Doxiadis prevention program and as part of the Fofi Genimata screening program. So, screening depends on two things: access, meaning vulnerable populations must have access across the country, and on quality, the quality of health services. I'm not only talking about the quality of the LDCT, but also about the quality of subsequent steps, because giving a medical opinion to a patient is not enough. Patients will go home and forget about it. The other day, I was at a breast cancer conference, and we were shown this imaging that described 2-3 cancer sites, but failed to mention that the patient must undergo follow-up tests. So it described that there were some lesions, and there was no comment prompting the patient to have follow-up tests. And this led us to a 26-year-old female patient suffering from severe cancer. So the LCDT is not enough on its own. It's part of a process. Take a look at this model. It's one of the models that are currently applied in the EU. And keep that model in mind. There is the leading center, there's center of reference, there is, we do have these centers in Greece. We have to highlight them though. And we need to make sure that they are quality driven. And these reference centers will be mandatorily included in a quality assurance system, and then liaised with centers that have LCDT equipment, that have experienced diagnosing radiologists, and they will mandatorily report to the regional center as well as primary healthcare. And all of these facilities must strictly comply with all of these principles. It's not something that is hard to attain. It's been done. It's been done in Croatia, in Poland, and elsewhere. But it requires cooperation. This involves all of us. We must also accept that we have a part to play. It's not up to the state alone. In closing, I would like to share an example of a program that has been running for 1.5 years now. Many of you know of it. It's a program for which I would like to thank Corina once again, because this program was launched as part of Corina's vision. At some point in time, after Simon's death, perhaps 5 years later, this was part of Corina's vision. It started it was started by a team of volunteers who help Fairlife, and also with the assistance of Fairlife, who support the unemployed, the uninsured, in order for them to have access to screening. It's a pilot program, and I will share with you our experience from this program. Some of the people who are working in this program are also here in the room. I think that it is important to say that it's not like we have reinvented the wheel. No, we follow what others have done before us, but we do it in a very careful way. These are the inclusion criteria. Persons aged between 50 and 80, active smokers, or those who have quit smoking in the past 15 years, and the number of pack years is more than 20. So also people, regardless of their smoking history, if they have relatives, first-degree relatives who suffer from lung cancer. So every week, on a voluntary basis, we assess the person in front of us. They may be healthy, they may not be healthy. If they meet the inclusion criteria, they're in the program. We register their data in a database. It's not a difficult thing. We have digital health, we have many different applications. We can have such databases. We refer the patient to a smoking cessation unit, or with the COPD practice. We also perform an LDCT, but not an ordinary CT. Keep that in mind. An LDCT that will be read using AI, algorithms that are in line with international standards, and by a diagnosing radiologist who is knowledgeable. This will give us a full opinion that will not only mention the findings, for example, nodules, but that will mention all needed data. Then a consultation within the team will follow. The team will provide a treatment plan or a plan for future steps. And again, it's not our own invention, it's the algorithms that have been introduced and acknowledged internationally, the ones that we're following. And we also provide instructions and recommendations. And if no findings are shown on the CT, we book an appointment for a year later. This is the checklist. I'm just allowing you to take a look at these forms because I merely want to show you that there are some efforts in place. They're ready to be used. They're voluntary efforts. Please make use of them. We will cooperate with you. So this is the checklist. It's also available in electronic format. It shows the patient's details. And this is the checklist of the diagnosing radiologist. It's not only us who have a checklist. No, the radiologists have their own checklist. And then this is a template opinion. So the description shown is in line with international standards and requirements. It's not only a listing of findings. So what is it that we have achieved during, well, the first people that were screened as part of this program? In fact, out of the first 106 people we have screened, 25% of them had abnormal findings. This does not necessarily imply cancer, but you know, CT and screening can actually identify other things. For example, cardiovascular things or a number of other abnormalities are not only cancer or malignancies. And these findings may help patients change their lifestyle, change their ordinary habits and patterns. And we've also actually identified 4 people with lung cancer, 4 out 106. So we've saved 4 lives, as simple as that. We've saved 4 lives through this very simple pilot program that is running in Greece. 2 of these people had resectable non-small cell lung cancer in early stages, and 2 of them had small cell cancers, one of whom was in an early stage, so that life was saved. We've also identified 1 woman with multiple pulmonary nodules that were proven to be metastatic due to pancreatic cancer. We've identified 3 persons with mediastinal lymph node disease, and we've identified 19 persons with nodules that require follow-up testing after 3 months or 6 months, as dictated by algorithms. So this is our experience. And this is my personal experience from the program we've been running in our hospital. So are we ready for screening at national level? We have evidence from across the globe. We have experience. We have the know-how. We are scientifically adequate, and we have the support of different scientific societies. We've actually tabled proposals to the Greek state, and we do have IT to support digital health, and we have the FOFI Genimata program. So what is it that we need? We need things that may sound easy. We need certification, accreditation, and certification for reference centers. Also, we need a smoking cessation clinic. It's an important component. Also, scientific knowledge and expertise, yet another significant component. The pulmonary nodule assessment clinic. The possibility to intervene early and have early diagnosis and early intervention. Also, we need a quality assurance program that will be run centrally. We need training, and we need liaison with primary healthcare. We remember that a colleague last year said that primary healthcare is the gateway to the system, and it should be considered as such. And last but not least, we need to identify ways to reach out to vulnerable populations while taking into account that there is stigma. And you know, lung cancers suffer from guilt. Smokers, particularly heavy smokers who are high risk patients, have to suffer the stigma because it's supposedly their own fault. And this person will find it very difficult to get to a doctor for screening purposes. So we need to come up with ways to reach out to them. And I think that all efforts made by Fairlife are very important. They will also run an anti-stigma campaign that, in my opinion, is very important, and we should all support it. And last but not least, there are many examples that serve as showcases. The one from the UK, for example. And I think that Professor Suliotis said something that I will repeat. It's not about us wanting it, it's about us being ready for it. Thank you.
Thank you very much, Mrs. Leonardo. Mrs. Agapidaki, there's so many questions. It's an ocean of questions. So I will give you the opportunity to prioritize and to make your own comments based on what you consider most important or most urgent. Yes. Before I start commenting on what we heard, I'd like to make an introductory remark. So, first of all, it's not the FOFI Genimata program. It's a national action for breast screening. We're also talking about cervical screening. We're talking about cardiorespiratory diseases, cardiovascular diseases, and in the coming weeks, we will have another program for cervical cancer. And up until the end of 2023, or rather end of February 2023, everything will be up and running. But there is a big difference when we talk about screening program and some tests. I want to say that the conditions are very different. It's one thing for me to go to the doctor and say, look, I'm X years of age, I have some risk factors, and then my personal doctor will say, go get some tests. That's on an individual level. That's different, that kind of screening. But when we're talking about mass screening, population screening, there must be one significant principle in place: do no harm. This means that you need to have research, years, decades of research in different countries with different populations that ensure in the best possible way, and all this is evidence-based, that we will actually do more good than harm, because there is no test or no drug without some risk involved, small or great. So we must be in a position to calculate the possible risk vis-a-vis the benefit. So the organized screening programs organized for years now are within this framework. So as we speak, there is a discussion going on in the European Commission. Greece is participating with the Ministry of Health regarding the revision of the guidelines at an EU level of these programs. And there's also another discussion to include screening for lung cancer in the European guidelines. What does this mean? This means that we will have the possibility to follow a common European framework. This is very important. Why? And this is my first comment. It's not whether we want to be ready or whether we don't want to be ready. That's not the question. There is no such question. And sometimes experts seem to find things easy, but they're not that simple, really. If you consider, Mrs. Leonardo, the wonderful protocol that you just presented, can it be replicated all over Greece? Can it be rolled out? No. Why? Because we need training of the experts. We're missing that. We can't, with the existing means, ensure that the radiation diagnostician in Thessaloniki has the same scientific competence as his counterparts in Rhodes, Zakynthos, and so on and so forth. So what you need is to have the funds. You need to have the capacity in place. You must be 100% sure that there's a homogeneous application of this protocol in all areas of Greece. You have to see where there is no access and where you need to have mobile units. Why am I saying this? Because in the case of breast cancer screening, so we're talking about digital mammograms, this is something we're familiarized with. We've known it, but we needed to have a lot of assumptions. You talked about interdisciplinary councils. Well, Greece doesn't have quality criteria regarding all these systems in place. So it's not just a matter of political will. There is the political will, and that's a given. The question is how we can start creating a framework. And I repeat, this should be in agreement with the European guidelines because we're going to the level of the population, not at the level of the individual citizen, saying that I have this test available at LP and whoever decides to do it and recommend it to his patients, well, that is a possibility. No. So the question is, how do you identify the population? We're not talking about general population. We're talking about high-risk groups. And in the high-risk groups, we must know how things are assessed. For example, smoking habits, how is this assessed? And Mr. Suliotis knows that in research, we have spent many years in order to come to a conclusion on this and to say that we have hard evidence showing X and Y. So the question is, how can we properly assess the population? How can we have a procedure in place which is quality-wise assured? We want people who can understand the test and who can explain it. And screening ends at a certain point in time, and then we have the journey of the patient in the national healthcare system. And all this has to do with digital transformation as well, so that everything can be monitored by the state. But we don't have a tradition in public health. We discovered public health in the midst of the pandemic. So we are moving ahead quickly, rather, with the screening programs, and we want to introduce this program in the national guidelines, and we want it to be implemented, but we need to do so carefully in order for us to be sure that we won't have the following problem. Let me just explain. Just imagine patients going and getting this test done, and then they have findings, and these findings are not assessed, and they fall out of the system. They're not accessing the system. This is not something that can be done quickly, and then the state can't just shrug its shoulders, for example, and say, sorry, we lost some people, that's not a problem. No. So screening programs are a new tool for Greece. We need to move carefully. We need to have strong foundations in order for it to be viable. Well, we want the country to react in a responsible manner. We don't want things to be done with lack of responsibility. I'm not here as a journalist. I think Mr. Loukidis can comment on this because there's a difference here between theory and practice. I think this is what was mentioned by Mrs. Agapidaki. Nobody wants theory that can't be translated into practice. So what we need is practice, implementing into practice all the above. Thank you very much, says Mr. Loukidis. And I'd like to say that the Hellenic Thoracic Society in its conference gives 3 prizes to people who've contributed to society. One of these prizes will go to Fairlife. Congratulations. And I'd like to congratulate Mrs. Linardo because she showed us the framework within which we need to operate. And let me try to popularize things. Some of the campaigns out there, well, we know that this was in one municipality in Piraeus. So there was somebody who heard this campaign. He went to his doctor and he said, I want a low dose CT. So the doctor prescribed it. I don't know if it was low a dose or not. And then he came to Attikon Hospital with a CD saying something. They found something. You need to help me. This is not screening for lung cancer. Let me clear that up. A campaign is one thing, and what we need to circumscribe is a different thing. So we, the Hellenic Thoracic Society, are in favor of a screening program because this is something that is recognized worldwide, but it must be done in an orderly fashion based on guidelines, and we should also have a pilot program. Metropolitan has a pilot program. It's a program where there's interdisciplinary collaboration and the results will be obvious. The same should apply in the case of the public health system. But right now, for a year approximately, we've been working on these guidelines. We have a working group. It's interdisciplinary. It's got many members. And we also have interventional pulmonology because there we need to carry out a diagnosis on these people. That's very important. And we also have another element, what we will do when we will find other diseases, cardiovascular diseases, interstitial pulmonopathy, and so on and so forth. And at the same time, and this was covered by the previous speaker, Mrs. Linardo, she said that we should quit smoking. If you find, for example, a nodule of 6 centimeters and you monitor this person, you can't allow him to keep on smoking. So we need to set a framework. And I mentioned this to Mrs. Agapidaki. This will be put up for consultation. So all stakeholders, all scientific society should be involved. And then we can talk to the ministry. The ministry is always welcoming us with open arms. And then we can talk about the framework for a pilot program. Because if the pilot program has a positive outcome, then slowly we can extend it. And in this way, we will help our patients, we'll help the health system, but most importantly, this will all be done in a way which is commendable, and people will say you did it correctly and not just to do something and to have campaigns. This is the main message, the key message. And one last thing, this has to do with what I've seen in clinical practice. In the last 2 years, a lot of CTs have been taking place due to COVID, many without reason. They were unjustified. But I think that one of the benefits from these CTs is not the problems caused by COVID, but many other diseases that were discovered because of the fact that people went to get tested. So this is the value of screening, provided it is done in an orderly fashion. Thank you very much, and I hope that next year we'll be talking about pilot programs. So let's look at the first step, one step at a time. Now, 2 very brief comments. We're very late. We're running very late. We've overstepped our time.
Well, picking up on what Ms. Agapidaki said, by the way, thank you, Ms. Agapidaki. It's one thing to know the scientific data, but it's a different thing knowing how to make use of them. So thank you very much, Ms. Agapidaki. Okay, I will pick up on what Evis said. There is a way to make everything happen in a safe way, and it's standardization. We're not only talking about the certification of equipment and human resources, we're talking about the standardization of the pilot program. If we do that, everyone will have to replicate this program. And that's the pattern. So, for example, the procedure followed in Kavala will be the same as that followed in Athens or elsewhere. So, we will all be on the same page. And this requires attention and this requires fiscal awareness as well. Yes, you've touched upon another parameter as well. So yes, next year we will have to talk about pilot programs. I know that there is a program similar to ours that is on its way in a hospital in Thessaloniki. I know that this will also happen in Athens, in another hospital. I've had several discussions with colleagues of ours, and everybody say that this is a nice idea. It's similar to the UK model, so we want to do similar things. We want to have similar databases that will then be given to the Greek state to build on them. Thank you. Thank you very much. Thank you.
Πάμε να προχωρήσουμε στις ενότητες. Έχουμε βγει λίγο εκτός χρόνου, αλλά θα το φροντίσουμε όλα. Η επόμενη ενότητα έχει τον τίτλο...
So we're running out of time, we're lagging behind, but we want to talk about precision medicine, its role in lung cancer and its value for patients. Please first watch a video. Thank you.
για τη σημασία της ανάλυσης.
So now we will talk about CGP, new technologies in molecular identification, and the challenges and best practices. Let's welcome Professor Christopoulos, who is a professor of hematology with the University of Heidelberg. Good morning. I would like first of all to thank Ms. Patelli for her invitation. That was an honor to me. So my topic is implementing precision medicine. Simply put, this means that we offer the most appropriate treatment to each patient depending on their tumor's characteristics. And this is why GCP is a determining factor. Just take note of two things. First of all, that for every property that may be taken use of from a therapeutic standpoint, for example, let's take a look at the green team, there is an oncoprotein that actually is responsible for tumors. Also, there is an activated oncogene in the DNA that carries a driver mutation. So we take a sample and perform a biopsy to perform sequencing. DNA is a molecule including codified orders based on the sequence of bases called ATCG. So when we have information about driver mutations through GCP, we become aware of the existence of oncoproteins, and this is very important in treatment. So this allows us, instead of destroying the DNA by targeting it in its entirety, to target specific oncoproteins. In fact, we target the oncoproteins that are important for tumor replication. So this implies medication that is more effective compared to chemo. Therefore, this means longer lives for our patients. But to achieve this, two requirements must be met. First of all, the GCP must be complete. So we must cover all mutations for which there are currently approved targeted medications. And these are the KRAS, the EGFR, BRAF, and HER2. And these are the standard mutations. And there are also some gene fusions, METX14, NTRK, RET, ROS1, ALK. We need all of these. If we only check 1, 2, maybe 3, the survival rates will be lower by approximately 25% within 2 years' time, according to a recent study. Requirement number 2, the GCP must be fast and results must be available before patients start getting treatment, so that we are able to give them the most appropriate medication from the very beginning. If there is a delay in getting the results, and if patients are put on another treatment, the outcome will be way different. So we need results within the first 5 weeks. So these are the two key requirements, the speedy results and a complete GCP. These requirements mean that next generation sequencing, the NGS, is of invaluable importance. There are so many different million things that are being sequenced, allowing us to have a good view, checking hundreds and thousands of genes at once. Compared to older methods such as PCR, Sanger sequencing, FISH, or immunohistochemistry, NGS allows us to check more than 10,000 genes at the same time. So we have faster results, we have an economy in terms of sample, we have lower costs, and we have higher sensitivity. In fact, the costs are lower by 20 or even 40%. Let me share two examples. In order to talk about the ALK gene fusions, approximately 1/3 of patients may be lost if we fail to use GCP. And there may also be some false positive results. It's only the NGS that combines a high prognostic value with respect to later response to medication, as well as a high rate of detection. Also, there are more than 100 variations involving EGFR exon 20 insertions. So, we can have a PCR method used, but this means that we will miss 40% of patients having these alterations. And please keep in mind that NGS is needed twice for each patient. We need NGS of the tumor DNA and we need an NGS of the tumor RNA. These two materials will be taken from the same biopsy in parallel. And there are some elements called introns that are just like exons, one next to the other. The alterations shown in blue color, well, we can actually identify twice as many cases if we have NGS. There are also some other technical issues that are of importance, but it's not now the moment to go through each method. I think that this is secondary. For example, today, either we talk about PCR enrichment or PCR enrichment with capture, or we talk about the ion torrent using WES. Well, we can actually achieve a lot. But I would like to talk about three things. First, we need NGS for all our patients with advanced non-small cell lung cancer, regardless of histology. This also includes squamous tumors. 2 years ago, the European Society recommended NGS only for advanced non-squamous tumors. However, this has changed in 2022. The recommendation now is a multi-gene panel-based genomic testing whenever more than one genomic biomarker is linked to a regulatory agency-approved therapy. This also includes squamous tumors because there are mutations that may be cured there as well. And there are also approved targeted therapies for squamous cancers. So, this affects approximately 20% of squamous cell carcinoma patients. These are the figures that are similar both in the US and Europe. Also, we can have a biopsy involving a blood sample. This is the liquid biopsy, and if applied, it will actually detect the same number of patients with advanced non-small cell lung cancer having curable mutations. And you can see the figures on screen. The tissue biopsy will detect 67% of patients, and liquid biopsy will detect 87% of patients. We have patients whose tumor is localized in a difficult spot, and this may mean that the NGS will be negative. Out of these patients, approximately 1/3 will have typical mutations that may be cured, as shown on the table, EGFR, KRAS, and so on. In general, liquid biopsy is faster and safer for patients compared to NGS. But this is something that is very hard to implement. Patients that are given targeted therapies may also find NGS useful, particularly when they fail to respond to treatment. This happens because these patients will either have a secondary mutation of the initial oncogene, for example, when given an ALK inhibitor or a second generation inhibitor or lorlatinib, they may experience new mutations. So they may benefit from new generation ALK inhibitors. And this also happens with other treatments. We have new generation inhibitors that may help patients. Also, there are many other patients who will have a refractory mutation in another gene, for example, MET-AMP and others. And these mutations can be treated, through available new drugs. And this is why after first-line medication, the recommendation is for a wider CGP involving not only the initial 10 genes, but some hundreds of genes. And the term is comprehensive genomic profiling. This will allows us to make use of more information for treatment purposes. For us to be able to give these people, these patients, the most appropriate medication, we need a molecular tumor board that will consist of different specializations. And the two questions that this board will have to answer is, first, is this treatment curable? And second, if medication is available but not approved, how will we grant and allow access to it for our patients? And then the answer is clinical trials or palliative care programs or off-label administration. This is an effort that is worthwhile because we already have the first evidence indicating that assessing patients with non-small cell lung cancer will lead to better survival rates. It's the red line. But early intervention for eligible patients, rapid completion of the CGP, and effective access to new drugs are all required. In closing, I would like to say that genomic profiling has a key role to play in modern oncology. It is a requirement for administering targeted medication. NGS is of essence for every patient with advanced non-small cell lung cancer, regardless of histology, so as to be able to fully check for all curable mutations before the initiation of treatment through combined DNA and RNA sequencing. Also, a new biopsy allows us to have targeted treatment for NGS, making use of a panel of experts and a molecular tumor board. This does not only involve few scientists. No, we need to raise awareness among stakeholders so as to introduce the state-of-the-art therapeutic practices and techniques in our day-to-day practice. And this is exactly the goal of Fairlife. This is why I would like to congratulate the organizers for today's event and wish you all the best of success in today's event. Thank you for inviting me. Thank you.
Thank you very, very much. And now let me invite Mrs. Evi Lianidou, Professor of Analytical Chemistry, Clinical Chemistry, Department of Chemistry, National and Kavadrastrian University of Athens. You have the floor, madam. So hello from me as well. First of all, let me congratulate Corina and let me thank Fairlife for the invitation. Let me wish you the very best of success in the work that you have undertaken. The subject I will be talking to you is liquid biopsy, clinical application, present and future, and the role of repeat biopsy. I'm really happy that Mr. Christopoulos, the previous speaker, talked about the liquid biopsy, and I hope that with my talk I will be able to heighten your interest in liquid biopsy. So liquid biopsy is not new. It started many years ago. So here you see with the arrow when in Greece we started using liquid biopsy 20 years ago. So we're talking about the analysis of the cell-free DNA, so cancer DNA in plasma and the circulating tumor cells. So here we see that many publications, there's an exponential rise of publications on liquid biopsy. So in comparison to classic biopsy, it has an advantage. The advantage is that we can monitor the patients and various time intervals, even when the primary tumor has been resected. And we can also see information regarding the tumor in cases where the biopsies are not possible. For example, in many cases of a lung metastatic cancer. So liquid biopsy has many analyses. For example, we have circulating tumor cells and circulating tumor DNA, where we can check for mutations and methylation, and also circulating miRNAs, microRNAs, but it's still very early days. So from this simple blood analysis, we can receive a lot of interesting information regarding the RNA level and the DNA level. And as was mentioned by Mr. Christopoulos, this is extremely important for the therapeutic approach. There are many different methodologies which have been developed in these 20 years, and a lot of effort is being made for them to be sensitive, specific, and so on and so forth, because as you can understand, what we see in the liquid biopsy is a very small number of cells or a small quantity of cancer DNA which circulates in the cell-free DNA in the plasma. So here you see many different technologies to isolate the circulating tumor cells, many different technologies, many different companies. So once we have the cells circulating in the blood, we can analyze at the level of proteins, at the level of RNA, and at the level of DNA. We can also check, and there's a lot of evidence on this, a lot of data. So we can check the heterogeneity at the level of single cells, where we can use various techniques, mainly NGS and Doppler digital PCR. So how does liquid biopsy help us in managed cancer patients? We can use it from the early stage, even for early detection and screening, after the surgical resection of the tumors, to identify the minimum residual disease, to check for relapse, response to treatment, and study of markers regarding developing resistance to specific forms of treatment. So it is used for all the above-mentioned reasons. Now, in relation to early diagnosis, liquid biopsy, well, there's need for more studies, but these have already started, at least some of them. In America, the FDA has already approved various methodologies based on liquid biopsy. And as you can see already from 2016, for EGFR mutations in circulating tumor DNA, metastatic non-small cell lung cancer, and real-time PCR and NGS. But also, again, we have KRAS G12C mutation. This is considered a diagnostic test which accompanies sotorasib, which was actually approved in June of 2021. Though even recently, we have the FDA, which cleared medical devices for Enhertu, ROS, for non-small cell lung cancer, and AstraZeneca, excuse me, and also tests based on liquid biopsy that were approved in September 22 and May 22 for circulating tumor cells. Now, the International Association for the Study of Lung Cancer with Christian Rolfo recently published a consensus paper, and this shows that the liquid biopsy may be used to add the tissue biopsy to the benefit of lung cancer patients. Now, CTCs, they have been studied a lot in NSCLC. I'll give you some information. So for years now, there's been a study after the isolation of CTCs using filters, special filters. There's an analysis by FISH, according to FISH, in order for us to see the changes and the fusions of the ALK gene. So on the basis of this, where we saw these changes in the CTCs in the blood, we monitored using crizotinib, which is a special drug for ALK rearranged cells. And we see that when we still have cells positive to ALK rearrangements, the prognosis is poor for the patients and they don't respond to treatment that well. There have been many studies. Here we have single circulating tumor cells. Here we see their heterogeneity, and we also see that the NGS, single cell sequencing, is an important tool for us to see the heterogeneous distribution of these cells and the relationship between this heterogeneity and the response of the patients to ALK targeted treatment. PD-L1, another important immunotherapy-related marker. This is mainly for primary tumors, but also in CTCs using specific systems. So here we can see with detail the heterogeneity of some are positive to PD-L1, some are negative. I'm talking about lung cancer. And here you can see various markers. We have immunofluorescence here, and these can be detected in lung cancer patients. And here you can see before and after treatment. So we also know that the cells that are positive to PD-L1 in lung cancer, well, they link to poor, if you like, prognosis. And this is why it's good for them to use immunotherapy, whole exome sequencing. We see which mutations are linked to resistance to chemotherapy and other studies which I don't have the time to go into in detail. So the importance of everything that I show you is that we isolate cancer cells before and during the treatment in patients with lung cancer, and on the basis of targeted markers, so we can see which treatment these patients will respond to. And again, ALK rearrangements and ROS fusion in studies, and here we see patients where these changes were found in circulating tumor cells during treatment. As a result, we see that the results of liquid biopsy may affect clinical outcomes and capture heterogeneity, and we see which are the mechanisms that cause resistance to these treatments, so we can finally choose the best personalized therapy for the patients. The same goes for cell-free DNA. Here we can see significant changes, and this show us that patients who are positive to cell-free DNA and CTCs have a worse prognosis. PD-L1 and Ki-67, these are markers important in non-small cell lung cancer and immunotherapy. We can see this in circulating tumor cells. And now I'd like to tell you a little bit about what we do in our lab in the chemical department of the University of Athens. We use an integrated approach for liquid biopsy in clinical samples. We use analyses from the same blood sample, both in cell-free DNA and circulating cells, and we carry out CTCs. We check for mutation and also epigenetic changes, different markers depending on the type of cancer, because it's not just lung cancer. We also look at prostate cancer, breast cancer, and basically I will present 3 studies that we did recently. We're talking about patients that were positive to T790 before and after treatment with osimertinib, and we checked with liquid biopsy the cells, epigenetic markers, and cell-free DNA. We actually use this device to isolate the cells. We managed to isolate them on the basis of their size, and after cell isolation, we isolate RNA. There are 3 time frameworks that we use: baseline, after chemo, and progression of disease. So here you see that we can have an expression study in many markers. One of them is actual, and as you can see, this is a new, very promising therapeutic target in lung cancer. Here you can see gene expression for every one of our patients, which genes are overexpressed in CTCs, and the differences we have in epithelial, mesenchymal markers during the treatment, the progress-free survival, and PD-L1. We also use immunofluorescence to examine the cells, and the study has shown that we can make use of this technology to see many more markers and to monitor the patients in various stages of their treatment. We also have seen in the same patients, this is a clinical study based on osimertinib. So we use digital PCR and crystal digital PCR. So we've seen mutations in the EGFR gene, and we carry out a comparison in the plasma and in the ROS method that has been cleared by the FDA, but also the Stilla method, crystal digital PCR, and the same mutations were also examined in the CTCs. So here we see that there is a good identification of the results with the FDA test by ROS and more sensitivity with crystal digital PCR, so we see more mutations. Here you see the percentage MAF of EGFR mutations at baseline and at progression of disease. So we have the possibility not just to see whether there's a mutation, but also the percentage, meaning at which the mutation is present and how this percentage changes at progression of disease. And here we have a map. Here you can see the primary tumor, you can see the plasma cell-free DNA, the baseline, and the progression of disease, and the same sample in the CTCs. So here you see patients who have exactly the same mutations, but in other cases you have other mutations in progression of disease, and this is something we need to take advantage of and benefit our patients. We've also looked at epigenetic changes in CTC and cell-free DNA. We're talking about changes in the DNA. We're talking about methylation level mainly and histones, but it's very important and very much linked to smoking. So smoking seems to cause a lot of methylation. We're talking about oncosuppressor genes, and these may lead to oncogenesis, particularly in the case of lung cancer. So the presentation of methylation in the promoters of the genes leads to deactivation of the genes, so oncosuppression genes are not expressed. This information is used for the early diagnosis, for prognosis, and for study of the minimum residual disease. So we saw methylations in oncosuppressed in oncosuppressive genes in breast cancer. This was 11 years ago, and now we have a direct correlation of methylation to specific genes which have a large number of high methylation, and we're talking about cell-free DNA and circulation tumor cells. And we saw that in many cases there are these methylations found in the liquid biopsy. And we've also seen PD-L1 in patients. We're talking about CTCs during the non-small cell lung cancer, and also other genes related to metabolism, glucose metabolism. So these are very important. And I hope that this plays an important role in circulating tumor cells in the case of lung cancer methylations. And finally, I'd like to say that PD-L1, we use digital PCR right now quantitatively, and this gives us the possibility to measure the expression of PD-L1 in CTCs with an absolute quantity determination. Finally, something very important in liquid biopsy is the standardization of methodology, the control of quality. This has been mentioned in previous stages, but also in these stages of liquid biopsy. And we have an IMI program. This was a European program which aimed at standardization of pre-analytic and analytical parameters for cell-free DNA and CTC studies. And all this is extremely important, and this is why labs that carry out liquid biopsy analysis should be certified by ISO 15189 in order for us to make sure that it is certified. We are certified for EGFR mutations and for the enumeration of CTCs with a cell search system, which has been approved by the FDA. So due to the importance of liquid biopsy, the main aim being to use it in clinical practice, we have created the International Liquid Biopsy Association, ILSA, and here we have participation of many bodies like NIH, like the International Liquid Biopsy Society, the European Liquid Biopsy Society, the aim being to standardize and to use liquid biopsy analyses as part of everyday clinical practice. Finally, let me say that CTCs and cell-free DNA provide important information for an NSCLC, and we can use all this to the benefit of patients and to monitor them when they are taking treatment. I'd like to thank all my collaborators in Greece and abroad. We've been working very closely all these years. I'd also like to thank my team, my research team at the University of Athens. And I'd like to invite you to our 6th conference, which will be organized. It's an international conference. It's on liquid biopsy. That's our theme. And this will be held next September, 2023, that is, on the island of Skiathos. Thank you very much.
Σας ευχαριστούμε πάρα πολύ. Ακούσαμε την...
Thank you very much. So we've listened to the scientific community, but now it's important to also listen to the Greek state's representative. So Mr. Rigatos, the head of the control of contracts and the auditor, the head of the Independent Directorate of Contracts and Vendor Auditing with the National Organization for Healthcare Services Provision. Good morning. So we'll talk about the organ that is called lung. How were lungs described in the past? Life resides in breathing. Breathing is the transmitter of every single vital action and all passions. And the core of life is a diaphragm. The soul leaves the body with a last breath. So we realize how important of an organ lungs were. Greece has to address all challenges relating to health. In this framework, we must integrate all modern approaches, therapies, and practices. Both the Ministry of Health and our organization support all efforts in this direction. There is no lung-related exam that is not reimbursed by our organization, AOP. Even new tests, you all know that there are new tests coming out every month that are getting better and better. Even these new tests are covered by under the Government Gazette number 4195. Doctors will submit a relevant request to our organization for any non-reimbursable test, and then reimbursement may be granted. I think that our organization, AOP, is always standing next to the Lung Society, with whom we cooperate in order to take advantage of its knowledge and resources. So thank you very much. So now we will meet our commentators who are with us remotely. We will start with Ms. Xenia Saridaki, who is a medical oncologist, president of the Hellenic Society of Medical Oncology. Ms. Saridaki, over to you. Good morning. Oh, now we can see you. Good. Thank you. Thank you for being here. Good morning. I should be thanking you. It's very important to have conferences like the one you're hosting by associations, entities such as Fairlife. This is an opportunity for different stakeholders to get together. Stakeholders that are involved in lung cancer treatment, that is. I think that all presentations were highly interesting. I've listened to colleagues who are experts in their own field, and it is an honor for us to be able to witness them talk about the research taking place within their facilities. On our part, on the part of the Hellenic Society of Medical Oncology, I think that what we must stress and highlight is something that has been put forward again and again. We must integrate all biomarkers in the national prescription system and also integrate NGS within this system. Like previous speakers said, it cannot be that we will prescribe and recommend the appropriate treatment and medication for our patients without having these two tools available. Undoubtedly, in Greece, there are many lung cancer biomarkers that are covered under the national prescription system, but NGS has not yet been included therein. Also, newer biomarkers have not been included either. We have had a successful effort in 2013, but since that time, we've only included 2 genes in the national prescription system, and only 10 days ago, these 2 genes were actually started getting covered from the very beginning. So we have forwarded a number of documents to all competent stakeholders so as to have coverage for all biomarkers. And we are currently processing a draft NGS consensus. Clearly, this will not only include lung cancer. Thank you. Thank you, Ms. Saridaki. Now we would like to listen to the input of Ms. Aphrodite Noni. She is a pathologist and the president of the Hellenic Society of Pathology. Hello. We can hear you. Hopefully we will be able to see you as well soon. Hello. So thank you. Thank you for inviting me to participate in this highly interesting conference. It is very important to touch upon every aspect of this disease. This disease involves a large number of data, imaging data, therapeutic data, and so on. But one of the most sensitive aspects of the disease is personalized treatment. And today we're talking about lung cancer. So needless to say, everything that has been said already have walked us through the most recent data, the latest studies and research, and enabled us to understand that things are actually happening. So many developments are taking place. So we want a holistic approach to all mutations that may be related to any type of cancer or carcinoma, lung cancer included, combined with appropriate treatment. Unfortunately, in Greece, although we have seen some positive efforts, it seems that these have been isolated cases. In the sense that, like Ms. Saridaki said, on the one hand, not all biomarkers are covered, despite that some targeted medications have been approved. And also, NGS is not covered for any organ. But the biggest problem of all is that there is a fragmented approach. There are fragmented efforts in the sense that there are no specific organized centers to cover histology, either it needed or not, so as to have the molecular profile of a tumor that will help all colleagues involved in treating patients. This is a wide topic. This requires people who are experienced. This requires centers that must be accredited. Otherwise, anyone will deliver whatever results they like. So in that sense, although there are more optimistic speakers in this panel, I am sort of cautious in light of Greek reality. I think that we have not come to the point where we would like us to be. We need organized, accredited centers being able to deliver the entire range of necessary, useful information for treatment purposes. Thank you. Thank you. And last but not least, Ms. Kathia Apostolidi, the president of the Hellenic Cancer Foundation and the past president of ECPC. So is Kathy with us? And this will bring us to the end of this session. So, hi. OC is muted, unfortunately. Please unmute yourself.
Okay. Λοιπόν,
Τώρα σε ακούμε.
Ευχαριστώ
Τώρα
πολύ
σας
για
ακούμε.
την...
Πολύ ωραία.
Ευχαριστώ πολύ.
Now we can hear you. Good. Thank you. I would like to thank my friend Corina for inviting me to today's conference. The agenda is excellent. I'd like to say that I've taken stock of two things mentioned by Mr. Christopoulos. First, the need for molecular tumor boards. These are different to standard medical boards, and they are necessary, at least in hospitals, providing services to lung cancer patients. I'm talking about hospitals such as Sotiria, which is a chest disease hospital, and others. Also, Mr. Christopoulos and Ms. Lianidou both talked about the certification of laboratories. This will assure quality. At this point, I would like to say that there is a big but. And this but has nothing to do with our willingness. It has to do with the lack of mandatory certification and quality assurance. So it's up to every laboratory and site to get certified. Also, we need certification for two things: the quality of laboratories and the quality of the equipment used. So we need a standard that will be used following appropriate changes to all types of cancers. For example, not only lung cancer, but breast cancer. And this has also been touched upon earlier. I would like to insist on a very specific issue, meaning biomarkers. Last year, the National Cancer Federation, hosted a one-day conference so as to present to Greece the results of the European study conducted by ECPC, of which I was a president in the past. This is a body comprising pharma industries from across Europe. So, this study involved 12 countries and it studied a panel of biomarkers. The relevant results have been published and they have been presented in Greece during a press conference held in September. We feel that it is very important for all countries to follow the same steps, the same policy guidelines, and the core is to approve and authorize drugs at the same time. Particularly with respect to lung cancer, we must have NGS for biomarkers. This is critical. And I can no longer tolerate excuses like this is expensive, let's think this through, because this is something that has already been applied in other countries. For example, in Belgium, which is a very small country, they have been applying this subject to conditionalities. And, you know, Dr. Martin van den Boog, the president of the Belgian Lung Cancer Institute, has been invited to Greece because we wanted to listen to him talk about how a small country whose population is more or less the same in numbers as the Greek one, how this small country succeeded in applying this practice. Also, there are other measures recommended by this European-wide survey. For example, the establishment of biomarker testing, the establishment of a panel of experts within hospitals. And sometimes we see that the budget is running out very fast. So we also need this to be taken into consideration, along with a series of other problems that must be addressed. We've heard Ms. Linardo and Mr. Christopoulos and Ms. Lianidou talk about what can be done. We must establish the quality certification of laboratories involved in testing that will be mandatory, particularly for liquid biopsies, because each site has their own rules, so standardization is of essence. Mr. Souliotis was right to highlight this. And we must also adopt a quality system. It cannot be that we have doctors who have to provide diagnosis working on lab results coming from non-certified laboratories. This is not a quality system. Thank you very much for your attention.
Thank you very much. And now we've come to the end of the first session. I'd like to thank the speakers, those of you who've been watching. So stay with us for the second session after we watch a short video. Thank you.
Οι ασθενείς με καρκίνο του πνεύμονα αντιμετωπίζουν μεταξύ άλλων και το στίγμα γύρω από την ασθένεια, κυρίως επειδή θεωρείται μία νόσος που θα μπορούσε να αποφευχθεί. Η πλειοψηφία των καρκίνων του πνεύμονα συνδέεται πράγματι με το κάπνισμα. 8 στα 10 άτομα που νοσούν με καρκίνο του πνεύμονα είναι καπνιστές ή πρώην καπνιστές. Είναι όμως σημαντικό να γνωρίζουμε, σύμφωνα και με πρόσφατες έρευνες, ότι το 15% των ασθενών με καρκίνο του πνεύμονα δεν κάπνισαν ποτέ και το 35% είχε διακόψει το κάπνισμα πριν από τη διάγνωση. Ο σύζυγός μου Σάιμον, που μας ενέπνευσε να δημιουργήσουμε τη Fairlife, νόσησε από τον καρκίνο του πνεύμονα σε ηλικία 56 ετών, ενώ είχε διακόψει το τσιγάρο από την ηλικία των 42 ετών. Ο Σάιμον δυστυχώς έχασε τη μάχη με τον καρκίνο του πνεύμονα τον Αύγουστο του 2020 και σήμερα η Fairlife στηρίζει όποιον βιώνει την ασθένεια, αλλά και την οικογένειά του που στέκεται δίπλα του. Πάντα με κατανόηση και ενσυναίσθηση. Δεν ξεχνώ όμως το πόσο άβολα και ενοχικά ένιωθε ο σύζυγός μου όταν το ρωτούσαν διαρκώς κατά τη διάρκεια της νόσου. «Καπνίζατε? Πολύ? Πότε το κόψατε?» Ένιωθε υπεύθυνος για το δικό του καρκίνο. Το στίγμα δυστυχώς το κουβαλούσε μαζί του καθημερινά μέχρι που έφυγε ανήμπορος στο δωμάτιο ενός νοσοκομείου. Το στίγμα δεν έχει και δεν πρέπει να έχει θέση σε μια δίκαιη κοινωνία όπου η περίθαλψη με ίσους όρους είναι δικαίωμα όλων μας. Όλοι οι ασθενείς με καρκίνο του πνεύμονα αξίζουν φροντίδα και συμπόνια. Είτε καπνίζουν, είτε κάπνιζαν στο παρελθόν, είτε δεν έχουν δοκιμάσει ποτέ το τσιγάρο. Αξίζουν να έχουν την ίδια ευκαιρία στη ζωή με κάθε άλλον που αντιμετωπίζει μία απειλητική νόσο για τη ζωή του. Όπως προδίδει και το όνομά μας, στη Fairlife διεκδικούμε μία δίκαιη ζωή για τον ασθενή. Δίκαιη με έγκαιρη και καθολική πρόσβαση στην πληροφορία, στην ενημέρωση, στις διαγνωστικές εξετάσεις, αλλά και στις καινοτόμες νέες θεραπείες. Η Fairlife διεκδικεί ίσες ευκαιρίες για όσους βιώνουν τον καρκίνο του πνεύμονα, χωρίς στιγματισμούς. Είναι τιμή μας λοιπόν να τρέξουμε στην Ελλάδα μια διεθνή καμπάνια για το στίγμα που έλαβε χώρα με καλά αποτελέσματα στον Καναδά και στην Αυστραλία. Όλοι μαζί μπορούμε να μεταφέρουμε το μήνυμα ότι το στίγμα δεν αφορά κανέναν. Δεν αφορά τον συνάνθρωπό μας που νοσεί με καρκίνο του πνεύμονα, δεν αφορά την οικογένειά του. Πολλά ερωτήματα πρέπει να απαντηθούν. Ερωτήματα που στοχεύουν στην εξάλειψη του καρκίνου του πνεύμονα, που αποτελεί μια μάστιγα, μια τωρινή πανδημία για την κοινωνία μας. Ας μην ξεχνάμε ότι όποιος έχει πνεύμονες μπορεί να εμφανίσει καρκίνο του πνεύμονα.
So we're waiting for the speakers to come sit here, but we're also waiting for those watching from afar. So let's move on to the second session, which is on personalized therapies in modern treatment of lung cancer, facts and new approaches. We have with us most of the panelists. I think this represents our lives, some from close, some from afar. So this hybrid model is more leaning towards physical presence. I'm very happy to note that. This was mentioned by the previous speaker. Last year, there were 5-6 people in a studio in a blue box, and we saw some screen, but everything was not warm, it was cold. Now we can talk to one another face to face, we can look at one another, we are physically close to one another. Now our first speaker is Mrs. Athina Christopoulou, medical oncologist, director of oncology unit at the General Hospital of Patras, is with us, but she'll speak from afar. But we always feel that she's very close to us. She's always with us, supporting Fairlife. Mrs. Christopoulou, good afternoon. Mrs. Papadimitriou, dear Elena, hello everyone. So we will see you in a couple of seconds, Mrs. Christopoulou. You will talk to us about the ALK biomarker. So you can keep talking to us, and we will be watching your presentation because we're pressed for time. You know what it's like. We have to run fast. Thank you very much for the invitation. So we're talking about personalized therapies, and we will talk about this biomarker, which is known as ALK. Please change slides. I can't see the slide changing, says the lady. Please change my slide. Can somebody change the lady's slide? Let's see. Sometimes there are technical problems, but they always are solved one way or another. So here we have the speaker, Mrs. Christopoulou. So I'm no longer sharing the screen because I don't want there to be a problem. You will be changing my slides. So which slide do you want us to go to? Next slide, please. Next slide. Thank you very much. Here we are. Solutions are always easy to come by. So what is ALK? ALK is responsible for the development of the CNS in embryonic life, and then it stops acting, but it may share genetic material with EML4, and thus we have this fusion, this EML4-ALK fusion, which has oncogenic activity, meaning it can lead to oncogenesis. This is something we first found out in 2007. Next slide, please. And already. So next slide, please. So here we have the developments. These developments were really mind-boggling. Here you can see various molecules starting from the first generation ALK inhibitor. So this is a factor that suppresses the oncogenesis of this fusion. And then we had the second generation and the third generation inhibitors, ALK inhibitors. Next slide, please. So here you can see the development clinically of ALK inhibitors, which changed the trajectory of the disease for people suffering from this genetic disorder. Next slide, please. What we need to mention is that this disorder is common, meaning the percentage is 3 to 7% in unselected patients with NSCLC, and more specifically adenocarcinomas. It's also very important for the clinician to know when he needs to seek it out, because these patients have specific clinical characteristics, meaning they're usually younger, and normally there is no history of smoking or minimal smoking history. We're talking about adenocarcinomas, and patients who have this genetic mutation often have remote metastases, meaning brain metastases. The percentage is 30% at initial diagnosis. Next, please. Next slide. So here we have this first publication. It was in the New England Journal of Medicine. Crizotinib, this ALK inhibitor, was tested versus classical chemotherapy, and the results we saw were very good in relation to overall survival. And we had in our quiver new molecules, and we also recognized that patients will take this inhibitor and develop resistance. So we found new resistance pathways with other next generation ALK inhibitors, and this benefited the patients. The overall survival right now is 7 years. It goes up to 7 years. Next, please. So here we see over time information regarding the newest ALK inhibitors, first line of therapy. Next slide, please. So we try to compare the younger generation inhibitors to the crizotinib, which was the first of its kind. And I wanted to show you orlatinib. Orlatinib is now first line of treatment together with 2 more molecules in ALK, rearranged ALK, meaning 2, if you like, translocations. And here we have significant studies, and these clinical studies showed, next slide, please. They showed significant benefit in the progression-free survival, meaning survival until the next relapse. Here you can see the curves. The blue curve was in favor of the patients who received orlatinib compared to the previous ALK inhibitor, the older one. Next slide, please. Next slide, please. And here you can see that this benefited patients with and without brain metastases at baseline. And it's very important to see this in patients with brain metastases, meaning from the beginning we have a molecule, and even though there's a brain metastasis, we see that it offers a benefit regarding survival. Next slide, please. And here you can see, and this is very important, another diagram. The diagram shows this benefit, meaning the fact that the brain metastases doesn't progress quickly. It is delayed thanks to this drug. And here you can see the curves, how they change and how they flatten out. The blue is the ferplatinum. Next one, please. So here we see that we have a drug that avoids the spread of the disease, and it also shrinks the existing tumors. That is very important. Next, please. And here you can see the important benefits that can be achieved, but also we sometimes have full response, so that's great. And let's move on to the next slide. So complete response. And in order to save time, let's skip this one. Unfortunately, I'm not the one handling the slides. And here you can see that we can slow down the next line of therapy. This is very important because we want to keep the patient for as long as possible on a good drug before moving on to the next one. And of course, the knowledge we have in our hands today shows that there are variants, various disorders that can determine the resistance to these inhibitors. We can identify them, and we can actually work effectively in favor of the patient. Next one, please. We can't hear the lady. The lady is, we can't hear her. I'm very sorry. Could she speak? There's a problem with the connection. I don't know if you can hear us, but we heard you very faintly, very faintly. I'm sorry. I can hear you now, says Mrs. Christopoulou. She's back again. So let us try to continue. So we've come to the end of my presentation, so please bear with me. Yes, please continue, Mrs. Christopoulou. We can hear you now. Please move on. Next, please. Next, please, in order to save some time. Next one, please. So we have available various ALK inhibitors, 5 important molecules. These are well-designed clinical studies. We had significant response rates. We had CNS responses and overall survival. So you can now move on to the next slide. Next slide. Next slide, please. Not that one. Please change slides. And this one too. So please change the slide. So right now we have we lack head-to-head second versus third generation TKI comparison. So we know that the clinician has to base himself on his experience and look at the clinical studies as well. Let's move on to the next slide. Here you can see the guidelines There are 3 significant ALK inhibitors used in first-line therapy. Next slide, please. And of course, the possibilities offered thanks to other ALK inhibitors when these patients relapse. Thank you. Next slide. Next slide. Next slide. So I've come towards the end. So what we must remember today is that we leave the tissue ID of the tumor behind. What we now want is the tumor molecular profile. So we know that we're talking about personalized therapy. So everything has changed. And now we have the different histological subtypes of non-small cell lung cancer. And again, the lady is breaking up and we can't hear what she's saying. So let's move on to the next slide. So we try to find the small genetic disorders which we are now in a position to target. Here we have all the resistance mechanisms, and we know this is very important. So we have different levels, meaning up to the 5th level. We try to offer targeted treatment. We are targeting a specific disorder and not just the disease. So we're talking about personalized treatment. Next one. So this is precision medicine. And here we have an example of response of the patient. Here you can see a PET CT image. We saw that at baseline, you can see how widespread the disease was, and after using an ALK inhibitor, we see how well the patient responded to treatment. This was my last slide, so thank you very much. Thank you for the honor and thank you for the attention.
Πάρα πολύ, κυρία Χριστοπούλου, και ευχαριστούμε.
Thank you very much, Ms. Christopoulou. And also, we would like to thank you for shortening your presentation due to problems with our connection. Our next speaker is here. It's Mr. Lainakis, the Deputy Head of the 4th Oncology Department with Metropolitan Hospital. The floor is yours. Hello. I would also like to thank Ms. Patelli and Fairlife for honoring me with their invitation. I'm here among esteemed colleagues, students, and patients who are experiencing a very difficult and challenging cancer. So my presentation has to do with a variation of the EGFR mutation. It's the EGFR 20INS. It's one of the mutations that are most common. We can see that approximately 60,000 people have EGFR mutations every year. Up until recently, these patients didn't have any therapeutic options. As a result, their survival was hugely impacted. This frequency it's continuously increasing, and we've come to a point where we believe that there are countries that do not have the evidence that they should have. This graph shows the frequency of this specific variation. Globally, it's the US, the Europe, and South Asia that seem to have the higher rates of detection with respect to this mutation. However, these rates are different between countries. There are different detection equipment and methods used, so possibly we are missing out on some patients. Still, we're not talking about a single entity when we talk about lung cancer, because there is different histology, there is different staging, and there is different molecular profiling. And this is reflected in US and EU guidelines. So now patients must be screened for all types of mutations, no matter how rare they are, because this will clearly affect our therapeutic decision. And what I said earlier is that unfortunately, these patients cannot benefit from typical agents targeting EGFR. Their response is poorer. For example, when they are given afatinib or serotinib. And we know from studies that those having mutations in exons 19 and 21 have better response with these agents compared to with chemotherapy. The 5-year survival rate is very, very poor, whereas the case is different when we're talking about the typical EGFR mutation, and we also see what happens to the real population data. The survival is only 16 months, which means 75% higher probability of death compared to standard EGFR mutation populations. And since we're trying to talk about this insertion, I would like to simplify what it means. We can see that the EGFR receptor is on the left. It's practically a protein, and mutations occur in its intracellular part. The insertion of concern means that there is a series of sequences introduced in the gene, and as a result, an abnormal protein is produced. It's the third picture on the screen. And this abnormal protein means that the agent targeting the specific receptor cannot bind with it. In other words, there is no drug for this specific mutation. Now, what are the populations of concern? The populations with EGFR exon 20s are the same populations having EGFR. It's non-smokers, females, and we talk about adenocarcinomas, lung adenocarcinomas. It's rare to have this mutation in squamous carcinomas. How is it detected? Well, it's through PCR and NGS. However, it is also important to use the most appropriate method because, like I said earlier, it's very important to not miss out on any patients. For every 2 EGFR mutations detected with NGS, 1 will be lost through PCR. And out of the 17 most common EGFR mutation variants, only 4 can be identified through PCR. Also, we've talked about the NGS advantages earlier. We know that it is a very simple method that requires a small amount of sample. Also, it requires a small turnaround time compared to other diagnostic methods. And, like we know, there are approximately 102 unique mutation variants that can be identified through NGS. And unfortunately, these mutations cannot be identified using PCR. Fortunately, since 2011, as shown on the graph, NGS has been increasingly used. Therefore, we have high rates of detection. And in fact, in the States, during these 10 years, the rates of PCR use dropped and the rates of NGS use increased. we can see the real life data involving immunotherapy and the PFS and the overall survival rate. We also see higher response rates. Chemotherapy amounts to lower success rates compared to first-line treatment. So the first-line treatment includes chemotherapy, which is a high toxicity therapy, and a non-targeted therapy. So having this mutation means a lot. There is research that has shown that the greatest percentage of patients suffer from severe disorders, emotional disorders, and in general, they suffer from anxiety about their future, about their finances, and there are also other symptoms relating to family social activities. So it is high time that we find an agent targeting this specific mutation. And now we have two approved agents, both of which have been approved by the FDA, and they have two different mechanisms of actions. It's amivantamab, and mobocertinib. The overall survival rate is 23 months. We are talking about treatment following platinum-based chemotherapy. And the overall rate is 40. Now, the success of both these agents is evident, and the side effects are not that evident. However, there may be toxicity, which may be a limit with respect to some types of patients. But I would like to share an optimistic message about the future. There are currently studies underway for this medication used as first-line treatment, either combined with chemo or combined with other agents. So maybe these patients will not be given the option of chemo and instead be given less toxic agents that are more effective and targeted. In closing, early diagnosis is of importance with respect to EGFR mutations. Previous methods have underestimated the total number of these mutations. Also, we know that NGS has been recognized as a very good method and that is beneficial for these patients in particular. And we know that we expect a treatment, a therapy that will provide best outcomes, thus helping approximately 60,000 people every year. This will give them more time to live, and it will also give them hope. Thank you.
Ευχαριστούμε πολύ, κύριε Λαϊνάκη.
Thank you very much. Now let's watch a video sent by Mr. Skoulidis, professor at the University in Texas. It's a recorded message, so let's listen to him.
Good afternoon. My name is Ferdinandos Skoulidis, and I'm an associate professor in thoracic oncology at the University of Texas MD Anderson Cancer Center. It is an absolute privilege to be joining you today for the Fairlife LCC conference to discuss targeting KRAS mutant non-small cell lung cancer. These are my disclosures. KRAS mutations represent the most prevalent oncogenic driver event in non-squamous non-small cell lung cancer, accounting for anywhere from 1 in 4 to 1 in 3 cases. And by far the most prevalent KRAS mutation in non-small cell lung cancer involves the KRAS G12C mutation, which taken together accounts for approximately 1 in 7 patients with non-squamous non-small cell lung cancer. This is a prevalence that is comparable to that of all EGFR mutations taken together in non-small cell lung cancer. Historically, targeting KRAS has been particularly challenging for a number of different reasons, involving primarily the very high affinity of KRAS for its substrate, which is GTP, which makes the development of competitive inhibitors difficult, but also the shape of the KRAS protein, which you can imagine as a large crystal ball with a smooth surface lacking crevices or pockets on which an inhibitor could easily bind. But another third perhaps challenge for the development of successful therapies targeting KRAS has been the inherent and almost pervasive biological heterogeneity of the disease. This means that one patient's tumor is very different from another patient's tumor, despite both of those carrying the same mutation in KRAS. And this is something that my lab has been particularly interested in for a number of years, what determines the biological heterogeneity of KRAS. Some years ago, we identified co-mutations, in other words, mutations not in KRAS itself, but in other genes that happen together with KRAS that define 3 major subgroups of the disease that we now call KC, KL, KP on the basis of mutations in different tumor suppressor genes. And this becomes important because these subgroups are therapeutically relevant. So the big breakthrough in targeting KRAS came in 2013 by Kevin Shokat's group at the University of California in San Francisco, when they identified compounds that could bind to cysteine 12 of KRAS G12C and occupy a previously unrecognized, if you want, a cryptic pocket that is now called the switch to binding pocket. And by binding to these pockets, these inhibitors could lock KRAS into its inactive or GDP bounding form, therefore preventing interactions with downstream effectors and shutting down oncogenic KRAS driven signaling. So today we know that we've got a number of different clinical grade KRAS inhibitors, of which sotorasib is currently the only one that is approved by the FDA and the European Medicines Agency and in over 40 healthcare jurisdictions around the world, based on the results of the CodeBreak 100 clinical trial that I had the privilege to be involved in. In CodeBreak 100, treatment with sotorasib yielded an objective response rate of approximately 37%, with a median duration of response of 11.1 months and a median overall survival of 12.5 months. A different KRAS G12C inhibitor, adagrasib, also got FDA breakthrough therapy designation in June 2021 on the basis of the results of the Crystal-1 clinical trial with comparable efficacy outcomes compared to sotorasib. You can see objective response rate approximately 43%, median overall survival 12.6 months. And most recently, in September 2022, another major milestone was reached with the reporting of the results from the first randomized phase 3 clinical trial comparing sotorasib with docetaxel, which is the standard of care for the second-line treatment of metastatic non-squamous non-small cell lung cancer. So in CodeBreak 200, sotorasib significantly prolonged progression-free survival compared with docetaxel, with a 34% reduction in the risk of disease progression or death. In addition to sotorasib and adagrasib, other KRAS G12C inhibitors currently in clinical development involve JDQ443 in the CONTRAST-01 clinical trial, GDC6036, D1553, and several others that I am not including in this slide. So what are some of the key unanswered questions in this field? Well, the first one is, what are the molecular determinants of KRAS G12C inhibitor efficacy? Can we predict patients who are more or less likely to respond to monotherapy with a KRAS G12C inhibitor? And this is where co-occurring genomic alterations or co-mutations in key tumor suppressor genes may be important, because in both CodeBreak 100 and Crystal-1, a signal emerged that perhaps patients with mutations in KEAP1 are less likely to respond to KRAS G12C inhibitors. This is an area of active study, and you will be hearing more in the following months. A second major challenge is acquired resistance to KRAS G12C inhibitor monotherapy. So this is resistance that emerges after a period of response. And this seminal study by Dr. Awad, published in the New England Journal of Medicine last year, identified three broad mechanisms of acquired resistance to KRAS G12C inhibitors: the acquisition of secondary genomic alterations in KRAS itself, acquisition of genomic alterations in other components of the RTK RAS MAP kinase pathway, as well as lineage switching, so changing the histology of the tumor from an adenocarcinoma to a squamous cell carcinoma, as well as other forms of histological transformation. So in order to enhance the efficacy of KRAS G12C inhibitor monotherapy, but also forestall the development of acquired resistance, one of the most interesting fields is what are the optimal combinations? What are other drugs that we can rationally combine with KRAS G12C inhibitors to achieve improved efficacy? And there are broadly three categories of agents that are being examined in clinical trials. Other targeted therapies that target components either upstream of KRAS or downstream of KRAS in the pathway. Standard of care systemic therapies such as chemotherapy, and obviously immunotherapies with immune checkpoint inhibitors that we know are highly effective in metastatic non-small cell lung cancer. I'm going to highlight one of these combinations with a targeted therapy called RMC-4630, which is a SHP2 inhibitor. This is a phosphatase that acts upstream of KRAS and controls signaling downstream of many receptor tyrosine kinases. So recently, we saw efficacy and safety results from RMC-4630 in combination with sotorasib. This is from one of the sub-protocols of the CodeBreaK 101 clinical trial, and the conclusion was that the combination was feasible, safe, and at least in preliminary results yielded considerable anti-tumor efficacy. We can see with an objective response rate of 50% among KRAS G12C inhibitor naive patients. And the study is actually underway to further characterize the efficacy of safety of this combination. It is also highly relevant to try to combine KRAS G12C inhibitors with immune checkpoint inhibitors. And here we saw results from the combination of sotorasib with either pembrolizumab or atezolizumab. The conclusion was that the combination yielded durable objective responses. You can see that the median duration of response is 17.9 months, which is what we want to achieve. However, this came at the expense of considerable toxicity, and in particular hepatotoxicity. So it is quite important to find the best way, the safest and most effective way to combine immune checkpoint inhibitors with KRAS G12C inhibitors, and sotorasib in particular is being now assessed at a lower dose, 240 milligrams, in combination with pembrolizumab using a lead-in cohort. So first you start with the KRAS G12C inhibitor and you add the immunotherapy after the first cycle. Adagrasib has also been combined with immune checkpoint inhibitors, and this is the CRYSTAL-7 clinical trial, and at least preliminary results suggest that the combination appears to be safe and appears to yield considerable efficacy. So more to follow on this. This brings me to an attempt to bring KRAS G12C inhibitors into earlier disease settings. So the CRYSTAL-7 clinical trial was performed in the first-line setting, patients that have not previously received any treatment for their metastatic disease. And Amgen is also trying to combine sotorasib with chemotherapy in the first-line setting, particularly for the subset of patients with a PD-L1 TPS of less than 1%. These are patients that derive less benefit from immunotherapy. It is also relevant to try to bring KRAS G12C inhibitors into surgically resected disease and in the neoadjuvant setting. So these are tumors that are surgically resectable, not metastatic. And in this context, we have 3 clinical trials currently enrolling. The first one is a study that I'm leading at MD Anderson. Here we are combining sotorasib with platinum doublet chemotherapy prior to surgery. There is a second clinical trial where sotorasib is being used as a single agent, and there is the NeoCant study where adagrasib is being used either on its own or in combination with nivolumab prior to surgical resection. In the last part of my talk, I'm going to refer to emerging novel approaches to target KRAS mutant tumors, and I'm going to highlight 3 different approaches. The first one is to expand the scope of mutant-selective KRAS inhibitors. So we know a lot about KRAS G12C inhibitors, but what about tumors that have got different oncogenic KRAS alleles, such as KRAS G12D, where we now have several efforts to develop mutant selective inhibitors for KRAS G12D, of which one of the most advanced is MRTX1133. This compound, at least preclinically, has demonstrated considerable efficacy in multiple KRAS G12D models of both lung and colorectal cancer, as well as pancreatic cancer. A different approach involves targeting not the inactive state of KRAS, which is what most KRAS G12C inhibitors, both sotorasib and adagrasib, fall into this category too, but try to target the active state of KRAS, KRAS G12C bound to GTP. At least in principle, this approach has got several advantages because it might overcome or it might forestall the development of adaptive resistance. And in this context, these compounds from Revolution Medicine seem promising, at least preclinically. They are now starting to enter the clinical development. And we've got a phase 1 study here at MD Anderson testing RMC-6236, which is a pan-KRAS inhibitor. It targets several different oncogenic KRAS alleles. The final approach is RAS degraders. These are a novel class of agents that actually try to deplete the pool of mutant KRAS. These are bifunctional molecules, and one part of the molecule binds to KRAS. It's got a linker, and then the other part of the molecule brings KRAS into contact with the ubiquitin ligase. These are enzymes that mediate degradation of proteins in the proteasome. So the whole idea here is to make mutant KRAS a substrate for the cell's machinery to degrade proteins and actually extinguish it. So with that, I'm going to briefly mention the key next steps and key areas where further research is underway. So first of all, we need to identify optimal and tailored therapeutic combinations to enhance the efficacy of KRAS G12C inhibitors. We need to identify biomarkers of response to monotherapy and to distinct combinations. How can we best select the optimal combination for the best patient? We need to devise strategies to maximize the immune sensitizing potential of KRAS G12C inhibitors, and we need to optimize combinations with immune checkpoint inhibitors. We need to bring KRAS inhibitors into earlier line settings, first-line metastatic disease, as well as early-stage surgically resectable disease. We need to better understand mechanisms of de novo and acquired resistance, and we need to develop novel and mutant-selective inhibitors, both for KRAS G12C and non-KRAS G12C, including inhibitors that target the active form of KRAS. Finally, new approaches to extinguish oncogenic KRAS proteins, and what I haven't talked about due to time constraints, but novel immunotherapy approaches for KRAS mutant tumors, including vaccines and adoptive cell therapy. With that, I'm going to thank you for your attention.
And now I will invite Mr. Michali Liodo, who is at the University of Athens. Mr. Londos, you have the floor. He's a medical oncologist. Thank you, Mrs. Pateli, for the invitation, and thank you to Fairlife, and thank you for allowing us to come here and talk about the developments in lung cancer. I don't know how to change the slide. So let me start off where the others stopped, because I think that we need to move on to molecular classification of cancer, and this is what will be the subject of the future. We will have specialized doctors dealing with specific mutations. I will talk about the BRAF, HER2, and MET alterations, and as you can see from the diagrams, these are rare mutations. The others we have actually targeted, but for these rare mutations, it's like looking for a needle in a haystack. And it's important to offer hope to patients suffering from these alterations, from these mutations. I'd like to, first of all, talk about the patients. Then I'd like to talk about how important it is to identify the mutations, and also the new therapeutic choices. So let me talk about BRAF mutations. We knew it for its oncogenic action in melanoma, But as you can see from the diagram, in melanomas, we have the BRF 600, it's oncogenic, and we see how it functions. But the same doesn't apply in the case of lung cancer because these mutations only concern a certain percentage. What happens with the other mutations? We know that BRAF genes have 3 categories of mutations. Category 1, this is position B260. So we have MEK inhibitors, BRAF, and we can deal with the second class, but these drugs are not that efficacious. They're not good in the case of class 3. But BRAF mutations are not common in lung cancer. We don't have specific patient characteristics that we can identify. So when we have a multi-NGS panel, we need to check our patients for BRAF because we have 2 studies. One is in combination with tabravevin, and we see that regardless of whether they are naive or whether they've been treated, we have good response and we have an overall increase of survival. We're talking about a population which prognostically was worse off than other cases. And let me talk about BRAF mutations. Many of them coexist with other genetic changes in genes involved in various other cases. And this is something we need to take into account. In combination with other drugs is the future that's out there, particularly those that have non-V600 mutations. Now, in the case of BRAF mutation, we have a combination of drapanovir and tarmanovir. And another category now, we're talking about HER2. We've heard of them from breast cancer. There is here we see the receptor which signals cell proliferation. In the case of lung cancer, we see that genetic reinforcement is rare. We rarely have HER2 mutation. It's exon 20, just like EGFR mentioned by Mr. Lainakis. And sometimes we have overexpression of HER2, but also gene amplification. And this has to do with resistance in the case of patients that have received first therapy with EGFR inhibitors. So what are the recommendations now? All patients that are diagnosed with adenocarcinoma should be evaluated for HR2 mutations. Also, people who have had a relapse must check again to see if there's overexpression or amplification of HER2. Why? Because we have a lot of treatments available for this group of patients. The drugs that have been approved in breast cancer are the Rupsticon. This is additional to HER2, and it has proven to be efficacious in patients with HER2 mutations with exon 20 insertion. And here you can see the response, and we see that the response is over 50% regardless of dose of the agent. However, we have a benefit in others who have overexpression of HER2 that have already received treatment. And here we see which is the best biomarker in order for us to assess the use of the agents in patients with overexpression of lung-2. And this is also approved for HER2 exon 20 insertion mutations. And we also have another one, another conjugate, which has proven to be good in the case of exon 20, and micromolecular inhibitors that work like poziotinib, which is a pan-HER inhibitor, and they are efficacious. And we see that we have over one opportunity that is now being investigated for this group of patients. Let me finish with mutations and amplifications in MET, in the MET gene. So MET mutations have to do with changes in the area around exon 14. So this is lost, which means that this is not decomposed, it's stabilized, and it's constantly activated it keeps sending messages and signals. This happens at a percentage of 3-4% of NSCLC and has a bad prognosis. So here we see MET gene amplification. This occurs in 1 to 6%, but here we also see resistance mechanisms in pretreated patients, and we have capmatinib. This is a selective MAT receptor inhibitor. It was tested in studies for patients with mutations, and there was a study regarding capmatinib, and here we had a gene amplification. So the degree of this amplification was checked, and we saw how the drug could be efficacious, but you need to have over 10 copies in order to have some efficacy. And we also have tepotinib, which is also a selective MET receptor that is very good in patients with mutations, regardless of whether this was in the tumor or through liquid biopsy. So tepotinib has been shown to be efficacious in patients with MET amplification, particularly if it is given early on. Then we have crizotinib. This is an agent we use for ALK and ROS rearrangements. And what we will expect to see in the future is to investigate how MET changes can be included in the mechanism of resistance with the EGFR mutant patients, and where there is resistance to the existing inhibitors. So we have the Andrella, for example, studies where we have osimertinib together with another agent depending on the mutation when resistance is developed. Now we also have a combination of ezetimibe and sapolitinib, and here you can see that there is significant response in the patients where chemotherapy in the past was the only option. Now they have other therapeutic choices. We're talking about second-line therapy in order for them to continue to have a good quality of life and to increase their survival. Thank you very much.
Εμείς σας ευχαριστούμε και να ζητήσω...
Thank you. I would like to ask Mrs. Kondra to take the floor. She is a medical oncologist and senior registrar in Erikos Dinan. Hello. I would also like to thank Fairlife for honoring me with their invitation to take part in today's event. So the landscape with respect to the molecular classification of non-squamous NSCLC is in fact striking. We have discovered a lot of mutations that are very important, and you can see that each of them may account for a small number of patients. However, lung cancer is a very frequent disease, so no matter how small a subgroup is, it is of importance because it involves thousands of patients. And you can see that approximately 50% of patients with advanced non-squamous NSCLC have a driver mutation that may be targeted by an FDA-approved agent. And most of these agents have also been approved by the EMA. So I would like to mention rather ROS1 rearrangement. This is rather rare, and it is detected in approximately 1% of NSCLCs. And it is even rarer in squamous disease. It usually involves people who have never smoked. Now, there was this drug, this agent crizotinib, that was known to us, and it delivered significant success rates. We have a medial survival with no progression of disease that is very important. And you know, for most patients are still alive after 4 years' time. The rate is 51%. Also, you can see the figures on screen. The difference between entrectinib and crizotinib is that there are different rates with respect to PFS and ORR. And you can see that crizotinib is effective, and currently it is recommended that patients may be given crizotinib or entrectinib at first, whereas lorlatinib is recommended as a second line of treatment for patients previously treated with crizotinib. The most common adverse events is visual disorders, whereas entrectinib is associated with weight gain. So currently there is a study, a phase 3 study for patients with locally advanced or metastatic ROS1 fusion positive NSCLC with or without baseline CNS metastasis. We're waiting for the results. Another rare molecular alteration is mostly detected in lung adenocarcinoma, and it's RET rearrangement. You can see that many different agents known from other types of cancer have been proven successful. However, I will talk about selpercatinib because a phase 2 study involving many different countries across the globe delivered very good results. In fact, the ORR was 85% among the treatment-naive patients, and even in pre-treated patients, the rates were very good. The same applies to pralsetinib. The phase 1-2 study delivered very good results. It was shown to be effective in patients previously treated with either chemotherapy or immunotherapy. And you can see that the response rates are very, very high in brain tumors. Among the side effects, please keep in mind that both agents are linked to increased transaminases, hepatotoxicity, and selpercatinib may also prolong the QT interval. So these side effects must be known so that we can effectively monitor our patients. We have phase 3 studies that are underway. For example, we have the Accelerate study that compares pralsetinib to platinum-based chemo. Also, there is the other study comparing it with when combined with immunotherapy and not. In closing, you can see that the NTRK rearrangements and TRK fusions may be identified in different types of cancer. With respect to lung cancer, this is detected in less than 1% of patients, and we have two well-known agents, larotrectinib and entrectinib. The response rates are 75% and 70% respectively in NSCLC, and the results are similar between adults and minors. Patients with a brain metastasis have been shown to respond less to these agents. You can see an example of a 2-year-old baby suffering from sarcoma. There was complete pathologic remission. And I would like to also talk about resistance with respect to these first-generation inhibitors. When there is no response at all, we must suspect that there may be a false positive result. In case where we have minor progress, we can locally treat the disease and continue with the same inhibitor. However, when the disease progresses, then if resistance is on target, meaning we have different mutations detected, we can continue either inhibitor, and when the resistance is off target, we will usually detect KRAS metastasis. So after larotrectinib, we can administer repotrectinib or merestinib or foretinib. In conclusion, targeted therapies have led to spectacular improvement in prognosis among patients with driver mutations. There are studies underway for preoperative treatment, adjuvant treatment, and combination treatments. It's important to have molecular testing for all patients for whom it is indicated. So we have longer response rates, and this is very important. And these agents are now administered in earlier stages of the disease. We're still waiting for results of further studies, but I think that we have, through this presentation, highlighted how important it is to have molecular testing. And I think that a customized approach to lung cancer is mandated by both science and ethics. Thank you.
Ευχαριστούμε πολύ. Κυρία Χατζιανδρέου.
Thank you very much, Mrs. Hanziandreu. You have the floor. I will speak very quickly, and I will try to speak in a simple way. We heard a lot about targeted treatment, about the molecular profile of the tumor, the need thereof, the inhibitors. So all this makes us optimistic. But I'd like to talk about something that's linked to the reason why this conference is being held, and I'm talking about clinical studies. I will talk about TILs, tumor-infiltrating lymphocytes, in NSCLC lung cancer. So we want to strengthen the immune system so that the immune system can fight cancer and fight the tumors. This means that the lymphocytes that have reached the tumor recognize the antigens and start doing their job, which is to kill off the cancer cells. But not all lymphocytes reach the tumor, and those that do reach the tumor may not all identify or recognize the antigens, and that's why we talk about personalized treatment. But TILs, the tumor-infiltrating lymphocytes, enter solid tumors, and in cases such as lung cancer, they may recognize multiple antigens, so they can effectively attack the tumor. So what is the TIL therapy exactly? They collected from a tumor specimen. They are proliferated in the lab, and then they are injected back into the patient. And the first results are very promising, mainly in the case of melanoma, but slowly we see that there are specific studies that are underway for cervical cancer, head and neck cancer, and also for non-small cell lung cancer. And because all the slides are available after the Fairlife event, I want to be very brief and I want to show you what happens. So we go to the tumor, we resect it in order to find which lymphocytes have already entered it and are trying to fight the tumor. So here you can see that in the case of lung cancer, you have lots of lymphocytes for a specific tumor. They go to the lab, they are actually strengthened, and then the preparation is available. So here we have two very interesting references in the bibliography. These are very detailed, so I'm going to actually rush forward. This is not a simple process. We need to have the resection, then we need to prep with enzymes. We need to multiply these, if you like, cells. It takes around 6 weeks, and then they inject it back into the patient. But these are the cells that have already shown the ability to fight the specific tumor in the specific patient. And of course, we have a lot of challenges to overcome. So we're trying to resolve all these challenges, i.e. not being able to resect the tumor, the center that will actually do this, because we want them to do the job correctly. We already heard a lot about inhibitors. Another very promising field is the combination of TILs with inhibitors, so that the therapy is even more efficacious. And here we see some slides for those that are interested, meaning what the combinations can be, meaning which inhibitors can be combined with TILs so that there can be co-administration. This is a very recent study. It's 2022 for lung cancer. And here you can see what experience shows us and what theory tells us about the efficacious use of TILs in lung cancer. 4 conclusions. So we're talking about cell therapy, the immunogenic microenvironment of the lung cancer renders it a potential candidate for such therapies. Up until now, we don't have decisive results as to the safety and efficacy of this TIL therapy. So we believe it is promising, and we know that we can also combine TIL therapy with other immunotherapies. So lots of clinical studies are underway outside Greece with TILs. Why is it difficult? Because it's a difficult, time-consuming process. It is expensive, as I said, and time-consuming, so we have high cost. We also know that because it's time-consuming, the lymphocytes may stop being that functional, and also because it's done in central facilities, it takes time, and the patient may have deteriorated. So what are the key challenges? We need to find answers. We need to have solutions that are cost-effective. We want to be able to find ways to further strengthen the efficacy of TILs, and mainly to be able to produce them close to the patient. So manufacturing decentralized near the patient bedside in order for us to have a rapid response and increased efficacy. So a biotech company here in Greece is trying to do just that. We are trying to produce at a low cost these TILs, and we will begin in 2023 in the first half. We will begin a first clinical trial on lung cancer. We're talking about NSCLC with specimens in order for us to produce TILs in a decentralized manner. The trial will be in Greece and Israel, and then we will actually submit an application for authorization, market authorization, and we might expand this therapy to other types of cancer. This is the synopsis. It's a phase 1 and 2 clinical study with a 12-month follow-up. And we will begin with 15 patients. And we hope in specialized centers with 2 hospitals already in Greece. So we hope we will begin in 2023. And I think this will be the first time that we will have production of such treatment, with the exception of Papanikolaou and Elpida. So we're talking about production in Greece as well. And the clinical study will be also in Greece. We base ourselves on the innovation that exists together with a biotech company that is listed in the US. So what you see is a container. It is closed loop. And here we have the production of TILs. And we're talking about billions of TILs that will be produced and then injected. And this will be only an hour or half an hour away from the hospital. And the cost will be 30% to 60% or 70% less than the existing cost. So we're talking about point of care technology, point of care therapies, point of care network. So we believe that this will be disruptive, innovative, but it will change the situation radically in Greece, and we will actually give this impetus so that these clinical studies can also start in Greece. Now, our plan, as I said, is to begin in 2023 and actually then continue with more patients, 70 patients approximately. So in 3 years, we hope that we will receive the first license to manufacture immunotherapy, the first such license in Greece, the first license produced in Greece and tested on Greek patients. Thank you very much.
How to say disruptive in Greek? Good question. So, Ms. Katsaounou, a deputy professor of pulmonology at the Athens University. The floor is yours.
Και στην πνευμονολογική κλινική τον πρώτο χρόνο της θητείας μου θυμάμαι...
You know, I remember vividly during my term of office having lost many patients within a single year. But in light of the new techniques in lung cancer, we can be very optimistic. However, we must all make efforts, both the state, and you help in this direction, and all of us, we must have NGS techniques accessible and actually do that fast. This will help us diagnose our patients and provide them with the most effective treatment. So prevention and early diagnosis are also important. We talk about early diagnosis because then this combined with treatment will be even more disruptive. And also we know that patients who are diagnosed and yet continue to smoke, so we must note that even after diagnosis, smoking cessation will increase survival by many months. So I think that all of these messages must be shared because these patients are not doomed. Lung cancer will become a chronic disease. Yes, I think that seeing you smile and taking note of your last comment, your last phrase, well, it's inspiring, particularly to all of us who are not familiar with all details of your clinical studies and advancements. Now, Ms. Battistatou, Professor of Pathology at the University of Ioannina, will take the floor. She's with us online. Hello, thank you for inviting me. It is indeed with great pleasure that I've been monitoring this conference. I've been watching you all since this morning. I've had some very impressive presentations that have clearly reflected Greek reality. And the reality is that there have been leaps in lung cancer treatment.
Και όπως είδατε υπάρχουν καινούργιες μελέτες.
And there are also new studies highlighting NGS, as previously mentioned. And these studies are very impressive, but we must never forget that they're based on the testing of biomarkers. Therefore, we must insist on having reliable biomarker testing. And this must be made on all patients. So we must have histology for liquid biopsy purposes, because this will allow us to have appropriate treatment. I want you to keep this in mind. The basis is the patient's sample, the patient's material. And then we must be able to take the sample and keep it in order to get optimal results. Thank you. Dear Mr. Bukovinas, nice to see you. Mr. Bukovinas is an oncologist and also the scientific head of the oncology unit in BioClinic Thessaloniki. Can you hear me? Yes, good. Indeed, this conference has so far been very impressive. I would like to warmly congratulate Ms. Patelli because she introduces newcomers to our field. And also, she makes efforts to raise awareness among the public. I think that all commentators have clearly said that innovation is very, very helpful because it prolongs the life of our lung cancer patients. Also clear is that changes in law, mostly in the States, have been the result of identifying the need for fast access to new treatments, focusing on specific populations. This is the so-called fast-track process introduced by FDA, and this underlines the importance for the EU to follow this lead. Also, there is high heterogeneity among lung cancer patients, and this gives rise to the question, why is that? Well, when a medication comes to the EU or Greece after 2 or 3 years, you can all realize how much valuable time is lost. So we must stand together as citizens and join our efforts to make things change so as to allow essential medicines, novel agents to enter the Greek market. Thank you. Thank you, Mr. Bukovinas. Now, Mr. Samadas, an oncologist in the second oncology clinic of Metropolitan. I think you're with us online. Hi, nice to see you. Nice to see you too, Ms. Papadimitriou. I would also like to thank Ms. Corina Bell and Fairlife for kindly inviting me to this exceptional conference. After listening to all 6 colleagues who presented data on therapies that target rare mutations, they did not talk about the most frequent mutations. I have some conclusions to share. You know, actually, 50% of lung cancer patients have a mutation for which agents targeting it are available. What does that mean? It means that all of our patients with metastatic lung cancer should have access to NGS, next generation sequencing. This analysis will allow us to identify the most frequent and most rare mutations, because this will imply greater survival rates and better quality of life. Also, these mutations do not only involve metastatic patients. We know very well that even patients in the earlier stages of disease can benefit from targeted medication as add-on therapy following surgery or chemo. For example, EGFR mutation patients will benefit from add-on therapy. Therefore, even patients in the earlier stages of disease must have access to NGS. And thankfully, the EGFR mutation screening is for free. And it's up to the Greek state to allow patients with NSCLC to have access to these techniques. Thank you very much. Thank you. I would like to thank all panelists and commentators. Now it's time for us to take the first break for 30 minutes. So please be back at 10 minutes to 3. Thank you.
Η Fairlife είναι ο πρώτος μη κερδοσκοπικός κοινωνικός φορέας στην Ελλάδα που ασχολείται αποκλειστικά με τον καρκίνο του πνεύμονα. Ο Σάιμον Μπέλ έχασε τη μάχη με την νόσο και η επιθυμία του για μια δίκαιη ζωή των ασθενών έγινε πράξη από τη σύζυγό του Κορίνα Πατέλη Μπέλ με την ίδρυση της Fairlife τον Νοέμβριο του 2020.
Ο καρκίνος του πνεύμονα μας αφορά όλους.
Στόχος, η ανάληψη δράσεων που θα έδιναν πνοή στο όραμά του, διαδίδοντας το μήνυμα «Η ζωή να κόβει την ανάσα, όχι ο καρκίνος του πνεύμονα». Η Fairlife απαρτίζεται από μια ομάδα που εργάζεται δυναμικά, αναδεικνύοντας τη σημασία του προληπτικού ελέγχου, της έγκαιρης διάγνωσης και της ισότιμης πρόσβασης των ασθενών σε νέες θεραπείες, καθώς και κλινικές μελέτες. Τη Fairlife αγκάλιασαν από την πρώτη στιγμή η ιατρική κοινότητα, επιστημονικοί φορείς, φαρμακευτικές εταιρείες, καθώς και τοπικοί φορείς. Είναι μέλος ελληνικών και διεθνών φορέων για την προαγωγή δικαιωμάτων των ασθενών. Τις δράσεις της υποστηρίζουν πάνω από 70 επαγγελματίες υγείας από την Ελλάδα και το εξωτερικό. Το έργο της αναγνωρίζεται και βραβεύεται. Η Fairlife μεγαλώνει. Αποκτά εκατοντάδες συνοδοιπόρους και πρεσβευτές.
Ας γίνουμε η γενιά που θα φέρει την ουσιαστική αλλαγή.
Η επιλογή είναι δική σου.
Με πολλαπλές δράσεις ενημερώνουμε, προλαμβάνουμε, στηρίζουμε. Συμμετοχή σε ημερίδες και συνέδρια.
Fairlife was born to fill a gap.
Θεματικά webinars και οργάνωση ημερίδων. Ψηφιακή ενημερωτική βιβλιοθήκη «Μαθαίνω, ενεργώ, ελπίζω». Ενημερωτικές εκπομπές 14 λεπτά ζωής. Δράσεις ευαισθητοποίησης νέων. Η Fairlife συναντά τα παιδιά στα σχολεία μέσα από ενημερωτικές δράσεις, καμπάνιες και μαθητικούς διαγωνισμούς. Δράσεις ευεξίας.
Καθαροί πνεύμονες, ελεύθερη ζωή.
Ο Χρήστος και η Fairlife τερματίσματα 5 χιλιόμετρα. Μπράβο, μπράβο.
Πενταψήφια γραμμή ενημέρωσης 11157 και το δωρεάν πρόγραμμα ψυχοκοινωνικής υποστήριξης Breath σε συνεργασία με έμπειρους και εξειδικευμένους επαγγελματίες υγείας από αναγνωρισμένους φορείς.
Η ζωή να κόβει την ανάσα.
Οι ασθενείς που νοσούν με καρκίνο βιώνουν ένα μοναχικό ταξίδι, όπως και οι φροντιστές τους. Χρειάζονται ενδυνάμωση, ψυχολογική υποστήριξη, κατανόηση και σεβασμό.
Η Fairlife διεκδικεί ίσες ευκαιρίες για όσους βιώνουν τον καρκίνο του πνεύμονα χωρίς στιγματισμούς.
Η Fairlife βρίσκεται δίπλα τους, ενημερώνοντας το κοινό, στηρίζοντας όλους όσοι έχει αγγίξει ο καρκίνος του πνεύμονα. Τους το οφείλουμε. Και αυτή είναι η υπόσχεση της Fairlife για μια δίκαιη ζωή.
Εύχομαι κανένα παιδί του κόσμου να μην χάσει το γονιό του από το καρκίνο του πνεύμονα. Η πρόληψη σώζει ζωές.
Fairlife. Η ζωή να κόβει την ανάσα, όχι ο καρκίνος του πνεύμονα.
Οι ασθενείς με καρκίνο του πνεύμονα αντιμετωπίζουν μεταξύ άλλων και το στίγμα γύρω από την ασθένεια, κυρίως επειδή θεωρείται μία νόσος που θα μπορούσε να αποφευχθεί. Η πλειοψηφία των καρκίνων του πνεύμονα συνδέεται πράγματι με το κάπνισμα. 8 στα 10 άτομα που νοσούν με καρκίνο του πνεύμονα είναι καπνιστές ή πρώην καπνιστές. Είναι όμως σημαντικό να γνωρίζουμε, σύμφωνα και με πρόσφατες έρευνες, ότι το 15% των ασθενών με καρκίνο του πνεύμονα δεν κάπνισαν ποτέ και το 35% είχε διακόψει το κάπνισμα πριν από τη διάγνωση. Ο σύζυγός μου Σάιμον, που μας ενέπνευσε να δημιουργήσουμε τη Fairlife, νόσησε από τον καρκίνο του πνεύμονα σε ηλικία 56 ετών, ενώ είχε διακόψει το τσιγάρο από την ηλικία των 42 ετών. Ο Σάιμον δυστυχώς έχασε τη μάχη με τον καρκίνο του πνεύμονα τον Αύγουστο του 2020 και σήμερα η Fairlife στηρίζει όποιον βιώνει την ασθένεια, αλλά και την οικογένειά του που στέκεται δίπλα του. Πάντα με κατανόηση και ενσυναίσθηση. Δεν ξεχνώ όμως το πόσο άβολα και ενοχικά ένιωθε ο σύζυγός μου όταν το ρωτούσαν διαρκώς κατά τη διάρκεια της νόσου «Καπνίζατε? Πολύ? Πότε το κόψατε?» Ένιωθε υπεύθυνος για το δικό του καρκίνο. Το στίγμα δυστυχώς το κουβαλούσε μαζί του καθημερινά μέχρι που έφυγε ανήμπορος στο δωμάτιο ενός νοσοκομείου. Το στίγμα δεν έχει και δεν πρέπει να έχει θέση σε μια δίκαιη κοινωνία όπου η περίθαλψη με ίσους όρους είναι δικαίωμα όλων μας. Όλοι οι ασθενείς με καρκίνο του πνεύμονα αξίζουν φροντίδα και συμπόνια. Είτε καπνίζουν, είτε κάπνιζαν στο παρελθόν, είτε δεν έχουν δοκιμάσει ποτέ το τσιγάρο. Αξίζουν να έχουν την ίδια ευκαιρία στη ζωή με κάθε άλλον που αντιμετωπίζει μία απειλητική νόσο για τη ζωή του. Όπως προδίδει και το όνομά μας, στη Fairlife διεκδικούμε μία δίκαιη ζωή για τον ασθενή. Δίκαιη με έγκαιρη και καθολική πρόσβαση στην πληροφορία, στην ενημέρωση, στις διαγνωστικές εξετάσεις, αλλά και στις καινοτόμες νέες θεραπείες. Η Fairlife διεκδικεί ίσες ευκαιρίες για όσους βιώνουν τον καρκίνο του πνεύμονα χωρίς στιγματισμούς. Είναι τιμή μας λοιπόν να τρέξουμε στην Ελλάδα μια διεθνή καμπάνια για το στίγμα που έλαβε χώρα με καλά αποτελέσματα στον Καναδά και στην Αυστραλία. Όλοι μαζί μπορούμε να μεταφέρουμε το μήνυμα ότι το στίγμα δεν αφορά κανέναν. Δεν αφορά τον συνάνθρωπό μας που νοσεί με καρκίνο του πνεύμονα, δεν αφορά την οικογένειά του. Πολλά ερωτήματα πρέπει να απαντηθούν. Ερωτήματα που στοχεύουν στην εξάλειψη του καρκίνου του πνεύμονα, που αποτελεί μια μάστιγα, μια τωρινή πανδημία για την κοινωνία μας. Ας μην ξεχνάμε ότι όποιος έχει πνεύμονες μπορεί να εμφανίσει καρκίνο του πνεύμονα.
Το να διαγνωστεί κάποιος με καρκίνο του πνεύμονα είναι μια δυσκολονόητη και δυσάρεστη εμπειρία που προκαλεί σωρία αρνητικών συναισθημάτων όπως δυσπιστία, άγχος, φόβο, θυμό, θλίψη. Το πιο σημαντικό βήμα στη διαχείριση και αντιμετώπιση τους είναι να ζητήσει και να αποδεχθεί κανείς τη βοήθεια των άλλων.
Ο κάθε άνθρωπος που θα διαγνωστεί με καρκίνο του πνεύμονα θα χρειαστεί κάποια μορφή βοήθειας. Είτε ψυχολογική, είτε πνευματική, είτε κοινωνική υποστήριξη, καθώς και βοήθεια στην επίλυση πρακτικών θεμάτων της καθημερινότητας. Η στήριξη αυτή μπορεί απλά να έρθει από την οικογένεια, το συγγενικό περιβάλλον, τους αγαπημένους φίλους, το πνευματικό του και γενικότερα την κοινότητα, ή μπορεί να είναι πιο εξειδικευμένη από εκπαιδευμένους επαγγελματίες υγείας, όπως είναι οι ψυχολόγοι, οι ψυχίατροι, η κοινωνική λειτουργοί και άλλοι. Επιπλέον, η στήριξη μπορεί να παρέχεται εξατομικευμένα ή μέσα από ομάδες στήριξης, τα λεγόμενα support groups, ή διαδικτυακές κοινότητες, όπως αυτά διαμορφώνονται από προγράμματα ψυχοκοινωνικής υποστήριξης υπό την αιγίδα εθελοντικών οργανισμών. Αναγνωρίζοντας τον άνθρωπο ως ψυχοσωματική οντότητα, καλούμαστε να φροντίσουμε τις ανάγκες τους στο σύνολό τους. Οι ανάγκες αυτές καθορίζονται από όλα εκείνα τα οποία ο ασθενής κουβαλάει, θα μπορούσαμε να πούμε, μαζί του τη στιγμή της διάγνωσης, όπως για παράδειγμα η ιδιοσυγκρασία του, η προσωπικότητα, τα ήθη του, η νοοτροπία, οι πνευματικές και φιλοσοφικές του πεποιθήσεις. Αυτό που είναι κοινό και πολύ σημαντικό για όποιον βρίσκεται αντιμέτωπος με τον καρκίνο του πνεύμονα είναι να συνδέεται και να επικοινωνεί με τους άλλους ανθρώπους. Για να γίνει αυτό, ο άνθρωπος πρέπει να έχει αρκετή αυτογνωσία, ώστε να ξέρει πότε είναι η κατάλληλη στιγμή για να ζητήσει βοήθεια. Αυτό, όπως καταλαβαίνετε, είναι μια πολύπλοκη διαδικασία, γιατί θα πρέπει να συλλέξει πληροφορίες, να οργανώσει τα συναισθήματά του, να εξασφαλίσει ένα κύκλο υποστηρικτών που εμπιστεύεται, ώστε να μπορέσει να ανταπεξέλθει σε αυτή τη δοκιμασία. Η διαχείριση της διάγνωσης του καρκίνου του πνεύμονα δεν είναι απλά άλλη μια εκκρεμότητα που προστίθεται στα υπόλοιπα που έχουμε να κάνουμε, μια υπενθύμηση, αν θέλετε, ένα τικ στο ημερολόγιό μας. Ουσιαστικά είναι η εκκρεμότητα. Κυριαρχεί πάνω σε όλες τις πτυχές της ζωής, συχνά τις επισκιάζει και απαιτεί τεράστιο κόπο και ενέργεια.
Αν και η στήριξη από τους φίλους και το οικογενειακό περιβάλλον είναι ένα πολύ θετικό βήμα, υπάρχουν ορισμένες ενδείξεις, κάποια προειδοποιητικά σημάδια που υποδεικνύουν ότι είναι καιρός να αναζητήσει κανείς τη βοήθεια ενός επαγγελματία ψυχικής υγείας.
Υπάρχουν πολλά σωματικά και ψυχικά συμπτώματα που δείχνουν πως ο ασθενής βιώνει πολύ υψηλά επίπεδα στρες και άγχους ή άλλες συναισθηματικές και ψυχικές δυσκολίες. Μπορεί, για παράδειγμα, κάποιος να δυσκολεύεται να κοιμηθεί ή να ξυπνάει κατά τη διάρκεια της νύχτας, να τρώει πολύ περισσότερο ή πολύ λιγότερο από το συνηθισμένο, να αισθάνεται νευρικότητα και υπερένταση, να δυσκολεύεται να οργανώσει τις σκέψεις του, να πάρει αποφάσεις, να ακούσει πληροφορίες σχετικά με τη θεραπεία ή τις εξετάσεις του. Αυτές είναι ενδείξεις, καμπανάκια θα λέγαμε, τόσο για την οικογένεια και τους φροντιστές, όσο και για τον ογκολόγο και την επιστημονική ομάδα, ότι ο ασθενής μάλλον χρειάζεται πιο εξειδικευμένη συναισθηματική και ψυχολογική υποστήριξη. Με τον ίδιο δηλαδή τρόπο που ασχολούμαστε και παρέχουμε ανακούφιση για τα σωματικά συμπτώματα, όπως η ναυτία και ο πόνος, είναι σημαντικό να αντιμετωπίσουμε και τα ψυχολογικά συμπτώματα, όπως το άγχος και η κατάθλιψη που συχνά συνοδεύουν τον καρκίνο του πνεύμονα.
Συχνά οι ογκολόγοι συζητούν με τους ασθενείς τους για ζητήματα που σχετίζονται με την ψυχολογία τους. Αν ένας ασθενής αισθάνεται ότι χρειάζεται επιπλέον συναισθηματική βοήθεια και ψυχολογική υποστήριξη, καλό είναι να επικοινωνήσει άμεσα με οποιοδήποτε μέλος της επιστημονικής ομάδας και με τους φροντιστές του για να λάβει την κατάλληλη στήριξη.
Οι περισσότεροι ασθενείς έχουν ισχυρή σύνδεση με τον ογκολόγο τους και ευχής έργο είναι και ο ογκολόγος να έχει την ετοιμότητα να παραπέμψει και ο ασθενής να έχει την άνεση να ζητήσει μια σύσταση ή παραπομπή, είτε σε κάποιο ψυχολόγο, ψυχίατρο ή κοινωνικό λειτουργό, για να λάβει βοήθεια. Κάποιοι άλλοι ασθενείς μπορεί να αισθάνονται πιο άνετα να προσεγγίσουν άλλα άτομα στην ομάδα που τους φροντίζει, όπως νοσηλευτές, γιατρούς άλλης ειδικότητας για σύσταση ή παραπομπή. Μπορεί ακόμη να μην μπορούν να εκφράσουν ρητά την ανάγκη τους για παροχή ψυχολογικής στήριξης, αλλά η όλη τους συμπεριφορά να δηλώνει έμεσα την ανάγκη τους και αυτό είναι κάτι που πρέπει να αναγνωρίσει άμεσα και έγκαιρα η επιστημονική ομάδα.
Υπάρχουν σταθμοί και ορόσημα στην ογκολογική πορεία των ασθενών που έχουν καταφέρει να επιβιώσουν από τον καρκίνο του πνεύμονα, οι λεγόμενοι survivors, κατά τα οποία αισθάνονται πιο ευάλωτοι και στρεσαρισμένοι. Τέτοια ορόσημα θεωρούνται η ολοκλήρωση της θεραπείας, η επέτειος της διάγνωσής τους, η αναμονή για τα αποτελέσματα επαναληπτικών εξετάσεων ή η περίπτωση υποτροπής και επανεμφάνισης του καρκίνου. Η κατάλληλη και έγκαιρη επαγγελματική υποστήριξη σε αυτούς τους σταθμούς μπορεί να βοηθήσει σημαντικά τόσο τον ασθενή όσο και την οικογένειά του.
Μέσα από πολυετείς κλινικές μελέτες γνωρίζουμε πλέον πως οι έγκαιρες παρεμβάσεις για τη βελτιστοποίηση της ψυχικής υγείας βοηθούν τους ασθενείς να ανταπεξέλθουν. Είναι ιδιαίτερα σημαντικό να αναγνωρίσουμε ότι η ανάγκη για παρέμβαση προχωράει και πέρα από τη διάγνωση και τη θεραπεία. Γνωρίζουμε, για παράδειγμα, πως οι επιβιώσαντες από καρκίνο αντιμετωπίζουν εξαιρετικό στρες πριν από την επανασταδιοποίησή τους με απεικονιστικές εξετάσεις, είτε την επανένταξή τους στο κοινωνικό σύνολο, το εργασιακό και κοινωνικό περιβάλλον και συνεχίζουν να έχουν έναν αδιάκοπο φόβο μιας πιθανής υποτροπής. Αντιμετωπίζουν, αν θέλετε, ένα μετατραυματικό στρες, όπως για παράδειγμα στρατιώτες μετά τη μάχη. Χρειαζόμαστε λοιπόν κάθε δυνατό τρόπο υποστήριξης, αξιοποιώντας όλο το ανθρώπινο δυναμικό, προκειμένου να συνοδοιπορούμε με τον ασθενή μας στο μαραθώνιο που λέγεται καρκίνος του πνεύμονα.
Η ενότητα Μαθαίνω, Ενεργώ, Ελπίζω έχει στόχο αφενός την πρόληψη και αφετέρου τη γνώση για κάθε στάδιο του καρκίνου του πνεύμονα που διανύει ένας ασθενής.
Πάνω από 70 επιστήμονες από την Ελλάδα και το εξωτερικό απαντούν σε όλα εκείνα τα ερωτήματα που απασχολούν τους ασθενείς και τους οικείους τους.
Ενημερώνουμε, προλαμβάνουμε, στηρίζουμε.
Δημιουργεί μια νέα πηγή έγκυρης και ουσιαστικής ενημέρωσης. Μαθαίνω, ενεργώ, ελπίζω.
Η ζωή να κόβει την ανάσα και όχι ο καρκίνος του πνεύμονα.
Ενημερώσου τώρα. Η Fairlife είναι εδώ για σένα.
Είναι η νέα σειρά ενημερωτικών εκπομπών της Fairlife που έχει ως στόχο την ενημέρωση και την ευαισθητοποίηση του κοινού για την πρόληψη και θεραπεία του καρκίνου του πνεύμονα.
Εισπνέω, εκπνέω, αλλά δεν αναπνέω. Η επιλογή είναι μέσα σου.
Είμαστε η νέα γενιά με όραμα και στόχους.
Η ζωή δεν μετριέται με αναπνοές, αλλά με στιγμές που σου κόβουν την ανάσα και σε συνεπαίρουνε.
Ας έχουμε μια ζωή χωρίς καπνούς να σκεπάζουν τα όνειρά μας.
Εισπνέω, εκπνέω, μα δεν αναπνέω.
Το κάπνισμα είναι ένα παιχνίδι στο οποίο πάντα χάνεις.
Κάνε μια ξεκάθαρη επιλογή. Καθαροί πνεύμονες, ελεύθερη ζωή.
Μην ανάβεις τσιγάρο. Άναψε τα όνειρά σου.
Με τα μάτια των παιδιών. Ένα κοινό όραμα, ένας κόσμος χωρίς καρκίνο του πνεύμονα μέσα από τα μάτια των παιδιών.
Κομμένη μαγιά γιατί θα πέσει στη σκλαβιά.
Όσο και αν καπνίσεις, δεν θα ξεχωρίσεις.
Είσαι μάγκας. Κάνε τη διαφορά. Πες όχι στο κάπνισμα.
Μη μου στερείς το δικαίωμα να αναπνέω ελεύθερα.
Πάρε μια ανάσα χωρίς να καπνίζεις.
Ας διαφοροποιηθούμε. Ας γίνουμε η γενιά που θα φέρει την ουσιαστική αλλαγή.
Ας αποφασίσουμε να κληρονομήσουμε τη ζωή. Πίσω από τον κρίζο του καπνού υπάρχει μια υγιής, αυτοματιστή ζωή.
Εισπνέω,
Εκπνέω.
Μα δεν αναπνέω.
Η επιλογή είναι μέσα σου.
Εισπνέω, εκπνέω, μα δεν αναπνέω. Η επιλογή είναι μέσα σου.
Πλέον ακούμε βήχα και σκεφτόμαστε αυτόματα τον COVID. Ωστόσο, ένας επίμονος βήχας που διαρκεί 3 ή παραπάνω εβδομάδες μπορεί να είναι επίσης σύμπτωμα καρκίνου του πνεύμονα. Ένας επίμονος βήχας ή ένας βήχας που χειροτερεύει είναι μόλις ένα από τα συμπτώματα του καρκίνου του πνεύμονα. Τα πιο συνηθισμένα συμπτώματα καρκίνου του πνεύμονα περιλαμβάνουν δύσπνοια, συχνές λοιμώξεις του αναπνευστικού, επίμονη κούραση ή έλλειψη ενέργειας, πόνο κατά την αναπνοή ή τον βήχα, αίμα στον βήχα ή στο φλέμμα, έλλειψη όρεξης ή ανεξήγητη απώλεια βάρους. Υπάρχουν κι άλλα λιγότερο συνηθισμένα συμπτώματα του καρκίνου του πνεύμονα. Περιλαμβάνουν πόνο στο θώρακα ή τον ώμο, βράχνισμα, συρριγμό αναπνοής, είδημα στο πρόσωπο ή τον λαιμό, δυσκολία στην κατάποση, πληκτροδακτυλία. Κάποιοι εμφανίζουν ένα μόνο σύμπτωμα, ενώ άλλοι ίσως έχουν περισσότερα. Αν έχετε οποιοδήποτε από αυτά τα συμπτώματα, πρέπει να επικοινωνήσετε με τον πνευμονολόγο σας. Αν δεν αισθάνεστε καλά ή ανησυχείτε, θα πρέπει να τον επισκεφτείτε. Κατά πάσα πιθανότητα, όλα θα είναι μια χαρά. Αν όμως είναι καρκίνος του πνεύμονα, όσο πιο γρήγορα γίνει η διάγνωση, τόσο το καλύτερο. Πριν το ραντεβού σας, σημειώστε όλα σας τα συμπτώματα, πόσο συχνά εμφανίζονται και τον αντίκτυπο που έχουν στη σωματική και ψυχική σας υγεία. Έτσι, θα δώσετε στο γιατρό σας ολοκληρωμένη εικόνα. Το σύστημα καταγραφής συμπτωμάτων μας μπορεί να βοηθήσει σε αυτό. Ο πνευμονολόγος σας θα αξιολογήσει τα συμπτώματα και το ιστορικό σας και θα σας κλείσει ραντεβού για αξονική τομογραφία θώρακος. Αν δεν το κάνει και εσείς ανησυχείτε ακόμη ή συνεχίζετε να έχετε συμπτώματα, μη φοβηθείτε να ξαναπάτε και να ζητήσετε να κάνετε αξονική τομογραφία θώρακος. Να θυμάστε πως αν έχετε πνεύμονες, μπορεί να πάθετε καρκίνο του πνεύμονα. Εάν έχετε κάποιο από αυτά τα συμπτώματα, επικοινωνήστε με τον γιατρό σας το συντομότερο δυνατό. Η γρήγορη διάγνωση του καρκίνου μπορεί να σας σώσει τη ζωή. Η ζωή να κόβει την ανάσα και όχι ο καρκίνος του πνεύμονα.
Τα 4 λεπτά για την αγάπη του παιχνιδιού. 14 λεπτά σκέιτ για να κόβει ανάση τη ζωή και όχι καρκίνο στο πνεύμα. «14 λεπτά για το πάτσμα». Μετά από καθημερινό διάβασμα, 14 λεπτά με τους φίλους μου είναι αυτό που μου δίνει χαρά. Κάπνισμα ή άτμισμα? Όχι. Προτιμώ 14 λεπτά δικά μου.
14 λεπτά κάνοντας ρόλερ για να κόβει η ζωή την ανάσα και όχι το τσιγάρο.
14 λεπτά βόλτα με το ποδήλατο. Πατάμε φρένο στον καρκίνο.
14 λεπτά διαβάζοντας το αγαπημένο μου βιβλίο για να κόβει η ζωή την ανάσα και όχι καρκίνο στο πνεύμα.
I'd rather spend 14 minutes of my life doing this.
Μετά από μια δύσκολη και κουραστική μέρα, 14 λεπτά παιχνιδιού με τη Λίλη είναι ακριβώς ό,τι χρειάζομαι.
Όσα ξέρεις αλήθεια για το άτμισμα.
Εύχομαι κανένα παιδί του κόσμου να μην χάσει το γονιό του από το καρκίνο του πνεύμονα.
Η ζωή να
COVID.
την ανάσα
Και όχι ο καρκίνος του
πνεύμονα.
Εγώ σήμερα υπάρχω γιατί πρόλαβα. Άργησα λίγο, αλλά πρόλαβα. Βίωσα το θαύμα της επιστήμης.
Η μέρα της γυναίκας. Η μέρα της δύναμης, η μέρα της ελπίδας, αλλά και της ενσυναίσθησης. Σήμερα επιλέγουμε να μιλήσουμε δυνατά για τον καρκίνο του πνεύμονα, γιατί μας αφορά.
Με αγάπη για τη γυναίκα, ταξιδεύουμε το μήνυμα ότι η πρόληψη είναι στάση ζωής.
Κάθε μέρα έχει 24 ώρες, 1440 λεπτά. Ας αφιερώσουμε 5, μόνο 5 λεπτά να ακούσουμε το σώμα μας.
Μην αγνοήσεις έναν επίμονο βήχα, μια επίμονη δύσπνοια, την ανεξήγητη κούραση, τα κιλά που έχασες χωρίς να το θέλεις. Αν τα συμπτώματά σου επιμένουν, μην τα αγνοείς. Ίσως το σώμα σου παλεύει να σου πει κάτι.
Ο καρκίνος δεν ξεχωρίζει φύλλα. Προστάτευσε τον εαυτό σου. Προστάτευσε τον αγαπημένο σου.
Καπνίζεις? Λάθος έκφραση. Είναι το τσιγάρο που σε καπνίζει.
Ο καρκίνος του πνεύμονα είναι η σοβαρότερη νόσος που συνδέεται με το κάπνισμα. Είναι η κύρια αιτία θανάτου από καρκίνο στις γυναίκες, ξεπερνώντας αυτούς που προκαλούν ο καρκίνος του μαστού και του εντέρου μαζί.
Επίσης υπάρχουν και αρκετές μελέτες που καταδεικνύουν ότι το γυναικείο φύλο είναι πιο ευαίσθητο στις βλαπτικές και καρκινογόνες ουσίες του καπνού και κατ' επέκταση του τσιγάρου. Εμείς οι κυταρολόγοι είμαστε εδώ για να σας βοηθήσουμε και να προστατεύσουμε τα κύτταρά μας και από αυτήν την απειλή.
Προστατεύουμε τη ζωή μας γιατί είναι μοναδική. Δεν γυρίζει πίσω και δυστυχώς δεν είναι για πάντα.
Η ενημέρωση και η πρόληψη είναι γένος θηλυκού, το ίδιο και η δύναμη και η ελπίδα.
Ο καρκίνος του πνεύμονα μπορεί να διαγνωστεί έγκαιρα όπως και ο καρκίνος του μαστού. Πώς? Με αξονική τομογραφία χαμηλής δόσης ακτινοβολίας.
Υπάρχουν λύσεις για τον καρκίνο. Η επιστήμη προχωρά. Είμαστε εδώ πιο δυνατές από ποτέ.
Τελευταία η έρευνα στον καρκίνο του πνεύμονα έχει να επιδείξει πολύ σημαντικά επιτεύγματα. Κάτι πολύ σημαντικό είναι η δυνατότητα συνεχούς παρακολούθησης της εξέλιξης της νόσου μέσω αναλύσεων στο αίμα, μία προσέγγιση που λέγεται υγρή βιοψία.
Constantly working to promote early and equal access to treatment and care.
Awareness is important to improve patients' education and engagement, and the primary prevention campaigns are crucial for the population, especially young people.
Η γυναίκα που δίνει ζωή, όταν η ίδια νοσεί, πρέπει να έχει όλη τη φροντίδα και την υποστήριξη που της αξίζει.
Δεν θα ήθελα ο φόβος, δεν θα ήθελα ο πόνος για τον καρκίνο να μείνουν σε μία ακόμα σιωπή.
Η Όντρεϊ Λόρντ είπε: «Όταν τολμώ να νιώθω δυνατή και χρησιμοποιώ αυτή τη δύναμη για να κάνω αληθινά τα δικά μου οράματα, τότε γίνεται όλο και λιγότερο σημαντικό το αν φοβάμαι».
Ο καρκίνος του πνεύμονα αποτελεί την πρώτη αιτία θανάτου στις γυναίκες. Αυτό δεν πρέπει να μείνει έτσι. Έχουμε τη θέληση, την γνώση, αλλά και τα εφόδια για να το αλλάξουμε.
Εμείς οι επιστήμονες καθημερινά παλεύουμε για νέες καινοτόμες θεραπείες που θα κάνουν τον καρκίνο του πνεύμονα μια μακροχρόνια νόσο.
Επιλέγουμε την ελπίδα και έτσι όλα είναι δυνατά.
Σαν πρόεδρος της εταιρείας μου, θέλω να βεβαιώσω όλους τους ασθενείς μας με καταληκτική νόσο ότι θα είμαστε πάντα δίπλα τους για να τους προσφέρουμε ποιότητα ζωής.
Αφουγκράσου το σώμα σου. Μην αγνοείς τα σημάδια.
Σήμερα τιμάμε όλες τις γυναίκες με τους πολυδιάστατους ρόλους τους και την κάθε μία χωριστά. Όμως ειδικότερα εκείνες που στέκονται παγκόσμια αλήγιστες στην υπηρεσία του ασθενή ανθρώπου από COVID και όχι μόνο. Σήμερα οφείλουμε να τιμήσουμε περισσότερο από ποτέ αυτές τις γυναίκες του ιατρικού, υγειονομικού και νοσοκομιακού χώρου.
Η νοσηλεύτρια ογκολογίας δίνει καθημερινά πνοή στη φροντίδα του κάθε ασθενή. Είμαστε δίπλα σας.
Μένουμε δυνατές με πείσμα στη γνώση και την πρόληψη.
Η ημέρα που επιλέγουμε να μιλήσουμε δυνατά για τη ζωή.
Εύχομαι κανένα παιδί του κόσμου να μην χάσει το γονιό του από το καρκίνο του πνεύμονα. Η πρόληψη σώζει ζωές.
Εμείς, οι γυναίκες του Fairlife, μοιραζόμαστε ένα μήνυμα αγάπης και ελπίδας, δίνοντας ζωή και πνοή σε ένα όραμα.
Να είναι η ζωή που θα κόβει την ανάσα και όχι ο καρκίνος του πνεύμονα.
Θέλω να προλάβεις κι εσύ, γιατί η ζωή σου αξίζει.
Η Fairlife είναι ο πρώτος μη κερδοσκοπικός κοινωνικός φορέας στην Ελλάδα που ασχολείται αποκλειστικά με τον καρκίνο του πνεύμονα. Ο Σάιμον Μπέλ έχασε τη μάχη με την νόσο και η επιθυμία του για μια δίκαιη ζωή των ασθενών έγινε πράξη από τη σύζυγό του Κορίνα Πατέλη Μπέλ με την ίδρυση της Fairlife τον Νοέμβριο του 2020.
Ο καρκίνος του πνεύμονα μας αφορά όλους.
Στόχος, η ανάληψη δράσεων που θα έδιναν πνοή στο όραμά του, διαδίδοντας το μήνυμα «Η ζωή να κόβει την ανάσα, όχι ο καρκίνος του πνεύμονα». Η Fairlife απαρτίζεται από μια ομάδα που εργάζεται δυναμικά, αναδεικνύοντας τη σημασία του προληπτικού ελέγχου, της έγκαιρης διάγνωσης και της ισότιμης πρόσβασης των ασθενών σε νέες θεραπείες, καθώς και κλινικές μελέτες. Τη Fairlife αγκάλιασαν από την πρώτη στιγμή η ιατρική κοινότητα, επιστημονικοί φορείς, φαρμακευτικές εταιρείες, καθώς και τοπικοί φορείς. Είναι μέλος ελληνικών και διεθνών φορέων για την προαγωγή δικαιωμάτων των ασθενών. Τις δράσεις της υποστηρίζουν πάνω από 70 επαγγελματίες υγείας από την Ελλάδα και το εξωτερικό. Το έργο της αναγνωρίζεται και βραβεύεται. Η Fairlife μεγαλώνει. Αποκτά εκατοντάδες συνοδοιπόρους και πρεσβευτές.
Ας γίνουμε η γενιά που θα φέρει την ουσιαστική αλλαγή.
Η επιλογή είναι δική σου.
Με πολλαπλές δράσεις ενημερώνουμε, προλαμβάνουμε, στηρίζουμε. Συμμετοχή σε ημερίδες και συνέδρια.
Fairlife was born to fill a gap.
Θεματικά webinars και οργάνωση ημερίδων. Ψηφιακή ενημερωτική βιβλιοθήκη «Μαθαίνω, ενεργώ, ελπίζω». Ενημερωτικές εκπομπές 14 λεπτά ζωής. Δράσεις ευαισθητοποίησης νέων. Η Fairlife συναντά τα παιδιά στα σχολεία μέσα από ενημερωτικές δράσεις, καμπάνιες και μαθητικούς διαγωνισμούς. Δράσεις ευεξίας.
Καθαροί πνεύμονες, ελεύθερη ζωή.
Με ο Χρήστος και η Fairlife τερματίζουμε τα 5 χιλιόμετρα. Μπράβο, μπράβο.
Πενταψήφια γραμμή ενημέρωσης 11157 και το δωρεάν πρόγραμμα ψυχοκοινωνικής υποστήριξης Breath σε συνεργασία με έμπειρους και εξειδικευμένους επαγγελματίες υγείας από αναγνωρισμένους φορείς.
Η ζωή να κόβει την ανάσα.
Οι ασθενείς που νοσούν με καρκίνο βιώνουν ένα μοναχικό ταξίδι, όπως και οι φροντιστές τους. Χρειάζονται ενδυνάμωση, ψυχολογική υποστήριξη, κατανόηση και σεβασμό.
Η Fairlife διεκδικεί ίσες ευκαιρίες για όσους βιώνουν τον καρκίνο του πνεύμονα χωρίς στιγματισμούς.
Η Fairlife βρίσκεται δίπλα τους, ενημερώνοντας το κοινό, στηρίζοντας όλους όσοι έχει αγγίξει ο καρκίνος του πνεύμονα. Τους το οφείλουμε. Και αυτή είναι η υπόσχεση της Fairlife για μια δίκαιη ζωή.
Εύχομαι κανένα παιδί του κόσμου να μην χάσει το γονιό του από το καρκίνο του πνεύμονα. Η πρόληψη σώζει ζωές.
Fairlife. Η ζωή να κόβει την ανάσα, όχι ο καρκίνος του πνεύμονα.
Οι ασθενείς με καρκίνο του πνεύμονα αντιμετωπίζουν μεταξύ άλλων και το στίγμα γύρω από την ασθένεια, κυρίως επειδή θεωρείται μία νόσος που θα μπορούσε να αποφευχθεί. Η πλειοψηφία των καρκίνων του πνεύμονα συνδέεται πράγματι με το κάπνισμα. 8 στα 10 άτομα που νοσούν με καρκίνο του πνεύμονα είναι καπνιστές ή πρώην καπνιστές. Είναι όμως σημαντικό να γνωρίζουμε, σύμφωνα και με πρόσφατες έρευνες, ότι το 15% των ασθενών με καρκίνο του πνεύμονα δεν κάπνισαν ποτέ και το 35% είχε διακόψει το κάπνισμα πριν από τη διάγνωση. Ο σύζυγός μου Σάιμον, που μας ενέπνευσε να δημιουργήσουμε τη Fairlife, νόσησε από τον καρκίνο του πνεύμονα σε ηλικία 56 ετών, ενώ είχε διακόψει το τσιγάρο από την ηλικία των 42 ετών. Ο Σάιμον δυστυχώς έχασε τη μάχη με τον καρκίνο του πνεύμονα τον Αύγουστο του 2020 και σήμερα η Fairlife στηρίζει όποιον βιώνει την ασθένεια, αλλά και την οικογένειά του που στέκεται δίπλα του. Πάντα με κατανόηση και ενσυναίσθηση. Δεν ξεχνώ όμως το πόσο άβολα και ενοχικά ένιωθε ο σύζυγός μου όταν το ρωτούσαν διαρκώς κατά τη διάρκεια της νόσου «Καπνίζατε? Πολύ? Πότε το κόψατε?» Ένιωθε υπεύθυνος για το δικό του καρκίνο. Το στίγμα δυστυχώς το κουβαλούσε μαζί του καθημερινά μέχρι που έφυγε ανήμπορος στο δωμάτιο ενός νοσοκομείου. Το στίγμα δεν έχει και δεν πρέπει να έχει θέση σε μια δίκαιη κοινωνία όπου η περίθαλψη με ίσους όρους είναι δικαίωμα όλων μας. Όλοι οι ασθενείς με καρκίνο του πνεύμονα αξίζουν φροντίδα και συμπόνια. Είτε καπνίζουν, είτε κάπνιζαν στο παρελθόν, είτε δεν έχουν δοκιμάσει ποτέ το τσιγάρο. Αξίζουν να έχουν την ίδια ευκαιρία στη ζωή με κάθε άλλον που αντιμετωπίζει μία απειλητική νόσο για τη ζωή του. Όπως προδίδει και το όνομά μας, στη Fair Life διεκδικούμε μια δίκαιη ζωή για τον ασθενή. Δίκαιη με έγκαιρη και καθολική πρόσβαση στην πληροφορία, στην ενημέρωση, στις διαγνωστικές εξετάσεις, αλλά και στις καινοτόμες νέες θεραπείες. Η Fair Life διεκδικεί ίσες ευκαιρίες για όσους βιώνουν τον καρκίνο του πνεύμονα χωρίς στιγματισμούς. Είναι τιμή μας λοιπόν να τρέξουμε στην Ελλάδα μια διεθνή καμπάνια για το στίγμα που έλαβε χώρα με καλά αποτελέσματα στον Καναδά και στην Αυστραλία. Όλοι μαζί μπορούμε να μεταφέρουμε το μήνυμα ότι το στίγμα δεν αφορά κανέναν. Δεν αφορά τον συνάνθρωπό μας που νοσεί με καρκίνο του πνεύμονα, δεν αφορά την οικογένειά του. Πολλά ερωτήματα πρέπει να απαντηθούν. Ερωτήματα που στοχεύουν στην εξάλειψη του καρκίνου του πνεύμονα, που αποτελεί μια μάστιγα, μια τωρινή πανδημία για την κοινωνία μας. Ας μην ξεχνάμε ότι όποιος έχει πνεύμονες μπορεί να εμφανίσει καρκίνο του πνεύμονα.
Το να διαγνωστεί κάποιος με καρκίνο του πνεύμονα είναι μια δυσκολονόητη και δυσάρεστη εμπειρία που προκαλεί σωρία αρνητικών συναισθημάτων όπως δυσπιστία, άγχος, φόβο, θυμό, θλίψη. Το πιο σημαντικό βήμα στη διαχείριση και αντιμετώπιση τους είναι να ζητήσει και να αποδεχθεί κανείς τη βοήθεια των άλλων.
Ο κάθε άνθρωπος που θα διαγνωστεί με καρκίνο του πνεύμονα θα χρειαστεί κάποια μορφή βοήθειας. Είτε ψυχολογική, είτε πνευματική, είτε κοινωνική υποστήριξη, καθώς και βοήθεια στην επίλυση πρακτικών θεμάτων της καθημερινότητας. Η στήριξη αυτή μπορεί απλά να έρθει από την οικογένεια, το συγγενικό περιβάλλον, τους αγαπημένους φίλους, το πνευματικό του και γενικότερα την κοινότητα, ή μπορεί να είναι πιο εξειδικευμένη από εκπαιδευμένους επαγγελματίες υγείας, όπως είναι οι ψυχολόγοι, οι ψυχίατροι, η κοινωνική λειτουργοί και άλλοι. Επιπλέον, η στήριξη μπορεί να παρέχεται εξατομικευμένα ή μέσα από ομάδες στήριξης, τα λεγόμενα support groups, ή διαδικτυακές κοινότητες, όπως αυτά διαμορφώνονται από προγράμματα ψυχοκοινωνικής υποστήριξης υπό την αιγίδα εθελοντικών οργανισμών. Αναγνωρίζοντας τον άνθρωπο ως ψυχοσωματική οντότητα, καλούμαστε να φροντίσουμε τις ανάγκες τους στο σύνολό τους. Οι ανάγκες αυτές καθορίζονται από όλα εκείνα τα οποία ο ασθενής κουβαλάει, θα μπορούσαμε να πούμε, μαζί του τη στιγμή της διάγνωσης, όπως για παράδειγμα η ιδιοσυγκρασία του, η προσωπικότητα, τα ήθη του, η νοοτροπία, οι πνευματικές και φιλοσοφικές του πεποιθήσεις. Αυτό που είναι κοινό και πολύ σημαντικό για όποιον βρίσκεται αντιμέτωπος με τον καρκίνο του πνεύμονα είναι να συνδέεται και να επικοινωνεί με τους άλλους ανθρώπους. Για να γίνει αυτό, ο άνθρωπος πρέπει να έχει αρκετή αυτογνωσία, ώστε να ξέρει πότε είναι η κατάλληλη στιγμή για να ζητήσει βοήθεια. Αυτό, όπως καταλαβαίνετε, είναι μια πολύπλοκη διαδικασία, γιατί θα πρέπει να συλλέξει πληροφορίες, να οργανώσει τα συναισθήματά του, να εξασφαλίσει ένα κύκλο υποστηρικτών που εμπιστεύεται, ώστε να μπορέσει να ανταπεξέλθει σε αυτή τη δοκιμασία. Η διαχείριση της διάγνωσης του καρκίνου του πνεύμονα δεν είναι απλά άλλη μια εκκρεμότητα που προστίθεται στα υπόλοιπα που έχουμε να κάνουμε. Μια υπενθύμηση, αν θέλετε, ένα τικ στο ημερολόγιό μας. Ουσιαστικά είναι η εκκρεμότητα. Κυριαρχεί πάνω σε όλες τις πτυχές της ζωής, συχνά τις επισκιάζει και απαιτεί τεράστιο κόπο και ενέργεια.
Αν και η στήριξη από τους φίλους και το οικογενειακό περιβάλλον είναι ένα πολύ θετικό βήμα, υπάρχουν ορισμένες ενδείξεις, κάποια προειδοποιητικά σημάδια που υποδεικνύουν ότι είναι καιρός να αναζητήσει κανείς τη βοήθεια ενός επαγγελματία ψυχικής υγείας.
Υπάρχουν πολλά σωματικά και ψυχικά συμπτώματα που δείχνουν πως ο ασθενής βιώνει πολύ υψηλά επίπεδα στρες και άγχους ή άλλες συναισθηματικές και ψυχικές δυσκολίες. Μπορεί, για παράδειγμα, κάποιος να δυσκολεύεται να κοιμηθεί ή να ξυπνάει κατά τη διάρκεια της νύχτας, να τρώει πολύ περισσότερο ή πολύ λιγότερο από το συνηθισμένο, να αισθάνεται νευρικότητα και υπερένταση, να δυσκολεύεται να οργανώσει τις σκέψεις του, να πάρει αποφάσεις, να ακούσει πληροφορίες σχετικά με τη θεραπεία ή τις εξετάσεις του. Αυτές είναι ενδείξεις, καμπανάκια θα λέγαμε, τόσο για την οικογένεια και τους φροντιστές, όσο και για τον ογκολόγο και την επιστημονική ομάδα, ότι ο ασθενής μάλλον χρειάζεται πιο εξειδικευμένη συναισθηματική και ψυχολογική υποστήριξη. Με τον ίδιο δηλαδή τρόπο που ασχολούμαστε και παρέχουμε ανακούφιση για τα σωματικά συμπτώματα, όπως η ναυτία και ο πόνος, είναι σημαντικό να αντιμετωπίσουμε και τα ψυχολογικά συμπτώματα, όπως το άγχος και η κατάθλιψη που συχνά συνοδεύουν τον καρκίνο του πνεύμονα.
Συχνά οι ογκολόγοι συζητούν με τους ασθενείς τους για ζητήματα που σχετίζονται με την ψυχολογία τους. Αν ένας ασθενής αισθάνεται ότι χρειάζεται επιπλέον συναισθηματική βοήθεια και ψυχολογική υποστήριξη, καλό είναι να επικοινωνήσει άμεσα με οποιοδήποτε μέλος της επιστημονικής ομάδας και με τους φροντιστές του για να λάβει την κατάλληλη στήριξη.
Οι περισσότεροι ασθενείς έχουν ισχυρή σύνδεση με τον ογκολόγο τους και ευχής έργο είναι και ο ογκολόγος να έχει την ετοιμότητα να παραπέμψει και ο ασθενής να έχει την άνεση να ζητήσει μια σύσταση ή παραπομπή, είτε σε κάποιο ψυχολόγο, ψυχίατρο ή κοινωνικό λειτουργό, για να λάβει βοήθεια. Κάποιοι άλλοι ασθενείς δε μπορεί να αισθάνονται πιο άνετα να προσεγγίσουν άλλα άτομα στην ομάδα που τους φροντίζει, όπως νοσηλευτές, γιατρούς άλλης ειδικότητας για σύσταση ή παραπομπή. Μπορεί ακόμη να μην μπορούν να εκφράσουν ρητά την ανάγκη τους για παροχή ψυχολογικής στήριξης, αλλά η όλη τους συμπεριφορά να δηλώνει έμεσα την ανάγκη τους, και αυτό είναι κάτι που πρέπει να αναγνωρίσει άμεσα και έγκαιρα η επιστημονική ομάδα.
Υπάρχουν σταθμοί και ορόσημα στην ογκολογική πορεία των ασθενών που έχουν καταφέρει να επιβιώσουν από τον καρκίνο του πνεύμονα, οι λεγόμενοι survivors, κατά τα οποία αισθάνονται πιο ευάλωτοι και στρεσαρισμένοι. Τέτοια ορόσημα θεωρούνται η ολοκλήρωση της θεραπείας, η επέτειος της διάγνωσής τους, η αναμονή για τα αποτελέσματα επαναληπτικών εξετάσεων ή η περίπτωση υποτροπής και επανεμφάνισης του καρκίνου. Η κατάλληλη και έγκαιρη επαγγελματική υποστήριξη σε αυτούς τους σταθμούς μπορεί να βοηθήσει σημαντικά τόσο τον ασθενή όσο και την οικογένειά του.
Μέσα από πολυετείς κλινικές μελέτες γνωρίζουμε πλέον πως οι έγκαιρες παρεμβάσεις για τη βελτιστοποίηση της ψυχικής υγείας βοηθούν τους ασθενείς να ανταπεξέλθουν. Είναι ιδιαίτερα σημαντικό να αναγνωρίσουμε ότι η ανάγκη για παρέμβαση προχωράει και πέρα από τη διάγνωση και τη θεραπεία. Γνωρίζουμε, για παράδειγμα, πως οι επιβιώσαντες από καρκίνο αντιμετωπίζουν εξαιρετικό στρες πριν από την επανασταδιοποίησή τους με απεικονιστικές εξετάσεις, είτε την επανένταξή τους στο κοινωνικό σύνολο, το εργασιακό και κοινωνικό περιβάλλον, και συνεχίζουν να έχουν έναν αδιάκοπο φόβο μιας πιθανής υποτροπής. Αντιμετωπίζουν, αν θέλετε, ένα μετατραυματικό στρες, όπως για παράδειγμα στρατιώτες μετά τη μάχη. Χρειαζόμαστε λοιπόν κάθε δυνατό τρόπο υποστήριξης, αξιοποιώντας όλο το ανθρώπινο δυναμικό, προκειμένου να συνοδοιπορούμε με τον ασθενή μας στο μαραθώνιο που λέγεται καρκίνος του πνεύμονα.
Η ενότητα Μαθαίνω, Ενεργώ, Ελπίζω έχει στόχο αφενός την πρόληψη και αφετέρου τη γνώση για κάθε στάδιο του καρκίνου του πνεύμονα που διανύει ένας ασθενής.
Πάνω από 70 επιστήμονες από την Ελλάδα και το εξωτερικό απαντούν σε όλα εκείνα τα ερωτήματα που απασχολούν τους ασθενείς και τους οικείους τους.
Ενημερώνουμε, προλαμβάνουμε, στηρίζουμε.
Δημιουργεί μια νέα πηγή έγκυρης και ουσιαστικής ενημέρωσης. Μαθαίνω, ενεργώ, ελπίζω.
Η ζωή να κόβει την ανάσα και όχι ο καρκίνος του πνεύμονα.
Ενημερώσου τώρα. Η Fairlife είναι εδώ για σένα.
Είναι η νέα σειρά ενημερωτικών εκπομπών της Fairlife που έχει ως στόχο την ενημέρωση και την ευαισθητοποίηση του κοινού για την πρόληψη και θεραπεία του καρκίνου του πνεύμονα.
Εισπνέω, εκπνέω, αλλά δεν αναπνέω. Η επιλογή είναι μέσα σου.
Είμαστε η νέα γενιά με όραμα και στόχους.
Η ζωή δεν μετριέται με αναπνοές, αλλά με στιγμές που σηκώνουν την ανάσα και σε συνεπαίρουνε.
Ας έχουμε μια ζωή χωρίς καπνούς να σκεπάζουν τα όνειρά μας.
Σιγά σιγά μαζευόμαστε, σε 5 λεπτά θα αρχίσει και επισήμως η επόμενη ενότητα. Αυτό είναι το σημαντικό. Μέσα στην αίθουσα ότι ακούγεται και έξω από την αίθουσα να συζητείτε.
Κάνε μια ξεκάθαρη επιλογή.
Βλέπω
Καθαροί
παντού
πνεύμονες,
χαμόγελα, γιατί
ελεύθερη ζωή.
την ευκαιρία. Εδώ οι παλιοί γνώριμοι και φίλοι που συναντιόμαστε πάντα στις εκδηλώσεις και τις συζητήσεις της Fairlife.
Μην ανάβεις τσιγάρο.
Για να
Άναψε τα όνειρά σου.
την επόμενη ενότητα που έχει θέμα την ανοσοθεραπεία.
Με τα μάτια των παιδιών.
Και πάλι,
ένα κοινό όραμα, ένας κόσμος χωρίς καρκίνο του πνεύμονα μέσα από τα μάτια των παιδιών.
Και οι λιγότεροι εκείνοι που βρίσκονται με σύνδεση από το σπίτι, από τη δουλειά.
Κομμένη μαγιά, γιατί θα πέσει στη σκλαβιά.
Το χρεώνουμε ως θετικό.
Όσο και καπνίσεις δεν θα ξεχωρίσεις.
Να περιμένουμε και
Είσαι μάγκας. Κάνε τη διαφορά. Πες όχι στο κάπνισμα.
Για να αρχίσουμε.
Σταμάτα το κάπνισμα. Η ζωή είναι μπροστά.
Μην ανάβεις το τσιγάρο. Άναψε τα όνειρά σου.
Ατμός, καπνός, χαμένος καιρός.
Μη μου στερείς το δικαίωμα να αναπνέω ελεύθερα.
Ωραία.
Very nice. Let us resume. The last people are coming into the auditorium so that we can move on to the next session on immunotherapy. Let me invite to the stage Mr. Ioannis Moutsios, Medical Oncologist, Director of the 4th Oncology Department and Clinical Trials Unit, Henri Dunant Hospital Center. Thank you very much. Good afternoon, ladies and gentlemen. First of all, a big thank you for this invitation. It is a great joy for me to speak here before you today because I know the efforts, the struggle, and the hard work put in by Fairlife and Mrs. Pateli personally to come to this celebratory, if you like, event, which is the culmination of efforts that date back many years. We all know her invaluable contribution, and I believe that the scientific and oncological community in Greece are by your side. We are with you. Thank you for your contribution, and I honestly believe that you have come to fill a gap that existed in Greece for many years, and thank you all for this effort that you've made. Now, in this session, which is immediately after the lunch break, I have the unpleasant role of talking to you about a purely scientific issue, which I will try to make as exciting as possible, because this is a new, groundbreaking breakthrough, if you like, or development in lung cancer. And we're talking about the role of immunotherapy in the early stages, i.e. in the early stages of lung cancer, of NSCLC. We heard this morning about the important contribution of immunotherapy to people with advanced lung cancer. And I believe that the next logical step was to scientifically see what immunotherapy has to offer in earlier stages of NSCLC. And let us now see what early stage means, first of all. I don't know how to change the slides. Is this done automatically, or do I do it? Do I press a button? Okay, now I've been told how to do it. So first of all, early stage lung cancer Well, it's important to detect it early, and it's not as rare as we believe. From large epidemiological studies, we see that 1 in 3 patients with NSCLC is diagnosed in one of stages 1B to 3A. These are stages where we know from clinical practice that despite the excellent surgery that is available, there's a possibility of relapse. So 1 in 3 patients presents with early stage disease. So why do we need complementary therapy in early stage? We need it because, unfortunately, even in very early stages, we may have a relapse. So here, or recurrence. Here you see that even patients at 1B stage, i.e. which is localized without the lymph nodes being affected and with the size of the tumor under old classification would be above 4 centimeters. Now we call it stage 2A. So it has half the possibility of 50% of recurrence in 5 years. And we see that in stage 2, 62% have a recurrence, and in stage 3, 3 out of 4 have a recurrence or relapse. So there is an unmet need to help the outcome of patients in these stages. So what did we have up until now? As oncologists in our quiver, we had chemotherapy. We all apply chemotherapy in order to improve outcome. But what we've seen from meta-analyses is that the benefit from complementary chemo is not what we would have hoped or what we would have expected. The large meta-analyses, i.e. Aggregate meta-analysis, we see that if we give 4 rounds based on platinum, the patients gain around 5%, roughly speaking, of survival in the 5-year period. So the possibility of them to be alive after 5 years increases by 5%. And I believe that none of us is pleased with these results. But nevertheless, we did it because it continues to be the best weapon we have in our arsenal. And personally speaking, and I'm sure that many colleagues discuss this, meaning when we talk about the possible benefits, side effects, toxicity created or caused rather by chemotherapy, I always offer this information so that patients may know what the expected benefit will be from adjuvant chemotherapy. So that's how immunotherapy arrived. The theoretical background is excellent, the scientific background is excellent, and we tested it in early stage NSCLC. So it is significantly efficacious in advanced stages. And let us not forget that in patients with early stage that are operated and then relapsed, this is in remote organs. So we have metastasis, and we know that immunotherapy offers a lot, even in advanced, if you like, cancer. So it targets metastatic disease and has a cytotoxic, a very good effect on the entire body. So we believe that immunotherapy may help prevent remote metastases. On the other hand, if we give immunotherapy early in patients with early stage, we can help combat the spread, which may not be obvious even when we use PET and may only be obvious with use of molecular biology techniques. So, on the basis of the above, we have this rationale as to how we can apply immunotherapy. There's a school according to which it's good to give it before surgery, neoadjuvant immunotherapy. So what are the advantages according to this therapy? First of all, the advantage is that it allows early eradication of micrometastatic disease, and we know that particularly in stages 2B and 3A, this exists from the moment of diagnosis. And we know this from clinical practice, and I believe that we will all agree. They tolerate treatment better before having gone to surgery. We also have biological material, i.e. tissue at diagnosis, and also after the neoadjuvant chemo, which will allow us to look at the response to the neoadjuvant immunotherapy, so we can score, if you like, the efficacy of treatment. And the immunologists know this well. The presence of the entire, if you like, tumor in situ when the immunotherapy begins allows us to have more antibodies. Why? Because there's a bigger diversity, antigenically speaking, in the body, and this allows the production of a wide range of antibodies which have a better anti-cancer, if you like, action. So, on the other hand, neoadjuvant immune therapy leads to the delay of the surgery, which may increase the stress of the environment, but also of the patient. There's always the fear that the therapeutic window for surgery may be lost, particularly in stage 3A, where the tumors are borderline resectable. And there's also a possibility of problems during surgery, and this may be due to the prior immunotherapy. And we hear some arguments by the thoracic surgeons regarding the problems they encounter during surgery due to the reactive fibrosis, sometimes caused by immunotherapy. And we also have the possibility that one might miss the window, particularly in stage 3, whereas most studies show that, practically speaking, 90% of patients that begin neoadjuvant immunotherapy and chemotherapy can reach surgery, so 90 of them can do so with safety and with safe oncological margins. Now, there is another school, and this school talks about adjuvant therapy, meaning providing immunotherapy after surgery, post-surgery, either together with chemo or after chemo. Here, the proponents of this strategy say that adjuvant immunotherapy, i.e., providing such immunotherapy after surgery, is what we had been doing until now in the case of chemotherapy. So this was the standard of care. Also, from the operation, we have tissue, and we can use this to extract biomarkers, which we can analyze in order to be able to estimate the possible response to the therapy, meaning we'll be able to see whether the potential therapy is efficacious or not. Of course, surgery is on time, thoracic surgeons are happy, and there is no case of missing an opportunity for surgery. On the other hand, we oncologists know that patients with treatment after surgery tend to have poor compliance with adjuvant protocols. We'll see 2 studies where adjuvant therapy is administered for around 1 year. So this requires collaboration and compliance on the part of the patient. Therapy is long-term, it's longer. It's difficult for us to estimate or assess, rather, efficacy because we don't have endpoints, intermediate endpoints, as is the case with the chemo, which we administer neoadjuvantly. Here we have to wait for some clinical event, for example, deterioration, progress of disease, or even death. So on the basis of the above, in the last part of my speech, I'd like to talk about the basic results from the studies that have been conducted so far in relation to immunotherapy neoadjuvant. I will talk about one study. It's the only randomized phase 3 clinical trial which has shown till now mature results. This is the Checkmate 816 study. So in other words, very simply, it included people with NSCLC stage 1B, but with a size of tumor over 4 centimeters, what we would now call 2A to 3A of disease. and they didn't have mutations which we could target therapeutically using molecular agents, or pills rather, and they were randomized, meaning half received 3 rounds of standard chemo based on platinum, or same scheme plus the immunotherapeutic nivolumab agent. And because, as we said, in neoadjuvant chemo, we have endpoints that allow us to check efficacy. The 2 main points checked by this study were, one, the efficacy of response. And here we're talking about having in the tumor that is resected only 10% of viable cancer cells during the histopathology, and the possibility of having some events post-surgery. What are these, if you like, events? Here we're talking, and this is complicated, we try to check events, and we're talking about progression of disease, which would preclude surgery, recurrence of disease after surgery, progression of disease without surgery, and death due to any cause. So these were the events. So this was a complex of endpoints, and here we saw a positive outcome, meaning it reduced the period, the interval from 20 months to 31.6 months up until such events occurred. So it was around about 1 year. And this means that there was a 37% reduced risk of those events by adding 3 doses of nivolumab to neoadjuvant chemo. So this is another very complex slide. I just wanted to show you one thing. It confirms what we mentioned before, i.e. it seems that systematic adjuvant therapy exercises systematic action, because the most advanced stage is stage 3A, a stage where we oncologists know that in practice at diagnosis we have a systematic spread of the disease. And here you can see that the relative benefit from adjuvant immunotherapy was bigger in stage 3A than it was in the earlier stages. And this means that the more advanced the stage of diagnosis, the bigger the comparative benefit which we derive from immunotherapy. Now, something else that I'd like to dwell on in this particular study, and this is very interesting, we had a lab analysis, and they checked the ctDNA. So there was blood drawn when the patients entered the study, and then one after surgery. And what was shown in the study is that patients who cleared the circulating DNA in their blood after the neoadjuvant therapy, be it chemoimmunotherapy or only chemotherapy, had a better prognosis in comparison to patients who were not able to clear ctDNA in the blood. And now let us move on to adjuvant immunotherapy, just a couple of words. Here I'd like to say that there are many studies that are in progress. Around about 5,000 patients worldwide are included on these studies. And we say this with great joy, and we're proud of Greek oncology. These studies are also running in Greece. Some of the new studies, some of the new clinical trials, most of them give adjuvant immunotherapy for around about 1 year. And the most common endpoint to check efficacy is time to relapse or recurrence. So here the endpoint is very clear. And here I'd like very quickly to talk about 2 studies that have shown results. One was the IMpower 010. This had patients of the same category with those we saw previously, i.e. 1B to 3A, which were operated on, and then they had to receive adjuvant chemotherapy, which was platinum-based, so this 5% benefit of chemo was not lost. And then they were randomized, and they received either 1 year immunotherapy with this atezolizumab, this monoclonal antibody, or a BSC. This was the control arm, if you like. And here the study has at a primary endpoint time until a recurrence, time until relapse in patients with stage 2 to 3A initially. And then the study also took into account a biomarker, the expression of PD-L1. This is a biomarker which is linked to the efficacy of immunotherapy in the sample of the tumor that was resected. So this study was positive, clearly positive. It showed that in patients with a positive expression of the biomarker, at least 1% and were of stage 2 to 3A at diagnosis. So in that case, by giving immunotherapy adjuvantly and not just chemo, reduced by another 34% the possibility of a relapse, of recurrence. And this was statistically significant. And of course, this study is continuing, but the follow-up continues. But we see that generally this was a positive study for the overall population, not just those that had this biomarker, but in the EU in particular. This agent received from the EMA positive authorization only those that have high expression of PD-L1 over 50%, because this was a subgroup in the clinical study that acquired the biggest benefit from adjuvant immunotherapy. So here we see the higher the expression of PD-L1, and here you can see the subgroup of patients that had an expression of over 50%, so they had a big benefit. The danger of relapse was reduced by over 50%, and here we see the overall population of patients. There was a positive expression of over 1%, so I'm talking about total population in this case of the study. But there was also a constraint, and I talked about the fact that it was authorized only for the subgroup of patients. So immunotherapy, we say that it's well tolerated, but we must take into account the fact that there are side effects. This is something that we need to inform our clients about. These events may be rare, but if they're not diagnosed and treated in time and effectively, they may truly affect the quality of life of the patient. Some of them are difficult, for example, pneumonitis, hepatitis, or thyroid and pituitary glands. So we have to ask our patients regarding their symptoms, and we have to watch and do lab work in order to watch out for these side effects. Now, another study which showed similar results was PEARLS. The study design was similar, the difference being that here adjuvant chemo was not obligatory. There was a recommendation for chemo to be applied, a strong recommendation for stages 2 and 3A. And here the pembrolizumab was given every 3 weeks for a maximum period of 1 year. The result was that around 14-15% of the patients did not receive adjuvant chemo, only adjuvant immunotherapy. Here the results were also positive. You see 34% of the reduction of the risk of death, statistically significant. And what we saw in these studies is that there was a benefit regardless of the stage and the expression of certain biomarkers like PD-L1, but there were some contradictory, if you like, results for some subgroups, like, for example, the ones that have PD-L1 overexpression. Of course, high efficacy was not confirmed, or people with GFR mutation, for which it showed efficacy contrary to the other study. So there's a lot of discussion going on. I don't want to tire you the different subgroups of patients, but these studies don't have mature results yet, so we have to wait for the mature results in order to conclude. And by way of conclusion, I'd like to say the following. The take-home message from my presentation is that immunotherapy, after it was used successfully in advanced cancer stage, is now used in the early stages, i.e., the ones where we have resectable tumors. We have nivolumab, which is given for 3 cycles preoperatively together with chemo, and it improves response and reduces the possibility of relapse after surgery. We also have atezolizumab and pembrolizumab, which are, when administered post-surgery and chemo, increase significantly the survival free of progress. And here we see that there's a lot going on, and the future will show us which strategy or which combination of strategies will be the best, i.e. having neoadjuvant chemoimmunotherapy and then adjuvant chemo in those where we don't have full response. So maybe this will be the way ahead, but this remains to be seen in future studies. With these few words, let me thank you, and I'm at your disposal for further questions. Thank you.
Ευχαριστούμε πάρα πολύ. Συνεχίζουμε.
Thank you very much. Now we will welcome Mr. Ilias Athanasiadis, Medical Oncologist, Director of Oncology Clinic at Mitera. Thank you very much. Thank you for inviting me. It was an honor. Fairlife activities are very important, and so is my communication with you. I'm very happy to be here among you. So now I will talk to you about metastatic disease. Patients with metastatic lung cancer used to be an issue to us. Why? Because they were the ones that were hard to treat. They were the ones whose lives were getting lost, and our options were limited. Why? Because it was a problem not only to Greece, but to the entire world. At first, lung cancer used to be considered a minor disease, but over time you can see how it skyrocketed, and at some point in the second half of the previous century, it became the leading cause of death among men. And you know why was that? Because people used to have a different lifestyle, and then smoking came in. So that was what happened in the 20th century. Societies used to smoke less. People used to despise or loathe smoking in different countries. Also, some treatments became available over time. So this allowed us to better organize ourselves, our practices, and actually raise awareness among the public by conveying the message that, you know what, smoking does kill. At first, we had posters like the ones you see on screen. They were saying that smoking is good for your health. They were saying that smoking has to do with our love for our children or with femininity. So you can see the different target group. Here, seduction, femininity is the key message. This was linked to smoking to such an extent that female emancipation was no longer different from smoking. So this clearly shows that things are beyond smoking. It's up to society to take the next steps forward. And you know, I've already mentioned biology. I picked this study that was also presented earlier. It was published in 2002 before immunotherapy came into play. These were the best 4 chemotherapy regimens available in the States. And the question was, which of the 4 was the best? And you can see the curves, the graphs. No matter what we did, all rates were disappointing. After 1 year, less than 10% of patients were progression-free. And also, after 2 years, there were only few survivors. That was very disappointing, and it had nothing to do with the effectiveness of chemo. It had everything to do with timing. There were patients who could benefit and patients who didn't benefit at all. Science Journal, about 9 years ago, announced immunotherapy, despite few available evidence at the time as one of the best options. You know what the rationale was. You know, every year this journal selects the most promising development of the year across all sciences. And the journal said that although there are few patients, we can tell that there is a shift of paradigm. Cancer is no longer an aggressive mechanism. It is considered as an organization that escaped our immune response. So it's as if it grows without our body noticing it. So we must mobilize the body's immune response and let it take control. So this is a new paradigm, marking a shift of paradigm. And that was the breakthrough development that changed oncology in its entirety, particularly in our field. And you can see that the immune response is an entire mechanism involving different parameters, for example, antigen identification, mobilization of the immune response, and also surveillance cells that are there to suppress the immune response. Why? Because the immune response is omnipotent, and in fact it can kill the body itself. So the body has some resistance mechanisms to prevent this from happening. It has mechanisms to set off the response and also stop it. So, immunotherapy, why? Because it's powerful, because it has a memory. Even when you terminate immunotherapy, the attack has been launched. And also, it is adaptable. So there are turn-on mechanisms and turn-off mechanisms. So there are many tricks in our asset case. And now we have many more methods for tailoring treatment to our patients. We have patients who have no targetable mutations, who have no targetable proteins, and these are the patients who are eligible candidates for first-line treatment. Most of them will be treated with a combination of chemotherapy and immunotherapy. I personally I'm very careful when I'm selecting who will only be given chemo. And the answer has to do not only with PD-L1, although it is a very significant indicator, but also it has to do with some personal characteristics, because physical condition and fitness is important. If you see a person who is being helped to walk, for example, well, things are way different than in other cases, than in ambulatory patients. And there was this study that showed that delaying treatment could actually be fatal. So the key eligibility criteria were untreated stage 4 NSCLC and PD-L1 TPS above 50%. So we're talking about people who were given chemotherapy imminently or later. And you know what? Immunotherapy was way better than chemo. And also very important was that with respect to survival, delaying immunotherapy was dramatic. So in this population, if you miss out on the opportunity, you will lose some patients. And in fact, you will not have the opportunity to administer this therapy to a lot of these patients. And if you see these patients late, do you remember what I mentioned about memory? You'll find that after 4, maybe 5 years, 10% of these patients will have control disease without any other treatment. That was previously unheard of. And you cannot say that I will be giving you some specific agent for some months or some years, and even when I discontinue this medication, you will still be well after 4 or 5 years. That was a huge breakthrough. And you know, patients who were given early this treatment at a rate of 31% did better than those who were given the therapy later. So this study changed the paradigm. I am in favor of the combination, even if PD-L1 is above 50. In practice, we have both options, but immunotherapy is more beneficial as first-line treatment, and with some patients, it may be harmful to do otherwise, and it's not as toxic as some of you may think. Now, this is the study that has been put to practice the most. You can see the combination between chemo and immunotherapy. Immunotherapy was better. Such a type of study had been unprecedented at the time, because it is not ethical to have a study and say that one will not be given immunotherapy. You can see the results on screen, but the most important result is that over 5 years, 20% remain alive. This is very important. The curve has not actually flattened yet. You can see the rates are changing over 3, 4, 5 years, but everybody have different options, because you know, the question now is for science, what do you do with patients when the answer is sort of lost? So this went beyond PD-L1. Therefore, the idealization we were looking for showed that PD-L1 is a useful indicator, marker, but in general you will have more or less the same results across all lines of treatment regardless of PD-L1. And also, over 2 years of immunotherapy, in practice, those who made it to 2 years, well, their survival was afterwards very good. Many did not relapse ever, and even among those who did relapse, did well. So, in other words, immunotherapy is the basis, it is the starting point, and it also affects other lines of treatment. Why? Because the immunological response has a memory of its own. I don't have that much time, so I will skip some slides. However, with respect to squamous NSCLCs, results are similar. And these results, these outcomes, were considered to be the best ones ever achieved with respect to squamous NSCLC. So, in fact, this combination is something that is of value, not only lung cancer, but also in other malignancies. And although this does not fall within today's topic, it is very important to take note of combinations between different immunotherapeutic agents. I think that the studies have actually determined the first-line treatment, and practically you administer low dosage chemo so as to avoid the window, because if you only start with immunotherapy, you will lose some patients. Now, everything showed that if you choose immuno plus immuno or immuno plus chemo, things are better than each therapy alone. And this is something that benefits all patients. And no matter what you follow, what regimen you follow, you must follow it while supporting the patient and while realizing that this is a valuable asset in your arsenal. And if you lose someone early, then you will have lost an opportunity. You will have lost the opportunity to make use of this asset. And the quality of care is important. Access to care is important. Intervening early is important. And to take it a step further, this immunological response is a complex thing. In fact, if you are given antibiotics and suffer diarrhea, you can actually stop the response. So if you experience anything that will put an end to your immunological response, for example, you have an infection and you are no longer ambulatory for the next 2 months, no one can tell you how the immunological response will change. It will not be lost that easily, but it is very important to remain healthy. So among people who lost the immunological response, this can be regained and recovered. So we can overcome resistance to immunotherapy. And in my view, all available analyses and studies are very important because they analyze targeted therapies, because they do not talk about the cancer cell, but the cancer tissue. They allow you to turn tumors into warm tumors. So now you can have ways to recover, to re-trigger the immunological response. So immunotherapy is the basis, and you can say, okay, so we've achieved a lot, but what about those who did not do that well? I think that I've allowed you to understand why I'm such a fan of immunotherapy. It's all thanks to what we have seen and to what we will see. But now I want to talk about something that is biospecific, some compounds that are linked to T cells, because now we can also have engineered T cells built in a way that will produce the desired antigen. Also, we have TILs that will serve as the immunological response tailored to the tumor. And then we have more difficult immunotherapies of higher toxicity, during which we will be building, engineering personalized medication. This is the reality. This is something that will happen soon. We will be asked to make use of all available funds, either human resources or financial resources, and we need to make use of the support from the pharma so as to turn our hospitals into therapeutic science, because we oncologists are not lone wolves. We are part of a multidisciplinary team consisting of surgeons, consisting of other specializations as well. So in conclusion, I wanted to showcase immunotherapy. It dramatically changed the oncology therapeutic landscape and how we approach cancer. The metastatic NSCLC changes its natural course, and immunotherapy is part of the first-line treatment for all patients where targeted therapy is not a priority. Resistance is also subject to clinical research, and new approaches are required. Algorithms allow us to overcome this. So that's all on my part. Thank you very much.
Ευχαριστούμε πολύ.
Thank you very much. I now invite Mrs. Panayota Mitu, Head of Independent Department of Therapeutic Protocols and Patient Registries, Ministry of Health. Good afternoon. Thank you for inviting me. It's a great honor. I will talk to you not as an internist, but because of my position in the Ministry of Health. More specifically, we will talk about digital transformation, which is being attempted in the case of cancer. It is true that the scientific landscape for most diseases, including cancer, is rapidly changing. So we have patients who can benefit from innovative treatment, but also from new technology. So it is the duty of the state and of society to facilitate early diagnosis and access of every patient to safe and effective treatment. So we believe that digital transformation can contribute to this end. So we're talking about the management of the treatment of cancer patients. So what is the goal? First of all, to provide better care to the patient thanks to digital technology. We're talking about collection and distribution of the information regarding the patient, supporting interdisciplinary communication and collaboration and decision-making. We also believe that the system will perform better because we will have standardized procedures, therapeutic protocols, but also supervision and comparative evaluation of units and health providers. The patient will be supported by means of digital applications which will facilitate his life and help manage the cancer. Of course, we will have high-quality national data which will be collected and which can be used for policy making, but also scientific research. So where does this program actually focus on? First of all, it wants to create a national registry of patients with neoplastic diseases. It wants to set up an IT system for patients with cancer, solid tumors, various malignancies that are blood-related. We also believe that it will help support interdisciplinary groups and manage cancer treatment, but also provide support to cancer patients via apps. First, it will be on a pilot phase in 10 hospitals, and then it will be rolled out. This is a program that has been submitted to the RRF, and this will be done together with the Ministry for Digital Transformation and IVICA. So what is the different phases? The first phase is the development of the National Registry for Cancer, to the parameterization of the ICT in the hospitals that will take part in the pilot phase itself, and then the rollout to all the other hospitals, various apps to support patients, and system support. So let's talk about this National Registry of Patients with Cancer. It is true that registries with cancer patients, and I'm talking about collection of data, clinical, non-clinical, for a population that share the same disease, same exposure. Well, we have that already. So the question is, why do we need to create something new which will cost us a dime? Because the available systems to record cancer that we have at our disposal are fragmented. So we have many cases where they've been recorded. I'm not saying that these are registries, and they include patients who've been monitored in one hospital if we're lucky, or even in a clinic in a hospital. So there are registries that have patients in one clinic, and then there's another clinic that monitors patients with the same type of cancer, and unfortunately they are not recorded in this register. So we're not talking about systems that can give us the available information at a national level. There are also many systems with double entries. Let me remind you of EAN, the National Archive for Neoplasia. This was started under previous ESPNA by the then KELPNO, many double entries, and sometimes we might have had a separate entry for the same patient when patients changed hospital. Now, data safety, data protection. Well, very few can be interoperable. It's difficult to have interoperability with other systems. The analysis is very crude, and this is based not on the needs of the patient, but on the treating physician. So We're talking about the creation of this registry. So the main aim is to create at a national level all these parameters that are needed in real conditions, and to collect information and draw conclusions on the natural course of the disease, the measurement and of outcome, safety, efficacy, risk from treatment, cost, and efficacy. So we already have the legal framework. It's Law 4600 of 2019, and there we have a clear description of the national registries. So we are talking about a registry which by law, which will be in line with international guidelines, the arrangements of the EU, national arrangements, the WHO and ECDC guidelines. So a very important thing is protection of personal data, sensitive personal data. So human rights are being protected, the right to privacy, and personal data in accordance with national law and international law, but also EU law. So here we can clearly see when we can have processing of data that is recorded in the registry for preventive medicine, diagnosis, provision of health care or treatment, when there is consent, written consent by the patient, when we need to make sure that the natural person's interests are being protected, and when we're talking about EU law or national law which allows this processing to take place. So the IT systems are suitable, and those that are in charge are sworn to secrecy. So we have confidentiality that is guaranteed. So the Ministry of Digital Transformation has created various techniques, encryption, anonymity, pseudonymization, and so on and so forth. And we have all the penalties in place and all the guarantees, of course. Third parties cannot process the data, banks, for example, employers, and there's also a penalty for anybody tampering or making accessible this data to people who are not authorized. So this registry will be based on other registries, and it will go beyond them. I have various platforms from the National Register. I'm talking about cancer in children. This is something that was set up in 2001. It's a prospective registry. It has to do with cases that were diagnosed in 2021 or were still under treatment. We have over 800 cases. So the patient, the treating physician uses his password. He does so through e-prescription, draws the data of the patient, the demographics. All this is done automatically. In the next field, he writes the diagnosis by ICD-10, ICD-03, date of diagnosis, type of diagnosis, the oncology unit, the protocol of treatment, referral to an oncology center, the surgery, radiation therapy, and also hospitalization in relation to the disease. So next slide, chemotherapy, monitoring of the disease, relapses, metastases, medical incidents or events. And here we also have evaluation by the Ministry of Health, meaning distribution of patients by category of cancer, therapy, and outcome of disease. But this national register will go beyond the existing registries. How exactly? First of all, it can collect multiple data. It will also have integrated quality control. It will be able to process and analyze data. It will be able to create pseudonyms, and it also will be interoperable, meaning it can communicate with other registries. Of course, we'll take into account guidelines from the European Network of Cancer Registries, which says that member states must be harmonized, so there must be a common set of data, codification, and quality control in order to ensure a minimum level of homogeneity, which will allow making use of these data at a European level, because otherwise there'll be an overlap. So what will be created is what you see on this slide. So in reality, we're talking about a national registry which will draw data, and this data will be fed into it. So it'll be from hospitals, from the oncological record. You'll see this IT system that we mentioned before that will initially be implemented. And as I said, first it will be in 10 hospitals and then in all hospitals. And it will automatically receive the results from the pathology lab. It will actually check the validity. It will check admission. It will merge documents in order for us not to have double entries. It will have the possibility for encryption automatically in order to assess the data for research purposes, but also for health policy reasons. At the same time, it will be interoperable and can accept, if you like, data from existing registries. We don't want to burden the existing, the doctor, the clinician, and of course, it will also be linked to the digital health record, for example, the AOP system for electronic preliminary approval. Now let's move on to the IT system, this oncological record. So what is the underlying logic? What is the vision? We want to create an IT system which will help in the management of cancer treatment. According to the approved therapeutic protocols, we're working with EOP and we're waiting for the updated recommendations by the end of the year for the management of solid tumors, and we're working with the Hellenic Hematologic Society for malignancies that are blood-related. So this is an IT system which will allow us to time plan the therapies. You know how difficult it is to plan things in the right time. So we will have a safe preparation of the drug in a special unit for the dilution of cytotoxic agents. And this may be a unit that will serve more than one hospitals. There'll be home care, so this can be administered in the home. We have this preliminary approval system. There'll be interoperability with local IT systems regarding the patients and also the apothecary in the hospital for stock keeping purposes. So the purpose is for us to follow the approved protocols, meaning the right drug at the right disease, right stage, right patient. We want the drug to be prepared safely without squandering of doses, and we want it to be administered safely in order for us to rationalize pharma expenditure without undermining the access of the patients to quality treatment. So, furthermore, we have encryption, anonymization, so the data from the treater can be used for clinical research and for public health policy. This will be the first systematic effort at a national level to collect reliable real-world data. At the same time, this IT system will be able to provide support to oncology boards and interdisciplinary teams. We want them to have at their disposal all the data, structured and non-structured, with diagnosis, stage of disease, histology, diagnosis, comorbidity, imaging, information related to treatment. So this must be collected in an automated fashion by the local IT systems of the hospital. There will be interoperability There will be a visual presentation of all the above data, sort of in order for one to have a clear picture of the case and how it evolves over time. So the Oncology Council will be holding meetings. The meetings will be recorded, and there will be secretarial support and, of course, IT equipment so that the members of these teams will deal only with the scientific part and not with the red tape, with the bureaucratic elements, the administrative work. So we want to have digital MBTs. And then the staff, the scientific staff, will no longer be involved in time-consuming data collection and will only focus on decision-making and assessment of the material. What we need is a change of culture with an emphasis on collective work, on teamwork and collaboration. So this is an oncology IT system, which, as I said, will receive information from the medical file. It will work together with the MDTs, with the oncology file. It will analyze data, and it will also work with the National Archive, CIP-IOP, AIFI, and also e-prescription. So the third thing are the digital tools that provide support to the patients. These are very useful because we know that here we can have the treatment plan. There can be reminders sent for the incidents, the events, the possibility to fill out questionnaires, and these are then created by the doctors depending on the needs. And of course, we can also have use of AI. So the patient will have access to his data, but this will actually be classified. There will be a possibility for interoperability with the IT system of the hospitals for people going there and monitored there, and the patient will receive information in relation to the disease, to the benefits, to his rights, nutrition, and so on and so forth. So we want these tools to cover real needs. The patients will not use and must not use applications that do not solve problems and make their lives more difficult. So these applications must be designed together with the patients and not just to be presented to them. So the patients need to be involved from the outset in the process. Another thing I'd like to talk about is care in the home care. There have been some legislative interventions in order for us to guarantee home care. There are many elements involved. For example, providing the treatment in the home, also helping the patient communicate with the doctor, the psychologist, the nurse, the possibility for the patient to receive treatment, for example, injectable intravenous therapy or even oxygen therapy, meaning things that could not be done at home in the past. There was a lacuna in the law, and the possibility in the terminal stage of his life to live a decent life at home without having to choose between not getting any therapy at all at home or going to hospital to receive treatment. So we want people to be able to live out their lives at home with dignity next to their loved ones. A lot of critical issues. I'm not saying that everything has been solved. A lot remains to be done at the level of governance, at the level of legislation. We need to make sure that if financing is secured, we have to provide continuity, because otherwise we won't have achieved much. And we also have another element that's important. Staffing of this National Institute for Cancer, creating a management framework. I'm talking about data that needs to be managed in accordance with EU guidelines, oncology boards and how they legislate it, and of course human resources, because our doctors already do a lot in the hospitals. Such a digital system must not have anything to do with the fact that the clinician will have to spend more time because their time is valuable in countries with advanced digital systems. The data manager, digital coordinator, and MDT coordinator, well, that's a separate role in the health system. They receive special training and certification and have rights and obligations by law. So we're talking about strengthening the staff in the cancer hospitals and in the oncology units. So by way of conclusion, digital applications, nationwide national applications for cancer patients may contribute to achieving a faster diagnosis, better treatment, better monitoring, access to innovative treatment, and better use of resources, financial resources. And of course, these digital applications must help the patient in his journey in the healthcare system, and not just to improve the prognosis, not only to help him gain some more months, but a better quality of life as well. Thank you very much.
Now, I do not know whether I should just let you watch the video or perhaps introduce it. I'll do both. The next speaker is not a member of the scientific community and is not a state official either. It's a patient. It's Christos Apostolakos, who just 10 days ago ran the marathon. So, let's watch the video and then welcome him on stage.
Yes.
Hello. Can you hear me? Loud and clear. I loved your introduction. I was surprised by it. It was our participation with Fairlife in the marathon about 10 days ago. You know, since 1983, I've been running the marathon every year, but this year's marathon was the most moving of all. So, I am Christos Apostolakos. I'm not a doctor, I'm not a scientist, I'm nothing of the sort. I will speak as a layman, as a patient with lung cancer. It started about 1.5 years ago. That's my history. At the time, it was resectable. But for different reasons, I will explain afterwards, I did not have the time to have it operated upon. So I went to stage 4 with liver metastasis and 10 small brain nodes. However, my course is very good. You can see I'm standing here. It's been a year since then. The brain nodes underwent 10 chemos in Alexandra Hospital, but you can see my hair has grown back. I'm 66 and I have hair, so I'm good. Also, I've started chemo. I had 4 cycles of chemo. Since March, I started immunotherapy in Alexandra Hospital. My physician is Mr. Dimopoulos, but his team is very good as well. I would like to mention Ms. Andriokopoulou. And I'm very satisfied. So, my diagnosis was stage 4 lung adenocarcinoma with liver and brain carcinosis. I've never smoked a cigarette in my life, so I do not know what happened. I was always fit. I'm a vegetarian. I'm in very good shape. However, 1 year and a half ago, I had this cough. It was persistent. Nothing it would make it go away. I even stopped using the fireplace, and I went to this pulmonologist who ordered a CT scan. He identified something and said that we will follow this up. But the cough was persistent, and 4 months afterwards, the pulmonologist ordered a scan, and this identified lung cancer. However, 4 months had already gone by between these two visits. And you know, the node was on the aorta, therefore it was inoperable. And until they performed the EBUS biopsy, the tumor was no longer operable. Too much time had gone by. But then I started chemo, and thankfully things have gone well. Oh, by the way, I forgot to mention earlier that I would like to profusely thank Fairlife and Corina. And hopefully there will be more Corinas, because we need them all. Cancer is something that is spreading. It has to do with our lifestyle, in my opinion. Now, what is it that I've realized during this 1 year and a half? First, early diagnosis is of paramount importance. I've already told you that I've wasted time between the first pulmonologist and the second pulmonologist. So perhaps treatment could have been very different. Also important, molecular testing is very important with respect to the cause of the disease. I know 4 cases, former fellow students of mine, who wasted time because their pulmonologists wasted time. And you know, time is life in our cases. Fortunately, my second pulmonologist ordered this profiling very soon. Unfortunately, my indicators are negative. PDL1 is less than 1%. So, since that is the case, immunotherapy is considered not that effective in my case. However, according to my doctor's instructions, I have been undergoing such therapy, and thankfully, results have been good so far. However, I also find it reassuring to know that if things get worse, there are also other available drugs. For KRAS, I will not name the agents, but this is something very useful. You know, my best friend, since when we were children, he was diagnosed, and within 6 months, he perished. Thankfully, now there are so many options available. So we, cancer patients in these days, are lucky, despite being unlucky, because we have new therapies, we have tailored, personalized treatment, and we are also better informed. Also, clinical studies, you know, Mr. Dimopoulos' team had included me in a clinical study conducted in Aretaion Hospital. But when the brain nodes occurred, I was withdrawn from the study. Then I had 10 radiotherapies in Alexandra Hospital, but unfortunately I could no longer return to the study population. One more thing. In my experience, cancer is a marathon, it's not a sprint. And in order to walk out this maze where you're found, doctors must be members of a multidisciplinary board. This board will include a nutritionist, a psychologist, a psychiatrist, a social worker, not only an oncologist, because unfortunately, this is what happens, if not in all cases, in most of them. And also, I, as a patient, need to own my therapy. I cannot expect the doctor or the universe or whomever, whatever, to own my therapy. I need to have a say. It's this new era of new therapies, new agents, and therefore we must also change our mindset. Cancer is not a death sentence. It's not a curse. It's not incurable. It's not a punishment. It's something that we can overcome. You know, when I was told I had stage 4 cancer, I felt crippled. It was not a joke, by no means. But after this initial shock, I decided I will throw everything at it. And thank God everything has been going well. Also, I have other methods in my toolkit. I exercise a lot. I run 5 days a week. You saw me running the marathon. And, you know, when I return home, I will put on my athleisure and run a few miles. And when I'm not running, I swim. I do gardening. Anyhow, I'm very active. Also, I pay attention to my nutrition, and I find it regrettable that nutrition has not been promoted as it should have been. People still eat junk food. So there are so many studies on sugar, for example, and the harm it does. And doctors will tell you, why don't you have a dessert? No, I will not allow the Titanic to sink. I will do my best to engage in healthy nutrition and also make drastic lifestyle changes. Cancer rings a bell. Change everything. Make changes as fast as you can, as many changes as you can. We're talking about cancer and a serious type of cancer. So, see what you need to change. Otherwise, you may achieve success, but relapse is just around the corner. Some of my friends are no longer with us due to this. And, you know, relapse is always worse than the original. So, in closing, let me check my notes. Okay, yeah, so I feel very lucky. Well, being unlucky, I feel lucky. I would very much prefer not being a cancer patient, but now that I am, I do my best to get stronger and stronger. I'm 66 years old. I want to lower my biological age through exercising, and therefore I'm disciplined. And then this unexpected gift is a sort of treasure. Quoting Nietzsche, whatever will not kill you will make you stronger. Thank you.
Ό,τι δεν με σκοτώνει.
So whatever doesn't kill me may make me stronger, provided I do what I can. It's up to me, as the song says, and what is true and what is correct. No cancer can kill me if I don't let it kill me, if I don't allow it to kill me. So whatever doesn't kill me makes me stronger. Thank you. Take care. And let us always be strong so that we can meet again. Thank you. And next year we can run 10 kilometers, and the year after that 20, and then we can double that, 40 kilometers. So we have to keep moving forward. Thank you. I don't know what you will now say, Mrs. Kanaloupiti, medical oncologist, director of the 4th Oncology Clinic at ESO Hospital, because we had the patient speaking and it changed the atmosphere, it changed the mood. Thank you very much, Mrs. Padimitriou, for giving me the floor. I would like to thank our beloved Corina Patelli, who is persecuting us, quote unquote, and we'd like to thank her for doing so, and thank you for allowing us to come here. I know my voice is hoarse. I've been suffering from laryngitis. I intended to begin my comments differently, but Mr. Apostolakis won me over. And he reminds me why we're all here today and why we do what we're doing. I believe that every oncologist, each and every one of us, feels that we are heroes. We had this feeling as children, and then we decided to do something about it as adults. And when I see people like Mr. Apostolakos running and speaking before us on stage and being with us, well, I feel like a hero. And I'm really happy to have people like Mr. Apostolakos with us, because he actually is the reason why we're all here. Now, I heard my fellow colleagues talking about the studies that exist in early stage cancer, but also advanced cancer, and I'm talking about lung cancer and immunotherapy. So I think that the more the study progresses, we have a lot of new things coming to the fore. We have a lot of medical information. So I think it's good of us to take stock. It's good to have people like my colleagues who classify everything, who explain all these studies to us in order for us to be able to understand immunotherapy as members of the broader oncology community, in order for us to have precision medicine, personalized treatment, and so on and so forth. Sophisticated therapeutic approaches vis-a-vis our patients. But I like putting things in order in my mind. And I believe that as far as lung cancer is concerned and immunotherapy, we have questions which we have answered and some questions which remain unanswered. We have answered, as was mentioned by Mr. Thanasiadis quite rightly, that no patient, when we have first-line therapy, which has no targeted mutations, must receive immunotherapy. So let's see what the prevailing thought is in oncology. So we have to answer two questions. One is, what is the right timing regarding the use of immunotherapy in the early or advanced lung cancer cases? And secondly, what was mentioned quite rightly by Mr. Athanasiadis, and I think he stressed it because there's a dire need for this, how will we actually give back the immune response to patients who no longer have this immune response? How can we restore it? And my contribution to this discussion is the following. I looked at a meta-analysis which was published this year in PMC Medicine Journal. This was a systematic review of 52 speakers, including over 13,000 patients. And the answers the questions seeking an answer were the following. One, is the use of immunotherapy in early cancer, early stage cancer, is it more efficacious compared to locally advanced but unresectable cancer, inoperable cancer? Now, whether chemo added to immunotherapy will give more benefits. And third question, whether the side effects and the toxicity of immunotherapy is lower when immunotherapy is used in early stages, meaning as neoadjuvant therapy. The answer, of course, this is a meta-analysis, was positive. It was affirmative in all three questions. So the rate of objective response and the disease control rate is better when immunotherapy is given at an earlier stage. And we know that immunotherapy is beneficial, and we see that toxicity is low of immunotherapy. So one thing we should take home is that in carefully selected patients, the immunotherapy, when given at an early stage, may have greater efficacy. And let me just say one thing before concluding. Now, let me talk about metastases. I am haunted by how one can restore immunological response when this has disappeared, because according to American Lung Association, we have improved the 5-year rate survival. It's 24% now. It used to be 16, but there's a remaining 70-odd%. So the answer is we have to find a more specialized carcinogenesis pathways, biomarkers, resistance mechanisms, and I think that we all need one another in this path. The pharma industry, the pharmacists, the state, the doctors, patient advocacy groups, we all need one another. And I think that these are the two questions that we need to answer in the case of immunotherapy. Thank you very much. Now, without further ado, let us go to Thessaloniki. Mr. Anastasios Boutis, medical oncologist at the Theogenic Cancer Hospital and General Secretary of EOPE, HESMO. Hello, good afternoon. Good afternoon, ladies and gentlemen. Thank you, Fairlife, for inviting me. It's a great honor. I'm very sorry that my work doesn't allow me to be with you today. I couldn't travel to Athens, unfortunately, due to my obligations. I will be very brief. And let me say that Mr. Apostolakos' speech made me wiser. I feel much wiser, and he actually made me understand that I need to talk to my patients, and I think it's good for patients to work well with their doctors. This gives them an incentive, if you like, to live. Now, in relation to the other presentations, I'd like to dwell on what Mrs. Marcou said. She's the representative of the ministry. What I consider very important is what she mentioned regarding, excuse me, but we cannot translate because we can hear music now, and the music is deafening, and it's actually covering what the gentleman is saying. I'm very sorry, but we cannot interpret.
Και σας βλέπουμε και σας ακούμε μια χαρά.
We can hear you now and we can see you. There was some music and I'm very sorry about that, but I think the problem has been solved. So I was talking about Mrs. Marcou, and she talked about the interoperability and the interconnection with other systems. And she said that all new measures of digital technology should not be a burden on doctors. We heard that they're there to provide decongestion. So we need to have people who are data managers, people who are specialized in data management. And we also heard about the involvement of the patients and using digital applications. This is very important. And we also heard that what should be included in the planning is what the patients really want and what health professionals really want as far as digital technology is concerned. Finally, from the comments made by the lady, we heard about the collaboration. We heard about the Association or Society of Oncologists of Greece. We heard about the different criteria. And this is very good because we see that scientific communities and healthcare professionals make efforts to improve the services provided to patients. And I think that we should be the allies of the patients. And we must always understand that what we do is patient-centered, and we should always have the patients and their families in mind. Thank you very much. Now, again, another connection. We will hear from Mrs. Zoe Gramatoglou, President of KEFI Association of Cancer Patients, Volunteers, Friends and Doctors of Athens.
Μας ακούτε, κυρία Γραμματόγλου?
Can you hear us, Ms. Gramatoglou? Yes, I can. Good, good. Oh, there you are. Good. I would like to also thank Fairlife and Miss Patelli in particular for inviting me to be here today. We have enjoyed a very good cooperation with all societies and associations. It seems that the state has been hearing the concerns we have voiced. But I would like to also comment on the enthusiasm shared by Mr. Athanasiadis and Mr. Moudzios. You know, these three new therapies actually gave us room for hope to us patients, that is. Hopefully this will be reproduced in the future in other types of cancer as well. I'm not a physician myself, I'm not a medical professional, but hopefully this will happen. And the other thing I also liked was reference to medical boards. Unfortunately, either due to hospital policy or due to lack of time, there are no medical boards treating us. This is an issue that must be addressed by the state. I would like to say that I've also listened very carefully to Miss Mitru. But you know, she reminded me of a pre-election campaign. So, Miss Mitru, is there political will to actually implement all of these programs? Because we had a lot of things about technology and applications, but how many times? I cannot even begin to count the number of times I've had talks about online health applications and home care. Unless we digitize hospitals, unless we apply home care, nothing will be done. Thank you very much. You know, there are some people, such as myself, who are cancer patients or former cancer patients, but not a single step has been taken. Only the Archbishop of Lavreotiki has done a few things. Other than that, no aid is given to us, no financial aid, because, you know, people who can afford treatment can have a more decent life than the rest of us. This applies to all diseases, not only our disease. Also, I was very enthusiastic listening to Mr. Athanasiadis. I'm very happy that he is optimistic. And you know, psychologists say that you're halfway there when your spirits are up. Thank you. Thank you. So, now, Mr. Paris Kosmidis will take the floor, and then this session will end. He is a medical oncologist in Ygea Hospital. Hi, how are you? I'm fine, thank you. I've been listening to this session. Unfortunately, I was not able to attend all sessions, but this last session was very, very interesting. And it's nice to see people who are actually engaged in treating lung cancer. And we must also give credit to the persons behind initiatives. I know that several initiatives have been taken on recently in the field of lung cancer because this cancer is a very hard to treat cancer. So I would like to comment on this. How can we tell that things are going in the right direction? Just take a look at our patients. One would say that if one checks medical histories and records, they would not expect such good outcomes. So this means that we do help our patients. If, for example, we have a patient who has never smoked and has benefited from immunotherapy, this is proof of the fact that we still have a lot to learn about immunotherapy. What is it that I'm trying to say? Lung cancer is a multi-layered, complex issue. It requires great efforts on the part of many stakeholders to achieve good results. And I do not want to talk about digital technology because we've heard a lot about theoretical interventions aimed at higher quality of services. These are all nice things, and we all welcome them. But we've heard about similar projects in the past on numerous occasions, and nothing has happened. So the technology is available, but it's up to us to absorb it and embrace it. So we must keep our minds open in order to make full use of all available technologies. But above all, we must address the fact that our facilities are deficient. We must remedy this situation before we welcome the new digital era. Thank you. Thank you, Mr. Kosmidis. So this is the end of this session. We will now go immediately to the next session. Now, I will ask the speakers to shorten their presentations. We are 1 hour behind schedule, and this is something that is frustrating from an organizational standpoint. So please be brief.
Κυρία Λινάρδου.
Mrs. Linardo, can you come to the stage, please? So the last section is clinical research. Mrs. Linardo, you have the floor. Thank you very much. Thank you. I think that the next session, so good afternoon to those of you I haven't greeted this morning. I think that the next session complements the triptych, if you like, of today's event, which was very artfully designed. We started with screening early in the morning, we continued with the biomarkers, and now we're talking about clinical trials. These are the 3 subjects where we have a lot to discuss, not just in cancer, but elsewhere as well. So, my speech will be the introduction, if you like, for this table, this round table. let me remind you the things that we know, the basics. Clinical trials are the only scientifically proven strategy to develop new drugs. Today in oncology, the number of clinical trials increases rapidly worldwide. It has increased a lot in the last decade. Unfortunately, over half of these clinical trials, oncology trials, are carried out in the US. And unfortunately, even though we have a large number of clinical trials, people with malignancies do not participate in clinical studies. Only 5% of the total number of cancer patients participate in clinical trials. The reasons are obvious. They do not know what clinical trials are. They've never discussed the matter with their doctor. They were never given the choice to participate in a clinical trial. Now, if you want to be more specific and look at lung cancer, valid platforms like clinicaltrials.gov can give you an idea of what's happening in clinical trials worldwide, not just in Europe, but in the world and in Greece in particular. So, if you see what's happening in the world when it comes to lung cancer studies, you see that most of the studies are in the US. You'll also see that in Europe, things are unevenly distributed. You'll see that countries in red are the countries which monopolize clinical studies, and we're only talking about lung cancer studies. And here you can see that the poor countries in Eastern Europe, including Greece, are in yellow, a light yellow color. And here we have double-digit clinical studies. So let's look at the figures more closely. In Greece right now, we have 30 active lung cancer studies, 30. So 26 of these are NSCLC studies. And here, if you go down and look at the different phases of these studies, you'll see that most studies are phase 3 and 4. So more advanced studies, studies where we compare the drug to conventional treatment. And we have no phase 1 clinical studies. So the studies with the innovative drugs where we try to see whether there are other choices, other options for our patients. And I think this is something that we should discuss further. So Greece has a very low number of clinical studies when we compare ourselves to other countries in Europe with a similar size. It absorbs a very small amount of funds made available for clinical studies in Europe, and compared to Greece, Hungary attracts five-fold clinical studies compared to Greece, Denmark 30 times more, Belgium 70 times more, etc. But this shouldn't be the case because it offers new jobs, and most of all, it offers high-quality services, health services. So a patient must participate in a clinical study. Why? Because he plays an active role in his choices. This was mentioned by the patient. He can choose what he's going to do. He has a free and early access to innovation. He can have choices for every stage of the disease. And of course, there's safety and much better monitoring. So the main reasons for non-participation of a patient are ignorance, which is the main reason, fear, lack of information, and myths or legends, myths rather. There are a lot of myths regarding clinical studies. And I will quickly look at the five myths. First of all, the myth number one, that patients are guinea pigs. What is the truth? The truth is very different. The truth is that clinical studies may not ensure a better outcome, but they do ensure safety and the rights of all participants. Myth number two. Clinical studies are only for those who have no other choice. Very big myth. Participation in a clinical study is always a choice for every patient at every stage of the disease. And this can be proven from many immunotherapy studies that have taken place in our country. And we saw that patients had early access to innovative treatment, and they are with us many years now, having received this agent. So there was a significant benefit for them. Laser pointer, there's a problem. I haven't been able to use it. I don't know what I'm doing wrong. Myth number 3. Patients may not receive active agent, but only placebo. This is something we hear often. What is the truth now? The truth is that if there is an established treatment, there is no way any patient will receive placebo. So patients participating in a clinical study will always receive some treatment, either the standard treatment, standard of care that they would have received outside the study, or the one under investigation, or the ones that will actually receive standard of care will have extra benefits, more molecular tests, more tests, support, and close monitoring in the study. Myth number 4, clinical studies are very expensive. Now, that is a big myth. All the managerial cost of a study, all the lab costs, all the costs related to tests and hospitalization, everything is fully covered, and there is no burden on the national health system or the patient. So clinical studies are not expensive. They are a resource for the national health system and an opportunity for patients who are uninsured and who can have equal access to innovation. And finally, another myth, myth number 5, that participation in a clinical study is not significant to me. That's not true. It is of vital importance. Every treatment we have today that is life-saving is the result of a clinical study. Participation in such studies gives us not only new forms of treatment, but all the information regarding the disease, diagnosis, prevention, and a deeper understanding of the disease. So this is a strategy that will help not only the specific patient in the study, but many others and future generations of people who will suffer from the same disease. So how does this change? I've been trying to change the slide without success. So how will we develop a culture of clinical research in Greece? We must create, if you like, in the health structures an orientation that is research-based. So we must create centers of excellence. This is something we've been repeating since this morning. We need to have a smooth flow of procedures. A lot of discussion is being held by the state regarding a single integrated IT system for clinical studies, a pilot phase of offices for clinical research in some hospitals, and the development of single procedures, legislation, and so on and so forth. And since 2022, we have a new European regulation. It's 536/2014 EU CTR for clinical studies or clinical trials. And we also have the clinical trial information system that has started operating. I will now conclude. I will tell you about what the situation is like today. What are the levels of clinical research in oncology in Greece? We have pharma-sponsored international or national clinical studies running in quite a few Greek centers. We have national studies that are investigator-sponsored from Greek cooperative groups. So we have academic research and basic research studies. So, of course, we have HACOG. This is an example that I'd like to mention. This is an example of a Greek cooperative group of clinical research, which I am the president right now of the scientific committee. So I have experienced from very close the procedures and the great work that such a group can carry out. This HECOG was established in 1990. It's the biggest such group in Greece. It was founded by 4 oncologists, pathologists, and we have over 2 cancer centers and 2 university centers. Now we have a participation from oncologists all over Greece, with over 25 oncology units from all over Greece. So, HECOG has worked a lot Many publications have taken place. Many clinical trials, many patients were involved. There are many international partnerships or collaboration. And what's important is that it has biological material with the consent of the thousands of Greek patients that have participated in the HECOG clinical studies since 1990. So we have a biobank. Here we have biological material. Huge, over 30,000 tissue samples or peripheral blood samples from over 42,000 patients. The numbers are staggering. You won't even find these numbers in other countries. So this is one of the great treasures, if you like, of HECOG. So we've been doing this for quite a few years, and the results of this biobank, of this huge contribution of our patients can be seen in the publications. This is one of the publications. It's the biggest molecular analysis of tumors, 3,000 patients, molecular analysis of tumors. And we also have this study, and this is my final study. I will show the study to you because we need to know it. These are studies that are not pharma-sponsored. They run in Greece. They are financed for the first time in Greece by SNF, the Stavros Niarchos Foundation, one of the biggest charity organizations in Greece. And this is a challenge for the future, but it's also a great honor for us. This is a study that was the brainchild of people from HECOG, and the grant was from SNF. So we have three pillars. There is a clinical pillar, a molecular pillar, and a digital pillar, and they're all merged. It's one. And we have free services for all these three pillars for our patients and fully financed by the Stavros Niarchos Foundation. So in the clinical pillar, our patients in all the centers in Greece receive the best treatment, and their data is recorded, and we're talking about real-life data. Real-world data. 200 patients will be included in the study. So in the molecular pillar, all the patients have free access to a large panel of 161 genes for molecular screening. This is one of the biggest panels. It's NSG, and it's all for free. And we also have the digital pillar, where we have access to the CareAcross platform, where every patient records side effects and receives
σε καινοτομία και χρησιμοποιούμε την τεχνολογία για την υποστήριξή τους, ιδιαίτερα όταν ζουν σε απομακρυσμένες ή ακριτικές περιοχές, 24 ώρες το 24ωρο, μειώνοντας έτσι φυσικά το φόρτο επικοινωνίας με το νοσοκομείο και συμπληρώνοντας και όχι αντικαθιστώντας την ιατρονοσηλευτική υποστήριξη. Και αυτή είναι η τελευταία μου διαφάνεια. Πρακτικά τη δείχνω πάλι για να τονίσω ότι έχει σημασία στις συναντήσεις μας να λέμε ότι η κλινική έρευνα στην Ελλάδα είναι σε πάρα πολύ ψηλό επίπεδο. Δεν είναι μόνο οι διεθνείς μελέτες που τρέχουμε με την υποστήριξη φαρμακοβιομηχανίας που έχουν κάνει άλματα στα νούμερα τα τελευταία χρόνια στη χώρα. Και αυτό οφείλεται στις προσπάθειες όλων, στις προσπάθειες των ερευνητών, αλλά και στις προσπάθειες των τοπικών τμήματων των φαρμακοβιομηχανιών που έχουν καταφέρει να ξαναφέρουν τη χώρα στο προσκήνιο και να είναι η Ελλάδα επιλογή συμμετοχής σε μεγάλες διεθνείς κλινικές μελέτες, που είναι καλό τόσο για τους ερευνητές και φυσικά πάνω απ' όλα για τους ασθενείς μας, αλλά υπάρχουν και συνεργατικές ομάδες και ερευνητές στη χώρα, οι οποίοι τρέχουν μελέτες που χαίρουν
Ευχαριστούμε πάρα πολύ, κυρία Ελινάρδο. Αγαπητή Έλενα, να καλέσουμε τώρα στον βήμα τον κύριο Δημήτρη Φιλίππου, πρόεδρο του Εθνικού Οργανισμού Φαρμάκων και επίκουρο καθηγητή ανατομίας στο ΕΚΠΑ.
of Anatomy to take the floor. Hello. Thank you very much for this invitation. You know, every time we're asked to take part in conferences organized by patients or including patients, well, we are more than happy to attend. I'm also happy because Ms. Leonardo mentioned 3 things on which I will build to present to you the regulatory framework that is applicable. And knowing the regulation for clinical trials is of essence if you really want to increase the number of clinical trials to levels found in other countries. In order for us to be able to understand what a clinical trial is, first of all, we must define it. So, we will define the clinical study as research involving human subjects and aiming to discover or verify clinical, pharmacological, and/or pharmacodynamic effects of a specific substance, identify any adverse events, and study the absorption, metabolism, and excretion of one or more investigational medicinal drugs. What is it that we study? The effectiveness, meaning what is the effectiveness of the investigational substance, and also what is the safety of the patients involved, because after all, do no harm is the guiding principle. So we want to make sure that this substance will clearly do no harm to patients, and then we will check the effectiveness. So this is the core definition of investigational medicinal product. Also, we will have to include the comparator as well, because some patients will be given the standard of care, whereas other patients will be given the new drug, the investigational drug. Both these drugs used in a clinical study will be defined as investigational medicinal product. So, who is it that is involved in this very complex process? A number of stakeholders or entities. First of all, is the sponsor. Who is the sponsor? The sponsor is the one that is actually studying, trying the new drug. Therefore, this entity is the one responsible for streamlining this drug. Like Ms. Leonardo said, this may be an academic institution or any other scientific association. Most of the times, there is no single entity that carries out a clinical study. So, the sponsor cooperates with CROs. They will be the ones responsible for carrying out the clinical trial. The second stakeholder, the second entity that is of importance is the regulatory body. Part of these bodies is the National Organization for Medicines, which I represent here today. So, once the proposed clinical study is finalized, the proposal is forwarded to the National Organization for Medicines and the National Ethics Committee. Each of these two entities will approach the proposal differently and check different things. Certainly, for a clinical trial to be approved, both these entities must agree to it. Then comes the research side, the clinical side. They may be public or private. All that matters is that they have the infrastructure required and the scientific knowledge required so as to carry out these highly demanding studies. Then come the financing entities. And you know, this is a barrier to clinical trials in Greece because university hospitals and private hospitals have mechanisms allowing them to manage clinical study funds. The public sector is lagging behind in order to establish a new, revised, up-to-date, and common financial management framework. Last but not least is patients, because all of these entities work for the benefit and in the interests of patients. On the slide, I mentioned volunteers, not patients. Why is that? Because nothing can be done without volunteers. Either we're talking about patients who will volunteer to try out a new substance, or we're talking about healthy volunteers, healthy subjects who will volunteer to enter a clinical trial. It all comes down to them after all. So what is the necessary documentation? The most important of one is the protocol. This includes all details relating to the conduct of the trial, the design, the inclusion-exclusion criteria, the procedures, the statistical analysis, and so on. It's the investigator's manual guide. This includes all data, preclinical and clinical data with respect to efficacy and safety. Then there's the informed consent form, yet another core component of clinical trials. And last but not least, it's the folder of the investigational medicinal product. All of these documents and evidence fall within the concept of GCP, good clinical practice. What is that? This is an international, uniform, evidence-based standard of quality that specifies the guidelines governing the role of independent ethics committees, the obligations of the sponsor and CROs, the obligations of the principal investigator, the structure of the protocol, and, last but not least, the structure of the investigator's manual. So you can see that, contrary to other scientific fields where self-initiative may occur, in this case, this is excluded so as to safeguard patient safety. And also, this will deliver reliable outcomes. And in order to take a closer look to each component mentioned, we will talk about the reality in Greece. In Greece, there is Directive 2001/20/EC that is applicable. This was transposed into national law under Decision 89/29/2 of 2003. So, what does this law mandate? When a CRO finalizes a clinical trial protocol, it will then be submitted to the regulatory authorities, the National Organization for Medicines and the Ethics Committee. There is a 60-day deadline for cooperation between these two bodies that are tasked with assessing the protocol and delivering an opinion on whether or not this trial will be green-lighted or not. Both these entities must green-light it in order for the trial to take place. So what does the National Organization for Medicines, EOF, assess? EOF assesses the existence of relevant documentation. These documents cover the characteristics of drugs and the application, the administration rather, of drugs to patients. These documents aim to make sure that the trial is safe. The protocol must state the scientific background, meaning the theories and that are guiding this trial. Once the theoretical background is mentioned, the benefit-risk ratio will be explored. Unless this ratio is positive, meaning unless it is shown that the patient benefits, nothing will happen. Then there is reference to the inclusion criteria. We've all heard the patient earlier saying that he was included in a trial and then withdrawn when he experienced some brain metastasis. Why was that? Because the study's design did not have in the inclusion criteria brain metastasis. Then the protocol describes the study procedures and the statistical analysis. In clinical trials, and you know, many clinical trials fail to demonstrate clinical benefit. So in clinical trials, the size of the sample is very important. We all know that the greater the sample, the more reliable the results. But this is not always possible, so we must identify and determine the appropriate number of patients to come up with our sample. And we must always take into account all documentation addressed to patients, the questionnaires, the diaries. Also, all documents and materials for investigators. These documents are checked by both the National Organization for Medicines and the National Ethics Committee for two reasons. First, for transparency, and second, because we want to make sure that patients enjoy the highest level of safety throughout the clinical trial. And also because we want to make sure that the patient's dignity is respected. And all of these issues must be reflected in the ICF, the Informed Consent Form. And the key word is informed. The doctor must take their time with patients in order to explain to them what the study entails, what patients may expect, what patients may anticipate. Once patients understand what has been shared with them, they will decide whether or not they will take part in the study. Therefore, the communication, the physician-patient communication is of paramount importance. Patients are volunteering to take part in a study. The regulatory framework has remained the same for 20 years, but then in 2016 things changed following the new European directive that was transposed into Greek law. The regulation, the European Regulation 536 of 2014 started being implemented. Currently in Greece, we are in an interim transitional stage. We can have studies conducted under the previous law or under the new law. But what is important is that we must know what the new EU regulation entails. The reason behind this regulation is, first, that we wanted to speed up clinical studies, and second, we wanted to increase transparency in clinical trials. Therefore, a key characteristic of this regulation is that there is a centralized clinical trial system, the CTIS, an electronic platform available across the EU for clinical trials. The assessment now takes up a maximum of 45 days, a maximum of 31 days as opposed to 45 days previously. Second, there is the option of joint sponsorship. Up to now, we used to say that there may only be one sponsor, but now two sponsors may cooperate, may partner up for a clinical trial. There is also increased transparency. There are strict deadlines prescribed, and there are also two new requirements introduced. The first requirement is clinical trial. And what is defined as clinical trial under the new regulation? Anything that cannot be carried out on the basis of the clinical study definition in the country. This needs to be further analyzed. The second requirement is that low intervention clinical trials are introduced. These are non-interventional trials that do not affect patients as much. Therefore, they are a way for us to have simpler clinical studies. And last but not least, what is applicable to non-interventional studies? For those of you who do not know, because, there are some experts among us, but there are also laymen. Non-interventional studies are the ones wherein already authorized drugs are used. There is the patient information leaflet stating the indications, the contraindications, the adverse events, and so on. So this drug is used to study some parameters. These are non-interventional studies, and in order to accelerate them, we've made sure that these studies are judged at hospital level or scientific committee level. And one last parameter that is usually neglected because the focus is on medication is other medical devices, other forms of technology, digital services that incorporate AI. So in the coming period, we will see new clinical studies, and these clinical studies will be testing other types of products. I feel that in the coming decade, the clinical studies for medical devices will be of concern. These are studies aiming to improve the patient's condition. Up until recently, these studies were conducted in the background, but now, in light of the new regulation and the new criteria introduced, particularly with respect to the CE label, I think that there will be many more clinical studies. And I think that we should invest in clinical studies and not just limit ourselves to wishful thinking. So, we must first become familiar with clinical studies. Saying that we want clinical studies is not enough. We must have the human resources to support them. You know, central hospitals have become saturated. They've reached the top of their capacity. And this is why new scientists must be taught that clinical studies are an integral part of their work. Second, we must complete legislative interventions so as to establish the appropriate bodies to handle finances. And we must also inform patients well and fast. Because, you know, sometimes clinical studies lag behind because information is not given to patients in a fast way. And last but not least, thank you very much for your attention.
So let us watch the video. I will have to leave, please forgive me. So let us watch Mrs. Amanda Psiri's video recorded message. She is Professor of Internal Medicine and Medical Oncology. Good afternoon. I would like to warmly thank Mrs. Bell for inviting me to this wonderful event. I'd like to congratulate her on her actions, which have a huge social impact. So congratulations to Mrs. Bell. And thank you on behalf of all oncologists. And the title of my presentation is the data related to academic research. My name is Amanda Psiri. I'm a professor of internal medicine and medical oncology at the Second Department of Internal Medicine at Attikon University Hospital. Next slide, please. So, no conflict of interest on my part. Now, let me talk about other companies that I may be involved in. My research is financed by some pharma companies and biotech companies such as Cura, Bristol Myers Squibb, BI, Roche, AstraZeneca. Next slide, please. Now, let me talk about academic research. So the studies are divided into proof of concept studies, i.e. it's such an idea which is the idea of the investigator, which the investigator wants to see validated through the clinical study. Now, the investigator often tries to answer questions which do not have any commercial interest. And let me give you some examples later on. For example, if the surgery is equivalent to radiation therapy in early-stage cancer patients. This is not a question of interest to the pharma companies, but it's important in the management of cancer, and quite often it is the subject of academic research. So, next slide. Here we see the two main categories of studies. As I said, the commercial interest studies that are financed by a pharma company aiming to answer questions that are of interest to the pharma, which will lead to an authorization of a drug, and these are normally phase 3. We have the investigator-initiated studies. So first we have the company-sponsored studies, and then the investigator-sponsored trials, which are financed by pharma companies or donors. However, the question in these studies may not lead to the approval of a new drug, and it may not be of interest to the company. So, next slide. Here we see the main differences between the two types of trials. We have the industry-initiated trials and the investigator-initiated studies. Often these investigators are also professors. Usually, the industry-initiated trials are of commercial interest, the main interest being to get clearance from the FDA or the National Drug Organization. So in the investigator-initiated studies, we have the interest of the investigator, which may not be of commercial interest. Now, in the industry-initiated trials, quite often we see that instructions are granted as well as advice by the FDA, for example, particularly in phase 1 and phase 3 trials. So this has happened to me as well. There was a study in relation to EMA, and they told us how to design the study and how it could then lead to the authorization of a drug. Now, investigator-initiated studies, well, the concept is from the investigator, and there is usually no input from the regulatory authorities. However, we see that industry-initiated trials are more restrictive, whereas investigator-initiated studies will not lead to product approval, but can be cited as being supportive, i.e. that the drug is efficacious. For example, it may be a phase 2 study, and it may be promising that the outcome will be positive. Normally, the industry are phase 3. The investigator are hypothesis generating, meaning they lay the foundations for the validation of an assumption, and we will see how this is proven in practice through the study. And quite often in the industry-initiated trials, in the treatment plan, there may be a compromise, whereas in the case of investigator-initiated studies, we may have publications or presentations as a result. So industry-initiated trials are expensive, whereas investigator-initiated studies are less costly. Industry-initiated trials have very strict inclusion and exclusion criteria, whereas the investor-initiated studies address a wider population and have a wider application. So here we see in the next slide the various drugs available and their mechanism of action, and how these investigator-initiated studies helped the approval of drugs. So we see that some investigator-initiated studies have led to drug approval, but they're not that many. And now let's move on. Here we see another study. This was conducted in Japan, and it led to the approval of this drug. Here we see gefitinib versus cisplatin plus doxacetal in patients. So it was carried out in Japan. Next slide, please. Here we see an academic study. This is a study which was presented in ESMO some years ago. This is a study where we had patients. So what we did was a comparison of a post-operative radiotherapy port to no port, no treatment, and patients with completely resected non-small cell lung cancer and mediastinal N2 involvement. And there seemed to be no benefit from radiotherapy post-op. So next, we see these investigator-initiated trials. They sometimes have a unique, very original design. They try to give a first indication of the efficacy of drugs for specific types of tumor. They're called umbrella studies. This is, they test the impact of different drugs on different mutations in a single type of cancer. Those are, and we also have the basket, if you like, studies. They test the effect of one or more drugs on one or more single mutations in a variety of cancer types. So these are of interest to the National Cancer Institute and generally the National Cancer Institutes in various countries. They're not that interesting for pharma companies. However, they make us understand what may be found in the future, and we have small budgets. Here we have this long map study schema. This is fresh tumor biopsy or archival FFBE. We also have SWAB here. SWAB is the academic group in the US. And here we see in this protocol how various new treatments are tested, and then they can be compared to standard of care in phase 3 studies by industry. So here we see the protocol. Let's move on to the next slide. And here we see, next slide, here we see that it was published in the American Association for Cancer Research magazine. And finally, next slide, here we see the benefits from the investigator-initiated studies. So you see creation of data. Here we have the setting. Here we can see that they are tested on the patients. It also helps assist in creating health policies. And this is an educational process. It's a learning tool for the staff of the hospitals so that they can hone their research skills. It also helps in creating more safety data, and there is less conflict compared to industry-initiated trials. And a lot of research questions can be answered, and questions that patients may have, meaning they don't know whether it's better, for example, to have radiation therapy or surgery. And this is the summary where we see the benefits of the various studies, but also the challenges of the investigator-initiated studies. Now, in relation to studies, let's move on to the next slide. I believe that one of the challenges in conducting academic research is funding and also patient accrual. So next slide. Here we can see the problems. The problems that may occur when we have investigator-initiated trials. Here we see a workshop by the ERTC, ESWE, RCR, and we see how in every step of academic research solutions are proposed to deal with these problems. So next slide, please. Here we see the problems, possible solutions, ethics committees, operations, analysis, and so on and so forth. And the workshop which proposed certain solutions. Next slide, please. Here we see the studies. In the UK, these are investigator-initiated. You see the questions here. These are of no commercial interest. So the question is, does smoking status affect outcome? This is not of interest to companies, but it's a very important question. And we also have another question in the UK. And let me also say that they have a research center which supports these studies. And here we have a summary of these studies. And I've come to the Hellenic Cooperative Oncology Group, HECOG. This is an example of a study in Greece. Here we have stage 4 NSCLC patients. This is a study that is ongoing. It was funded by ACOS, and in all patients there is targeted NGS. So we look at PDL1, PROS. So we want to see whether they have biomarkers and patient-reported outcomes. So they actually fill out a form. And the last slide, here we see that the investigator-initiated studies, IIS, help by generating data on effectiveness and safety of a drug in the real-world setting, and attempt to answer questions that clinicians face in their everyday practice. Academic research plays a vital role in generating evidence that could eventually drive policy. And of course, this may pave the way for high-quality research that will eventually drive local, national, or even international policy for greater patient good. So we see that there's a change, and this is for the good of the patients. Thank you very much for your attention.
Thank you very much. I will continue to ask all speakers to be brief. Hopefully you will listen to me, otherwise we will find ourselves in a very awkward situation very soon. So, the following subsection has to do with patients and caregivers themselves. And perhaps, of all people, they're the ones whom I shouldn't be asking to be brief. However, I hope that they will be. So, we'll start with Mr. Giorgos Siaravas, who is a caregiver. And it's very interesting to listen to what he has to say, particularly at this point in time. Oh, Corina. Corina first. Who? Well, I don't want to waste your time, but I am very touched because I've listened to so many nice comments. I would like to thank Orestis Mikelakis. He is the youngest of all volunteers of Fairlife, and he has inspired a number of campaigns run under Fairlife. I would also like to thank Thomais. She represents all Fairlife volunteers. She was the very first volunteer. She started with me back in November 2020, and after 1 year, she took office next to me. I would like to thank all Fairlife team members, because, you know, we are all inspired, and our inspiration is Simon and my children, because my children came to me and said, "Mom, what next? Can we save some people?" And given that we have some persons from the States with us, I would like to say that I admire all of you, Lindy, Terry, Janet. I admire you all. You were an inspiration to me before I started this thing in Greece. So thank you. Thank you. Mr. Siaravas.
Καλησπέρα, ονομάζομαι Γιώργος Σιαράβας.
So hello, I am Giorgos Siaravas. I'm not used to standing before audience. And I also try to be out of the spotlight. I don't want to be known. So, First of all, it is an honor to me to be here and address you all. I'm very happy that Corina conferred me this honor after years to be able to address you. I am an IT expert involved in logistics, so I'm into improving processes. And up until a few years ago, I was working abroad. Due to a personal adventure, I had to return to Greece. I knew at the time that I had to return to Greece, otherwise I would not be able to access the opportunities I later did. So while on this topic, I would like to share my personal experience with you. There's a need for support. There's a need to take care of a person. That was the reason that brought me back to Greece. So I was forced to shatter everything I had achieved by that time. And also I had to limit my personal and family activities to the very minimum. As a result, the first diagnosis was stage 4 non-small cell lung cancer. So then I came into contact with Fairlife and they guided me. I felt that they gave me vision. I felt that I was able to not only take things, but also offer things back. And this is what brought me to Corina. We shared pain, a common pain. So this also gave me guidance and orientation. So I realized that biomarkers must be checked. We're talking about a rare type of cancer, exon 20. From what I've heard today and from what I've read so far, we check all items on the checklist. We are the rarest case of all. And we know that our options are limited in terms of therapeutic protocols. So we must focus on clinical studies. And the key was biomarkers. I didn't know that back then. So we had to make things happen fast. And we entered a clinical study. The good thing is that, well, we've listened to people talking about numbers, but you know, numbers can only be numbers. But the good thing is that we are here after 4 years. So my loved one is employed, they are active, and still they have tumors everywhere. So that's one thing. But I would like to focus on this slide because earlier the representative of the Ministry of Health talked about registers. I wanted the tools to be able to share information. So I had to set up this platform allowing me to share data, not only with my loved one, the patient, but also with other patients and caregivers. So we need the coordination of all stakeholders. In my experience, it's 12 steps. Step number 1, coordination of all stakeholders. Step number 2, focus on patients. 3, speedy actions and timing. 4, coordinated tests. 5, knowledge. 6, complete medical record and ongoing updates from temperature to whatever. Every single day, every single piece of information is valuable to a treating physician. 7, access to treatment and clinical protocols. 8, cost. This is the most important factor. 9, acceptance. Acceptance on the part of patients, acceptance on the part of doctors that partnerships are in order. Number 10, you know, this is not a curse. This is something we all suffer. And perhaps some of us have not had to suffer through it yet. So talk about the problem, seek help. 11, digital tools, undoubtedly. And 12, you're not alone. There are many people around you. There are many organizations that will be there for you. Now, up to now, drawing on my experience involving this particular case. We have taken 4,500 drugs and injections. We have underwent 181 treatment sessions, 55 imaging tests, 121 hospitalization days, 40 day hospitalizations, and 42 days of hospitalization. This is something that cannot be known to any ministry, and all of the above might have been avoided if only we could have had regular low-dosage CT scans. So if only we knew that this option was out there a few years ago, this patient and many other patients would have avoided a large part of these costs. So just imagine the costs and the out-of-pocket costs, because we're talking about the patient and all those around them. And you know, I have the cost list. I could share it with you. So finally, because I want to be brief as much as possible, screening through low-dosage CT does save lives. I recommend it strongly. Also, coordinated actions are very important. The gene panel is very important. It is critical because it unlocks modern therapies. Healthcare professionals know this better than I do. Digital tools and a complete medical record. If I had waited for all of these things to happen, my loved one would not be alive today. And last but not least, information to patients and caregivers about clinical trials. That's all. Thank you. I wanted to be brief. Thank you.
I have the impression that in these few minutes, a lot of substance is to be found. A lot of what was mentioned from 10 o'clock this morning till 6, which is the time now. But it's very important for us to continue to find sources of inspiration. Corinne is a source of inspiration for many, but Karina drew her inspiration from Lindy Campbell, president of Breath of Hope from Kentucky. And Mrs. Campbell, can we hear from you? Hello, Mrs. Campbell. Are you there? Can you hear us?
Can you hear me? Yes, of course. How are you? Great. Thank you. I'll go ahead and get started so I can be as brief as possible. But I want to thank you for asking me to join you today to share my personal story of hope. I live in the United States, and I've spent my entire life in a city and state called Lexington, Kentucky. The hope in my lung cancer journey is through my experience with early detection. I had an x-ray of my chest in August of 2015 during a routine wellness checkup with my primary care physician. The doctors, I was 51 years old at the time, my chest x-ray showed a small shadow on one of the lobes of my lungs. I didn't qualify for a low-dose CT scan for lung cancer, but my doctor wanted to get a closer look at the shadow, so she sent me to a pulmonologist and asked him to order a scan of my chest. The results confirmed I had a 1.2 centimeter nodule located in the lower lobe of my right lung. I continued to have CT scans for over 2 years until the nodule reached 2.4 centimeters in size, and the doctors felt it was time to have it removed for further testing. I had surgery on December 6th of 2017 when I was 53 years old, woke up to learn the nodule was cancer, and they removed 2 lobes of my right lung to give me the best chance for the cancer not to return. At that time, they diagnosed me with stage 1 lung cancer and said my surgery was considered my cure. So for a year and a half after the lobectomy, CT scans showed no signs of any more cancer. But by November 2019, a few spots started showing up on scans in my left lung. In May of 2020, I had a wedge resection of my lower left lobe to remove an 8-millimeter nodule, and it was also cancer. They sent a new growth for biomarker testing that revealed I have the EGFR exon 19 lung cancer mutation. We were excited to find out that a clinical trial had just been approved by the Food and Drug Administration for a targeted therapy drug for me to use to treat fully resected stage 1B to 3A lung cancer patients. The results of this trial showed a significant improvement in delaying recurrence for early stage disease, so I was able to immediately start this targeted therapy medication to treat my mutation. And I'm happy to say that I've been on this drug for 2 years and 4 months with no signs of a cancer recurrence. In my home state of Kentucky, we have high levels of smoking, secondhand smoke, and radon. And at the time of my diagnosis, we ranked #1 in the United States for lung cancer cases and deaths. We believe that extremely high levels of radon discovered in my childhood home after I was diagnosed and the amount of secondhand smoke I grew up around most of my life were likely associated with my lung cancer diagnosis. I started the nonprofit Breath of Hope Kentucky because I knew I wanted to do more in my state to help erase the stigma of lung cancer and build a community of support for patients and families who are diagnosed with this disease. I also wanted to raise money that I could donate to lung cancer mutation research that's working to develop better treatment options for patients. Finally, I wanted to educate our citizens about all the causes of lung cancer and what they can do if they think they're at risk for getting the disease. My story is one that gives hope for the future of lung cancer. I'm thankful for the low-dose CT scanning procedures that allowed the pulmonologist to follow the growth in my lung, of my nodule. I'm thankful to both surgical procedures that allowed doctors to remove the early stage disease from my lungs. I'm thankful for biomarker testing that discovered my lung cancer mutation. I'm thankful for research and the newly approved targeted therapy drug that allowed me to immediately start treatment for early stage fully resected cancer. I'd like to end my time today by saying I'm excited to report that my scans currently do not show any signs of disease, and I will be coming up on my 5-year lung cancer anniversary in just 12 days. So thank you for your time.
Thank you very much. Happy anniversary from Athens. Και τώρα να συνδεθούμε με την...
Now let's hear from Terry Conneran. Terry, can you hear us? Terry Conneran, are you there?
I am here. Can you guys hear me?
Okay.
Yes, am I here?
Yes, of course I can hear you. Can you hear us?
Yes, yes.
Okay, the floor is yours. We'll see you in a minute.
Okay, thank you. And I've got to say, it is an absolute pleasure to be here because I know, Karina, you have been just an absolute fire starter in making things happen in Greece. And so it is really a treat to be able to participate with y'all. My name is Terry Conneran, and I live in Charlotte, North Carolina in the US. And almost 6 years ago, I was diagnosed with non-small cell lung cancer. My non-small cell lung cancer was probably as a result of having lungs. Now, I don't mean to sound brief in that, but how I mean that is I had somewhat of a smoking history. I didn't have like a considerable 40-year smoking history, but I did have enough of a smoking history that it's quite possible that that had something to do with it. Fact is, we don't really know. Well, anyway, I got diagnosed with the lung cancer after I had gone through a number of different allergies, asthma symptoms, and that sort of stuff right before Christmas of 2016. It was about this time of the year that led me to the doctor's office. And what happened was I had pneumonia, and the pneumonia is what ended up saving my life. I don't think I would have been feeling what was growing on inside of me. It was a tumor that was highlighted by the fluid that was in my lungs that showed up on that chest x-ray. Chest x-ray is not a really good way to get diagnosed with lung cancer, but it's what led down that path. As a result of that, I was referred out to a pulmonologist, went through a number of different testings, and had a biopsy that resulted in the stage 3 lung cancer. Subsequently, I had gone through chemo and they removed half my lung, and I had no evidence of disease. From the no evidence of disease, I kind of started wanting to connect and understand better what this was that was going on inside of my body and find other people that had it as well. Because I didn't have enough friends and family that really felt what I was going through. Found out that there was these important things called biomarkers from a lot of these different organizations that are on here as well today, and wanted to find out what my biomarker was. My doctor said I didn't have anything. That wasn't quite true. I did have a biomarker. I have this KRAS biomarker. This KRAS biomarker is something that is the most common of all lung cancers, and it's also in colorectal, pancreatic, and a number of other cancers. I went looking for a specific group of people that I could connect with and find out what this meant. There wasn't a specific organization. So I kind of started on a quest to get that information and find out and connect with other people. By now, it had been 3 years that I'd had the disease. I'd had 2 different recurrences. And at the second opinion doctor, they really enforced how important it was that this biomarker was. Well, I just didn't want to feel alone. So I started a Facebook group. This was just as COVID was happening. And in Facebook group, I was able to connect with people internationally. We have some folks from Greece. We have people all across Europe. We have them all over the world that have different types of a KRAS cancer. And in that community, even though we're finding that we're not the same person, we don't have the same exact illness, because we need to get to that information, most importantly. We need to be able to find it, and we need to find it rapidly and connect with other people in a similar situation. So we're doing that through that Facebook group where we can post the clinical trials, where we can find out who else is in them, find out what is going on within it. Because the reality is, right now, today, I have no evidence of disease, but it's probably coming back. I've had 5 different recurrences over the past 5 years, and my particular type doesn't have a specific drug. By staying informed and knowledgeable about what's coming next, what's happening in the research world, and where it's going, I'm able to find out and take control, be my own advocate, be able to coordinate what may be next if I need a next. Because the truth is, quite often this comes back. And nobody wants to have that sense of it came back and I don't know what to do. So we use the Facebook group, we use our website, and through that information, we work together to kick cancer's KRAS. And how we're doing that is bringing in the education, the knowledge from the doctors, the research that's working, that's all working together worldwide so that we know what's going on, so we can advocate, work for ourselves as a self-initiative in order to have survivorship, and do that with a sense of community, a sense of belonging, and a sense of humanity together. Because anybody can get a disease, but it takes a whole community of effort for us working together to join forces and not feel alone and know that we can make a difference and we have a plan for what's next. So what I would encourage you to do is, if you or anybody in your family, your community has a cancer, insist on the biomarker testing and find out what that biomarker is. There's other groups, other organizations that are not KRAS, that are the different subtypes, and from that information, you'll be able to find out what's coming, what's next, and connect with other people that have that sense of knowledge, that you know that you're not alone. And that also will help lead you to the best information clinically and in research. And that is where I find my hope, is in the research that's coming, and knowing that if I need a clinical trial, how I can find that and what I need to do about it. So thank you for listening to me today. And I know that Janet's going to do a rocking job talking about the clinical trials, because that's the research and that's what's keeping us all alive. So thank you for having me today.
Thank you very much, Terry. Last but not least, Κυρία Janet Freeman Daly. Janet, can you hear us? Oh, hello.
Yeah. Thanks to Karina for inviting me to present today. I met her through the STARS program, which I'll talk about in just a minute. In early 2011, I had a light cough, kind of a that had been around for several weeks. My husband suggested I go to the doctor. He gave me antibiotics 2 different times, but I didn't get any better. After several procedures and tests, I was diagnosed with stage 3A non-small cell lung cancer. My oncologist thought I was curable, so I was treated with radiation combined with chemotherapy. Those treatments successfully shrank all my tumors. But 2 months after I stopped treatment, a scan showed the cancer was growing again. Well, I'm a researcher and a science geek, so I went looking for more information. I found an online lung cancer community and learned about biomarker testing and clinical trials. At that time, only 2 biomarker tests, ALK and EGFR, were available for lung cancer, and my cancer tested negative for both of them. I found a clinical trial that was testing for more biomarkers, but my cancer didn't have any of those either. And I didn't qualify for any of the clinical trials at my hospital. So I had more chemotherapy followed by more radiation. Again, the treatment shrank all my tumors, but as soon as I stopped treatment, my cancer spread. My doctor told me I'd be on chemotherapy for the rest of my life, which would be short. I was now a metastatic lung cancer patient. Fortunately, the year after I was diagnosed with lung cancer, researchers published findings for a new biomarker. I arranged to have more testing done on my tumor tissue, and my cancer tested positive for a ROS1 fusion, which is found in 1 to 2% of lung adenocarcinoma. It's relatively rare. I found a place for a clinical trial for an experimental ROS1 targeted therapy at the University of Colorado in Denver. It was 1,000 miles from my home in Seattle, but I still enrolled in the trial in November of 2012. By my next scan, all of my tumors had disappeared. Although targeted therapies do not cure, the drug I took allowed me to return to a relatively normal life. A few years later, in 2015, I met 4 other patients with ROS1 positive lung cancer. They were taking the same targeted therapy drug that I was taking. However, most people eventually develop resistance to targeted therapies, and we knew we had no other treatment option except chemotherapy when our targeted drug stopped working. We decided to join together to find more treatment options for patients like us. And we founded an online group of patients and caregivers living with ROS1 positive cancer. We named ourselves the ROS Wonders, and we're now a nonprofit that has hundreds of members in over 30 countries. Pretty good for a rare cancer. Our mission is to improve outcomes for all ROS1 positive cancers, not just lung cancer, through community education and research. Lung cancer detection, treatment, and care have improved dramatically in the past decade. The drug that I am currently taking was not available when I was diagnosed. I have had no sign of cancer on my scans for 10 years. I'm still taking the same targeted therapy, which is now approved in many countries. And my rare type of lung cancer now has 2 approved drugs, and there are more in clinical trials. For some types of lung cancer, a clinical trial might be the best treatment option. Thanks to new drugs that have helped patients like me live longer, lung cancer has many individual patient advocates, patient groups, and patient advocacy organizations like Fairlife. Patient advocacy can take many forms. It can include outreach and education for patients and the public, helping patients navigate the healthcare system, advocating to change healthcare policies, providing the patient perspective to research, and fundraising to make all of this work possible. The last one of those I mentioned is research advocacy. Effective research advocacy requires the patient or caregiver to have an understanding of the research process and some knowledge of the science associated with lung cancer research and treatment. The STARS program, offered by the International Association for the Study of Lung Cancer, trains, develops, and nurtures lung cancer patient advocates as they evolve into research advocates. And this is where I met Karina. Thanks to clinical research, online patient groups, patient advocates, and research advocacy, more lung cancer patients are being cured, and more patients with advanced lung cancer are living longer with better quality of life. That is hope. Thanks for listening.
Thank you very much. Και τώρα ήρθε η ώρα για τους εκπροσώπους.
And now it's time to welcome the former representatives, starting with Mr. Konstantinos Poulimenos, who is the head of Clinical Studies Department, Roche Hellas. Thank you very much. Hello, I would like to thank Ms. Patelis for inviting me. It's an honor. Also, I would like to congratulate her on today's event and on putting the clinical studies on the agenda. I'll try to be very, very brief. I would like to briefly talk about the setting in which clinical studies are conducted nowadays. There is financial hardship and restraints. The regulatory authorities keep on changing the clinical study assessment methods, and we have patients who are waiting, and their role is changing. Patients are now having a say in their treatment. And also, the world is changing in its entirety, particularly in light of digital solutions that have become available. So we must never forget that clinical studies are necessary and are here to answer a number of questions and address unmet medical needs. So we are anticipating that there will be specific drugs allowing us to meet currently unmet medical needs. So there are different benefits that result from clinical studies for patients, the public health system, the national health system, and healthcare professionals. I would like to touch upon the newly introduced legislation. It was passed this summer. Under this legislation, 40% of the 40% of revenue from clinical studies may be allocated to upgrading the equipment of hospitals. This is something that is very positive. So clinical research does indeed mean innovation, and it is inextricably linked to development and the economy and society. Now, 40% of the 2021 oncology pipeline are still in phase 1. This means that in the coming years, we anticipate the outcome of these studies so as to see what will be available in our toolkit. Figures do not always tell the truth. However, it is important to see what is taking place globally at the moment. The pandemic did not impact clinical studies. Oncology holds the lion's share compared to other therapeutic fields. Also important, the pandemic did not impact the geographical distribution of clinical studies. However, it is worrisome that in Greece and in the EU in general, we're lagging behind. So on the left part of the screen, you can see that Asia is in the lead. It's mostly China and South Korea where the number of clinical studies is increasing. Now, Ms. Leonardo also showed this graph, but we are in Europe, so we must know what is going on in Greece and in Europe in general. So there has been a drop in the number of clinical studies. Also, currently in Greece, we find it pleasing that we have overcome the psychological threshold of 150 clinical studies per year. It seems that we have achieved that. And amid the pandemic, we've reached a total of 196 clinical studies. Some of them had to do with COVID, obviously. But if we take a look at the National Organization for Medicine's website, we will see that these numbers are increasing. Also, Ms. Leonardo mentioned, and I agree with her, that a patient in Greece will not have the same opportunities to enter a lung cancer clinical study as a patient in France or other countries. 1 out of 4 patients will fail to enter a clinical study either because these studies are not available in their country of residence or because they fail to meet inclusion criteria. And you know, there are also some factors to blame. For example, the lack of information for patients and the lack of trust. This impacts the extent of inclusion. There is law. In fact, the law has been in place since 2016. It provides for the establishment of a national register for biomedical research. This platform would allow everyone to know what kind of research is taking place in Greece at any given moment. So where can we find this information? We can find this information by Googling or by checking the work of individual hospitals or individual research groups. However, there is no single platform, there is no organized, dedicated platform. We expect that this will happen in 2025. So what will we do until that time? Because now there are only 3 clinical trials in Greece to be found in the platform that is now available, which is the EU CTIS. What about the future? The pandemic has taught us many lessons, and it has introduced new technologies. We've all tried to make use of these technologies in Greece so as to bring studies closer to patients and make them more accessible to them. And what about decentralized clinical trials? What's that? This is a brand new concept. So this is an effort to bring the clinical trial closer to the patient's home. We want to make use of some technology, some services such as telemedicine, portable devices, mobile devices, the electronic health record, the delivery of drugs at patients' homes, because these things will help us increase access. So we want to make sure that patients will not have to travel to the medical facility. Roche continues to invest in medical research, and we take pride in the fact that in recent years, in fact within 5 years, we have started more than 65 new clinical trials. We have granted access to 700 new patients. Currently, we have 60 clinical trials that are ongoing in Greece involving 250 sites. But I always like mentioning examples. So I want to mention something that we take particularly pride in. This is the reason that brings us to work every day. We all know what's going on in Ukraine. There's this war. We all know the impact of war, but we are here to enable Ukrainian patients to continue to have access to investigational drugs. And although Kharkovo may be located thousands of miles away from Athens, but we did locate one patient. We did find a patient that was in Ukraine. We have successfully brought them to Greece, and now this patient still has access to the clinical research and to the innovative drug they were on while in Ukraine. So what about the day after? I've already talked about it. Will Europe become more competitive? That remains to be seen, but we all need to work on this. Digital technology, decentralized clinical trials. We need legislative decrees. European countries have taken many steps, so it's high time we started taking similar steps as well. Otherwise, we will lag behind. And since we are in the era of innovation, that is also part of today's topic, I would say that innovation is not truly innovation unless patients have access to clinical trials. Thank you. Thank you very much. And I think that there's a video. Yes, let's watch the video.
That forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope.
So we move on to the next speaker, Mr. Andonopoulos. He's from AstraZeneca. Hello, good morning from me as well. I would like to thank Fairlife and Mrs. Patelli for this invitation. It's a great honor, and I'd like to congratulate everybody, Orestis, Thamaida, and all the colleagues who have contributed, because there's no longer a taboo when it comes to lung cancer. I will begin differently. I would say let's not have any clinical trials in Greece. Let's not do anything. Let's try the stage 3, 4 to bring it here, because a 5-year overall survival from this point will go there to this other point, and everything that we have discussed today will become a reality if we just realize this. However, clinical studies, our knowledge, the intention of clinical studies is something that we need to have. It's necessary, so that should be our goal. Today, we also heard, and this is a given, about collaboration. So, in order for us to win this fight against lung cancer, we need to work together, and we need to work together on all levels. An initiative which started at a global level in AstraZeneca, and this has to do with Lung Alliance Ambition, I correct myself. This has to do with this underlying logic, i.e. all stakeholders, everybody working behind the pillars related to timely diagnosis and finding a new therapy, but also quality of care and people experiencing cancer. Well, this is something that the pharma industry needs to work on. It needs to focus more on, and this is the only way forward, the only way to win this battle. In Greece, we help, we are partners, and I'm talking about AstraZeneca Greece in collaboration, as I mentioned before, with all the stakeholders in order for us to win this wager. So before we heard about clinical studies it is obvious that the pharma industry will always be on the side of timely diagnosis when it comes to innovation. So we would like the state to help us deal with all the problems, overcome all the problems, so that Greece can become part of what's happening in the rest of the world. Mr. Philippou talked about it earlier. He also talked in the first session about screening. So we need to look at clinical research, not just treatment. And together with ITER, we are creating a project called Thorax. It's a model project. It has to do with finding random nodules, detecting nodules. And I encourage all pharma industries to try to work on this and use AI in order for us to take stock of what's happening in the rest of the world as well. So finally, I would like to say that if Christos's word did not energize you, and George's words, because they actually spoke from the heart and told you their life story, let us not forget that today there's a great opportunity when it comes to lung cancer. There's a great opportunity for us to win this battle against lung cancer. And as Professor Topak said this morning, it's up to us. Each of us, from our own vantage point, can work, but we can also work together in order to do something that seemed impossible some years ago, so we can have cure of lung cancer. This is something that is in sight. Thank you very much. So I'll now give the floor to the next speaker from Amgen, Mr. Periklis Giovas.
Καλησπέρα σε όλους.
Hello all. I feel that this day is very important because new data and new evidence has come to light. I am fortunate enough to have ROS1. Therefore, I am on targeted treatment and I'm a survivor. I'm very moved, please forgive me, but I'm grateful to Corina and to Fair Life, the organization she has successfully set up that brings to surface and highlights a serious topic such as cancer. Thank you very much.
Καλησπέρα και από μένα. Ευχαριστώ πολύ.
Thank you. Thank you for inviting me. So in the next 2 minutes, I will share 2 slides and try to share with you as briefly as possible, some evidence that showcase a successful lung cancer case. 1 out of 8 patients with non-small cell lung cancer has KRAS mutation. What is KRAS mutation? So I will try to walk you through 4 decades. In 1992, the oncogenes KRAS are discovered. What are they? They are mutated oncogenes that codify a protein. This protein talks to cancer cells and shows them how to proliferate. But the problem is that this protein castle had not been conquered for many years. We were unable to find a way in this castle. It took us 31 years of research. Like Mr. Poulidis said, we found this crypto-pocket, this therapeutic solution. And then the marathon became a sprint. So we find this way in, this innovative approach that has less side effects than chemo. And in 2013, you can see the timeline on screen, we found a way to silence the messenger and thus alter its effect. In 2018, preclinical trials began, and in 2019, phase 1 clinical trials began. And Ms. Linardo, who is here, was one of the pioneers in this field of research. So there was the fast track designation that followed, and 2 years afterwards, the FDA provided authorization, and then the EMA also followed suit. So this is a new therapeutic option and solution available to patients. There are other therapeutic options that are being examined at the moment by other companies. In closing, I would like to say that clinical research has taken huge leaps forward in lung cancer, but let's never forget what has been said times and times again today. For us to capitalize on this gain, we must take careful steps and ensure access to biomarkers and reimbursement for relevant tests so that our patients have access to the most appropriate tailored treatment. Thank you.
BMS Greece, Mrs. Zefi Vlachopioti, Market Access Lead, Greece and Cyprus. You have the floor. Hello, good afternoon, ladies and gentlemen. Congratulations on this wonderful event, and thank you for allowing me to participate in this dialogue on the role that the pharma industry can play in clinical research. Let us move on to the next slide. Perfect. In BMS, we want to change the lives of the people making use of science. This is why we are committed to clinical research, because clinical research has the strength not just to change patients' lives, but to transform them. So at a global level, only in 2020, we invested over $11 billion in R&D, and there are over 50 molecules in over 31 therapeutic categories that are under investigation right now. In Greece, where we have been present for over 60 consecutive years, we have invested 10 million euro in the last 5 years in clinical research. And as we speak, there are 40 clinical studies underway in which we have the participation of over 1,000 patients. So most of these clinical studies are for cancer. As you can see, 19 oncology, 14 hematology, and there are also 5 in immunology and 1 cardiovascular disease. So our investment is complemented and our footprint is complemented through actions and initiatives that have to do with the healthcare policy. And the main aim is to improve access to quality healthcare treatment, and we want this to be without obstacle. And we are one of the founding members of the platform in order to improve quality. All Can Greece. This is coordinated by ELOC, the Hellenic Cancer Federation, together with the Institute for the Economics of Health. We have undertaken 2 initiatives regarding cancer. One has to do with the National Fund for Cancer, the National Cancer Fund. So we're talking about co-financing of all types of cancer, from prevention to cure, through the use of special taxes on harmful products, on products that may cause cancer and are hazardous to one's health. Another initiative has got to do with access to biomarkers. More specifically, this has to do with the creation of a reimbursement scheme for biomarkers in order for us to deal with this issue once and for all, i.e. having access to biomarkers for all patients. Another initiative that I will mention is Blood and Beyond. This has to do with the creation of recommendations through an experts committee, which is coordinated by the Institute for Healthcare Policy, the main aim being to have optimal blood management in Greece. We know that a lot of people have to undergo transfusions, and many of these people also have cancer. So these recommendations were recently discussed at a special meeting of the Social Affairs Committee in the Greek Parliament. So similar initiatives are as far as awareness raising is concerned. So we're talking about campaigns regarding BMS. For example, we had one campaign for skin cancer, one for lung cancer, one for blood donation, but also providing support to patients, organizations. And I'd like to say that in 2021, BMS contributed 150,000 euro to such patient organizations. Now, lung cancer, the awareness campaign, this has just started, and I'd like to thank Fairlife for the support they've provided and for the fact that this was carried out under their auspices. So, by way of conclusion, let me come back to clinical research. So let me come full circle, and the question is, what are the possibilities and what are the prospects for further promoting clinical research in Greece, but also how can we achieve this? How can we do something good? So can we attract more investment? The answer is yes. It's a resounding yes. In Europe right now, on an annual basis, around 36 billion euro is spent on R&D. In Greece, only 100 million of this is used. So if we manage to achieve our national goal, which is to converge to the EU mean, we can go from 100 million euro to 500 million on an annual basis. So this will directly benefit the health of the patients, but we will have a bigger budget for hospitals because 20% of the amount is given to the hospitals conducting the clinical studies. So the question is, can we do something extra in order to make Greece more attractive for clinical research? How can we attract more R&D investments? Well, the answer again is affirmative, and these are the 4 simple steps that we can do to achieve this, that we can make. First of all, we need additional incentives for companies so that they can invest in R&D in Greece. So tax incentives, or these can be the investment clawback measure, for example. This was a very good measure because R&D investments can be offset against the clawback paid by the companies, and this is a measure that many multinational companies cannot make use of. Now, simplification of procedures and operation of a special office, either in the hospitals or the Ministry of Health. Something similar was done by Denmark in 2012, and now they are 3rd in Europe in attracting R&D investment. What else can we do? We can facilitate participation of patients. This was mentioned previously through a web page, for example, where we will have all the information on clinical studies conducted in Greece. And then it would be easier for the patients to see which centers are conducting which clinical trials in which they could possibly participate. And this can be done through awareness campaigns as well. Finally, we have staff training of hospitals in order to speed up procedures. This would greatly help attract R&D investments. Thank you very much.
Thank you. And Mr. Stathopoulos from Janssen. Dear friends and colleagues, it is both a pleasure and an honor to be here with you today. I've spent at least 20 years in oncology and lung cancer in particular, and it is with pleasure that I see familiar faces. We all know each other very well, and this is an achievement, and it is very important to come together and meet each other. So, disclosures. So, just a snapshot of what Johnson & Johnson Janssen means. In pharma, underway. There are more than 50 molecules in the pipeline in phase 1 and 2. There are more than 40 in phase 3, and there are 10 more in the registration process, a total of 107 new pharmaceuticals that are in the pipeline. Also, Janssen, as you know, is a leader in hematologic malignancies. It has novel regimens in leukemia, multiple myeloma, and its legacy is well known with respect to prostate cancer and urothelial cancer, but the most intriguing cancer of all is lung cancer, which is what brought us here today. I will not talk about the epidemiology. We are all familiar with relevant data. I will, however, say that we can make a difference with respect to novelties that we may offer our patients. At the moment, in this personalized medicine field, we have targeted treatments available to Greek patients. These target in particular EGFR exon 20 insertion mutations. This is a very small group of patients, but each and every patient matters. We're here to meet unmet medical needs. Is that enough? Clearly not. What we all want is to have treatments available as first-line treatments. Therefore, we must combine treatments, targeted treatments and chemo, and also target the most common mutations in the wider EGFR spectrum through combined treatments. This is a shared vision, and relevant clinical studies are underway. Like other colleagues said earlier, the biology of this disease is that complex that all we want to do is to be able to take an early lead. This is the only way to increase survival, just like Mr. Antonopoulos said. And this is something we can achieve through clinical studies for the benefit of Greek patients. Currently, there are 18 clinical studies underway in Greece. Some of them are in oncology and others in hematology. And we commit to having more clinical studies in lung cancer in particular. In closing, I need to say that we need to address several challenges together. And these challenges not only have to do with clinical studies, but with innovation in general. Ms. Vlachopiotti, mentioned this as well. Let's simplify the applicable regulatory framework. Let's speak the same language. We still try to address legal issues. We need to train administrative staff. I'm talking about governors, deputy governors. Will they be managers? When will that happen? We want to be able to talk with them and share an understanding. Ms. Linardo mentioned this earlier. Also, there are some cancer hospitals that lack clinical study offices within them. As to staffing, unless we properly train these people, our associates, how will we be able to take the next step? So these are the basics, the pure basics, the fundamentals. We're trying to set up the framework, but we're not there yet. And also, Mr. Suliotis, we've had several discussions about this over time. E-prescription, therapeutic protocols, it's not that hard. Ms. Mitro walked us through the framework earlier. Let's find a way to make this framework a framework based on process management. And now let's talk about the patients, because we serve patients. Like Mr. Poulimenos, an excellent friend and an esteemed colleague said earlier, We're trying to see whether something is updated or not. So we must have a National Clinical Studies Office agency. How can it be that this has not happened yet? We need to have up-to-date information not only today, but also tomorrow and for the day after. Within 2 years, starting from scratch, we came to the point where we're all today in a single room. So we need to voice a single message. And this message has to do with prioritization. Preparing lists is not enough. Prioritizing is important. Last but not least, biomarkers. We're still some years behind. NGS could actually provide us with all the information needed in lung cancer. We need to offset investments. We look at each other and try to come up with solutions. Let's talk to each other. Let's see how will we be able to have a return on investment. And last but not least, with respect to health rebate. There's 4.1 billion that is subject to rebate. And 6 out of 10 patients essentially get early access and other benefits, but we must see whether innovation is something that concerns all of us or only pharma. So, it takes 3 to tango here. Pharma, the physician, no matter where they are, they may be an NHS doctor, an academic, whatever. And there's the state. That's the third pillar. And all of these pillars together must try for the day after, because this is the critical path that we must follow to the next day. Thank you.
Thank you very much. And now, just before the conclusions, I will ask Mr. Veve, Mr. Souliotis, our commentators, to give us a very quick comment, a 1-minute comment each, if possible. So let's start from Mr. Vedes, President of the Greek Patient Association. Mr. Vedes, you have the floor. Let me thank you for the invitation. Let me congratulate Mrs. Patelli on this wonderful event and this roundtable. Fairlife is an august member of the Greek Patient Association, and we would like to make the subject of clinical studies something in which we can contribute as patient association. So the Greek Patient Association is participating in the working group by Mr. Kotsiopoulos, and it's a great opportunity. So we have all stakeholders involved. So I believe that through this group we can do a lot of things. In the 11th conference we held some days ago, there was a dedicated panel on clinical studies, and together with Mr. Philippou, we agreed on the need for a campaign, an awareness campaign, to address to the citizens and the patients, but also to engage in closer collaboration with EOF, the Hellenic Drug Organization. I'd like to conclude by saying things that were already mentioned by the previous speakers. Patients nowadays play an institutional role. We're talking about recognition of priorities regarding research, the needs. They also participate in clinical protocol design. They also are engaged in IRBs, in the ethics committees in accordance with the European regulation. So we have an active role. And in the Patient Summit, which is organized every year by the Greek Patient Association, we had a dedicated part for training regarding clinical studies. So then we can debunk the myths that were presented today. Thank you very much for your attention.
I think that everything has been said about clinical studies. I was personally involved as a member of the National Ethics Committee back in 2012-2013, and we all remember what that period looked like. Anyhow, I experienced a doubling of our workload at the time. So I have good news and bad news. The good news is that since we were able to double our workload at the time when Greece was on the verge of collapse, just imagine what we can now do. The facilities, the infrastructure that are available in Greece, the interest is huge. So I think that we have tied ourselves to this huge burden that is keeping us down. Truth be told, clinical studies will allow us to take a huge step forward. Also, we're no longer alone. There are many other countries that are very competitive, that are very dynamic, and whose legal framework is more attractive. So, we, over time, were familiar to study being subject to costs and cost restraints and having to adapt. But now we must try and make efforts to reverse this. Let's not view pharmaceutical spending as costs, because this is a suffocating setting. Perhaps we should start talking about fiscal relaxation and also about the notorious multiplier. For every single dollar invested, there is a return of $3 for the GDP. So perhaps we should prioritize this investment as part of the health policy. Let's just speed things up. Let's avoid institutional burdens. We do have problems. Let's not create more problems. I want to be optimistic, and my optimism stems from the fact that we can. We've proved as much. Again, I refer you to the 2012-2013 period. Things have changed to the better. Let's just give it a try. Thank you. Thank you very much. So we will welcome online Andrew Kipek. Andrew, are you here?
Thank you so much to the organizers of Fairlife for inviting me to comment on these talks today. I found it really heartening that we heard firsthand from several patients today through sharing their own experiences, the impact and importance of clinical trials and clinical lung cancer research. And, it's thanks to these advances that people are not just living, but they're also thriving after lung cancer diagnosis, and we really saw that. And, so I think trials should be considered part of standard of care for patients. And, it can be a way for them to access some of the newest therapeutic options. And for some patients, might be the best options for them. But it was demonstrated how important trials are, I think, today. But people also alluded to several things that I think are needed to make sure trials are available to all that I just want to expand on really quickly here at the end. First, I think we need patient awareness and education about trial opportunities. We heard firsthand from some of the patient advocacy groups and the amazing work they've done to spread word patient to patient, but a role can also be played by sponsors, the medical system, and people involved in research. And we need to ensure that we do community outreach to make sure we reach all patient populations to make them aware of opportunities. We need inclusive trial design from researchers and sponsors, making sure our inclusion-exclusion criteria allow all types of patients to join. Also that our trial designs are supportive of patients joining, that there's support for things like cost, travel, and also that how we select sites for research or utilize some of the innovative trial designs we heard some of the other speakers talk about, such as decentralized trials to bring opportunities closer to patients. I think we also need resources and staff support for running trials. I mean, we've all heard systems and staff have a lot on their plate to provide care, and they've been overworked, especially since the pandemic. And we want to make sure that we invest from the top level in the resources that we can actually do to run trials and support the staff and make sure they're available. And lastly, we heard several speakers, I think, touch on the need for high-level, like government support and supportive regulatory frameworks to speed up approval, but also opening clinical trials, and also that we need research funding so that we can continue to do more research and make more opportunities available to patients. So in conclusion, I have a lot of great hope for the future with what's going on in lung cancer and all the research advances that we've seen, but we need to make sure that we support awareness and ensure that all patients have access to trials. And so we still have work to do. And I want to thank you very much for your time.
Thank you very much. Amy Moore, για το κλείσιμο, λίγο πριν...
So, just before we call it a day, and conclusions, Amy?
To be with you all today. It's been a very informative session, and I'd like to echo much of what my good friend and colleague, Dr. Kupek, just said. At Longevity Foundation, which is a US-based lung cancer advocacy organization, we think about many of the issues that were raised today. I heard reference to issues around workforce and ensuring that there is a trained generation of younger clinicians who are willing and able to roll out new clinical trials. So we need to make sure that that remains part of the care continuum. We heard the challenges around policy issues and as Dr. Kupek said, the regulatory infrastructure necessary for allowing greater rollout of clinical trials throughout Greece. I think we heard the same issues and concerns around funding. We need to make sure that there is a continuous flow of funding to support research and clinical trials throughout the region. We heard about some of the barriers to clinical trial accrual, including the consent process, and that's been an area where Longevity has been recently very focused, is on making, for example, informed consent forms easier to read, more patient-friendly, if you will. And my colleague, Dr. Belinda King-Kalamanis, just presented at the recent World Conference on Lung Cancer in Vienna on work that we are doing to make these informed consents more accessible and more readable for patients. So there is a continuum of work that Longevity is focused on, from education and awareness through sponsoring and being engaged in research to addressing the policy and regulatory issues. And we are ready to stand by as partners to all of you in Greece and our international lung cancer community as we seek to deliver solutions to some of the challenges that have been raised today. So we wish you well. This is the month of lung cancer awareness, and we thank you for your efforts to increase awareness of lung cancer. And please look out for next year. We have our International Lung Cancer Survivorship Conference, and we hope all of you will be participating in that, where we share the latest updates on lung cancer research and clinical care. So thank you for your time and for all of the work that you shared today.
Thank you very much. Αυτό κάνει Fairlife. Κάνει ό,τι μπορεί.
This is exactly what Fairlife is doing. It does everything it can 24/7 for awareness raising, and it's very important because I have worked in parallel with Fairlife. I've seen it grow. I've seen it open its arms to people who need care, with whatever that may mean and whatever this may entail. And now I'll give the floor to Mrs. Chatziandreou, who will give us the closing address. Thank you very much. Elena, thank you personally and on behalf of Fairlife for everything you've done. This was a wonderful one-day event. Dear friends, I will not resist the temptation, and I will just quickly give you two conclusions. One, that this was a very optimistic event. We had science and we had emotions, we had feelings, and in the end we had optimism. So I would like to thank all of you, the participants, the speakers, the audience, those who were here physically, the sponsors, our supporters, those who joined us via internet. And it would be impossible without the help of the sponsors and without the incredible group, which is full of energy, and the dedicated team of Fairlife. I would like to stress before closing that we are committed, and our commitment is unwavering. Atalantevti in Greek. I know I used the wrong word in Greek. It's because I'm tired. So we have unwavering strength, commitment. We have been persistent and we show consistency in what we do. We're very decisive in our work. So we are determined to continue what we do. And what I realized today is that Fairlife may become the catalyst, and it will bring all of you and all stakeholders around the same table in order for us to achieve faster and more effectively what we all want, i.e., we don't want cancer to take your breath away, but we want life to take our breath away. We'd like to wish you happy holidays, health, creativity, and see you again here next year. And I'm sure that we will have made a lot of steps forward, which we will be talking about next year. And that is what I had to say. Thank you on behalf of Fairlife, and have a nice evening.
Και τι θα μπορούσε να γίνει διαφορετικά για την επόμενη ή τον επόμενο Σάιμον. Ο Σάιμον, μετά από μια κακή εκτίμηση του παθολόγου για το βήχα που είχε τον Ιούλιο του 2019, πήρε αρχικά αντιβίωση και σε ένα μήνα μετά διαγνώστηκε με αδενοκαρκίνωμα. Μετά από μια σειρά πολλαπλών εξετάσεων και ασάφειας για τη σταδιοποίηση της νόσου, ο Σάιμον ακολούθησε χημειοθεραπεία και νοσοθεραπεία που δυστυχώς δεν έφερε κάποιο αποτέλεσμα. Η νόσος προχωρούσε, είχαμε μεταστάσεις, παρενέργειες, νοσηλίες και μεταγγίσεις. Από κάθε γωνιά της γης, από τη χώρα μας, την Αγγλία, τη Γερμανία, την Αμερική, μας τόνισαν το Γενάρη του 20 ότι η μοναδική προοπτική θα ήταν να λάβει άμεσα μια νέα καινοτόμο θεραπεία μέσω κλινικής μελέτης, και αυτό θα ήταν ίσως η μοναδική δυνατότητα να ζήσει περισσότερο, να αλλάξει την πορεία της νόσου και θα του έδινε ένα παράθυρο και μια ελπίδα. Και έτσι ξεκίνησε ένας πραγματικά μαραθώνιος για να πάρει το φάρμακο. Η κλινική μελέτη δυστυχώς δεν έτρεχε στην Ελλάδα. Στην Ευρώπη είχε κλείσει στα κέντρα που έτρεχε και δεν καταφέραμε δυστυχώς να ταξιδέψουμε στην Αμερική λόγω της πανδημίας τον Απρίλιο του 20. Μετά από δεκάδες ακτινοβολίες, νέες μεταστάσεις, πήραμε ειδική άδεια από την Αμερικανική κυβέρνηση να ταξιδέψουμε μέσω κορονοϊού τον Ιούνιο, ενώ ο Σάιμον ήδη νοσηλευόταν στο Μετροπόλιταν και γίνονταν πραγματικά υπεράνθρωπες προσπάθειες να τα καταφέρει. Εμείς συνεχίζαμε να πιέζουμε προς κάθε εμπλεκόμενο φορέα, γιατί ήταν ξεκάθαρο ότι η ζωή του κρεμόταν σε μια κλωστή, και να ζητάμε να λάβει την αγωγή στην Ελλάδα, γιατί η χώρα μας έχει εξαιρετικούς γιατρούς και την υποδομή να παρακολουθήσει τον ασθενή. Δυστυχώς όμως διαπιστώσαμε ότι καινοτόμα φάρμακα, ενώ βρίσκονται σε προχωρημένο στάδιο κλινικών δοκιμών στο εξωτερικό, παραμένουν απροσπέλαστα για ασθενείς στην Ελλάδα, τόσο διότι ελάχιστες κλινικές μελέτες διενεργούνται στη χώρα μας, σκεφτείτε ότι λιγότερες από 30 υπάρχουν αυτή τη στιγμή για τον καρκίνο του πνεύμονα, όσο και λόγω γραφειοκρατίας και του νομοθετικού πλαισίου που αποκλείει την εναλλακτική δυνατότητα πρώιμης πρόσβασης σε φάρμακα που μπορεί να είναι και η μοναδική λύση για τον ασθενή. Το πειραματικό φάρμακο που έτρεχε μόνο μέσω κλινικής μελέτης δεν παραχωρήθηκε στο Σάιμον. Και έτσι στις 4 Οκτώου έφυγε από τη ζωή, αφήνοντας πίσω του ένα τεράστιο και ανεκπλήρωτο κενό. Αυτό το βίαμα μας έδωσε την όθηση για να δημιουργήσουμε τη Fairlife, φροντίδα και πρόληψη για τον καρκίνο του πνεύμονα, με στόχο να δημιουργήσουμε τις υποδομές πληροφόρησης για συμπολίτες μας που αντιμετωπίζουν αντίστοιχες συνθήκες και να βοηθήσουμε όπως και όσο μπορούμε για να μην βρεθούν στη δική μας θέση άλλοι άνθρωποι, και παράλληλα να ενημερώνουμε ότι η έγκαιρη διάγνωση και η πρόληψη σώζει ζωές. Εάν και η συζήτησή μας αφορά τις κλινικές μελέτες, θα ήθελα να πω ότι εάν ο Σάιμον γνώριζε ότι υπάρχει η αξονική τομογραφία χαμηλής δόσης για το θώρακα και είχε προχωρήσει σε αυτή την εξέταση ως πρώην καπνιστής σε τακτά χρονικά διαστήματα, αυτό θα είχε σώσει τη ζωή του και θα ήταν σήμερα μαζί μας, γιατί θα είχε προλάβει τον καρκίνο του πολύ νωρίτερα. Εμείς στη Fairlife θεωρούμε πολύ σημαντικό ο ασθενής να είναι ενημερωμένος, να γνωρίζει την πληροφορία και επίσης να έχει ίσες ευκαιρίες. Τι είναι όμως οι κλινικές μελέτες που ίσως κάποιοι από τους ακροατές μας δεν γνωρίζουν, είναι ασφαλείς, γιατί είναι τόσο σημαντικές? Θα πρέπει να πω ότι κάθε θεραπεία που έχουμε σήμερα στα χέρια μας έχει εγκριθεί μέσα από κλινικές μελέτες. Οι κλινικές μελέτες είναι αυτές που μας δίνουν όχι μόνο τις νέες θεραπείες, αλλά και όλες τις πληροφορίες για την πρόληψη, διάγνωση και τη βαθύτερη κατανόηση της νόσου. Και αυτό είναι πάρα πολύ σημαντικό. Πολλές φορές μπορεί να αποτελούν και τη μοναδική σανίδα σωτηρίας και ελπίδας, γιατί δίνουν πρόσβαση σε νέες θεραπείες πολύ νωρίτερα από τη χρονική στιγμή που τα φάρμακα είναι διαθέσιμα. Εάν ο Σάιμον είχε λάβει το πειραματικό φάρμακο, είμαι απόλυτα πεπισμένη ότι θα ήταν μαζί μας, γιατί είχε τρομερή θέληση να ζήσει, να νικήσει τον καρκίνο του και να είναι δίπλα στην οικογένειά του σήμερα. Επίσης, είναι καλό να γνωρίζουμε ότι οι κλινικές μελέτες μπορεί να μην εξασφαλίζουν την καλύτερη έκβαση για τον κάθε συμμετέχοντα, αλλά σίγουρα εξασφαλίζουν την ασφάλεια του κάθε ασθενούς με απόλυτη προτεραιότητα και πολύ αυστηρά κριτήρια ελέγχου. Δυστυχώς, οι ασθενείς χάνουν την ευκαιρία να συμμετέχουν σε κλινικές μελέτες γιατί το αγνοούν ή γιατί δεν ενημερώθηκαν για αυτή την επιλογή. Σκεφτείτε ότι μόνο το 5% των ασθενών συμμετέχει σε κλινικές μελέτες, ποσοστό πολύ χαμηλό συγκριτικά με το μεγάλο ποσοστό των ασθενών που για αυτούς δεν υπάρχει μια εξατομικευμένη θεραπεία. Κάτι δε το οποίο είναι πάρα πολύ βασικό είναι ότι οι κλινικές μελέτες στην Ελλάδα είναι δωρεάν και για τον ασθενή και δεν επιβαρύνουν το σύστημα υγείας. Εν αντιθέσει, αποτελούν οικονομικούς πόρους στο σύστημα υγείας και ιδανικά το ποσό αυτό που εξοικονομείται θα μπορούσε να αξιοποιηθεί για την κάλυψη των αναγκών του ΕΣΥ. Ποιοι είναι όμως οι βασικοί εταίροι μιας κλινικής μελέτης? Πρώτον, είναι το Εθνικό Σύστημα Υγείας. Τα τελευταία χρόνια γίνονται σημαντικά νομοθετικά βήματα στο να ενταχθούν οι διαδικασίες έγκρισης και γενικότερα να διαμορφωθεί ένα πιο φιλικό περιβάλλον για την προσέλκυση κλινικών μελετών στην Ελλάδα. Παρ' όλα αυτά υπάρχει ακόμα πολύς δρόμος, καθώς η χώρα μας παραμένει αρκετά πίσω στον αριθμό των κλινικών μελετών, τόσο φάσης 3, αλλά και ιδιαίτερα πρώιμων φάσεων 1 και 2. Δεν αρκεί μόνο η πολιτική βούληση, καθώς και μεμονωμένες νομοθετικές ρυθμίσεις, απαιτείται ένας πολύ καλός συντονισμός μεταξύ όλων των εμπλεκόμενων φορέων, Υπουργείο, ΕΟΦ, νοσοκομείων, επιτροπών έγκρισης, ώστε να αποφεύγονται καθυστερήσεις και να έρονται γραφειοκρατικές αγκυλώσεις. Δεύτερος εταίρος είναι οι φαρμακευτικές εταιρείες. Είναι πολύ σημαντικό για τις θυγατρικές των πολυεθνικών φαρμακευτικών να συνεχίσουν να προσπαθούν να προσελκύουν στην Ελλάδα τα κλινικά τους προγράμματα, καθώς έχουμε πολύ έμπειρους ερευνητές και αξιόλογα επιστημονικά κέντρα, αλλά οφείλουν να βοηθήσουν και τους Έλληνες ασθενείς να έχουν πρόσβαση σε καινοτόμα φάρμακα και να έχουν ίσες ευκαιρίες με τους πολίτες άλλων χωρών. Τρίτος σημαντικός εταίρος είναι οι γιατροί. Στην Ελλάδα όλοι γνωρίζουμε ότι έχουμε από τους καλύτερους γιατρούς παγκοσμίως και πολλοί από αυτούς είναι και εξαιρετικοί ερευνητές με εμπειρία και σημαντική συνεισφορά σε πολλές κλινικές μελέτες. Είναι σημαντικό να είναι για τους γιατρούς μας προτεραιότητα η ενημέρωση των ασθενών και η παραπομπή τους σε κέντρα κλινικών μελετών εφόσον αυτό κρίνεται απαραίτητο. Κατά την άποψή μου, ο ασθενής πρέπει να γνωρίζει από την πρώτη επαφή που έχει με τον ογκολόγο του την πιθανότητα να συμμετέχει σε μια κλινική μελέτη, γιατί αυτό του δημιουργεί την ελπίδα και την εντύπωση ότι έχει μπροστά του πολλές θεραπευτικές επιλογές. Και ξέρετε πολύ καλά ότι η ψυχολογία του ασθενή είναι κάτι πάρα πολύ σημαντικό και τον βοηθάει πολύ με την νόσο. Επίσης, έχει σημασία η διαρκής επανεκπαίδευση του προσωπικού, η επένδυση σε διεθνείς συνεργασίες και δίκτυα κέντρων αριστείας και σαφώς η εστίαση στην πιστοποίηση της ποιότητας των επιστημονικών κέντρων. Από την πλευρά μας, οι φορείς των ασθενών οφείλουμε να δουλέψουμε ώστε οι ασθενείς να έχουν πληρέστερη ενημέρωση για την αξία των κλινικών μελετών και για την ευκαιρία που τους δίνεται να αποκτήσουν πρόσβαση σε καινοτόμες θεραπείες που μπορεί να αποτελεί τη μοναδική ενδεδειγμένη λύση, όπως ήταν και για την περίπτωση του δικού μου συζύγου που δυστυχώς δεν του δόθηκε η ευκαιρία να λάβει το πειραματικό φάρμακο. Κλείνοντας, θα ήθελα να ευχηθώ να υπάρχει σύντομα για κάθε καρκίνο ένα φάρμακο, για κάθε ασθενή μια κλινική μελέτη, μια ελπίδα και τα επόμενα χρόνια ο καρκίνος να είναι χρόνια νόσος. Μπορεί ο δικός μου άνθρωπος να μην τα κατάφερε, αλλά εύχομαι η επόμενη και ο επόμενος Σάιμον να τα καταφέρει. Ο ένας για τον άλλον είναι η συνταγή της ζωής.